Deepak ji, please let us know when we are online.
Yes, sir. Just a minute, sir.
Okay. Sir, should we start now, sir?
Yes, sir. Go ahead, sir.
Itender first introduce the speaker.
Yes, sir. Okay. Good morning, sir. Welcome to the ENT update 2020, second day. And it is my honorable to be a moderator for this session. So the program for this morning session is as follows. Salivary gland tumors, then evaluation of dysphagia, head and neck reconstruction, neck dissection, and then CSF rhinorrhea. So today, at present, Dr. Vaibhav Saini is going to present about the salivary gland tumors. Sir, please start the proceedings.
Okay, very good morning to all. At the onset, I would really like to thank Dr. Ravi Meher sir, Rathod sir, Ishwar Singh sir, Pasar to invite me to this August gathering. And this is a very vast topic. I would really breeze through the presentation, and I will mainly focus on the things which are very important for the postgraduate examination PG students. So, as we all know, we have three major salivary glands: parotid, submandibular, and sublingual. Largest one is parotid. We know it is located in the retromandibular fossa with these relations, and this gland is divided into deep and superficial lobe through the facial-venous plane of pate. Into 80% lies in the superficial lobe and 20% in the deep lobe. And there is an accessory parotid gland which is located, which is usually present in the 20% of the cases, which is lying over the masseter muscle. So, pretty important question and very frequently asked: why the parotid swellings are painful? So, the parotid glands lie between the two layers of superficial and deep layer of the cervical fascia, which is attached to the stylomandibular ligaments. So, the swelling which occurs in the closed compartment causes more pressure symptoms and more painful. And the parotid is drained by Stensen's duct at around the second maxillary molar. One more important thing: facial nerve traverses through the parotid gland, but it doesn't supply any part of the parotid gland. It is a tricky question which is usually often asked in the exams. Histologically, there are acini which drains into the striated duct, which drains into intercalated duct, and these all form into main salivary gland duct. Brief about submandibular anatomy: it is a J-shaped gland divided into the superficial and the deep part, which is divided by the mylohyoid muscle. Here, three important things which you have to see. This is the cut end of the mylohyoid muscles. This is J-shaped gland, and the lingual nerve is looping around the submandibular duct. Here you could see the submandibular duct opening into the floor of mouth, and this hypoglossal nerve, it goes into the floor of the submandibular gland. So these nerves are quite important to identify while we're removing the submandibular gland, and this is the submandibular ganglion. This is the important structure also while we so these are these are the same thing: lingual nerve, very closely related to the deep part of the gland, and this is the hypoglossal nerve running in the floor of the mouth. And this is the sublingual gland. Sublingual glands are very small gland, as the name suggests, located beneath the tongue. The duct of Renivus, it opens as summit of the sublingual papilla, and the duct of Bartholin's open the submandibular ducts. Some salivary gland tumors, though 80 to 90% of the gland tumors are located in the parotid glands. Most of these are benign. Pleomorphic adenoma is the most common benign tumor, Vardin is the second most common. Mucoepidermoid carcinoma is the most common malignancy. Carcinoma ex pleomorphic adenoma 5 to 18%, and adenocystic carcinoma and polymorphous low-grade adenomas are rare in parotid. Submandibular gland tumors are much less common than in parotid. Most of them are benign, and if malignancy, the adenoid cystic carcinoma is most common. So in parotid, mucoepidermoid is the most common malignancy. In submandibular, adenoid cystic is the most common malignancy. These are the list of benign tumors located in the salivary glands. I will not go into the details. Similarly, the malignant tumors by the WHO in 2017. So, pleomorphic adenomas. Why the name pleomorphic? Because it has a morphological diversity. You could see that it also has epithelial cells, myoepithelial cells, mucoid, sometimes cartilage, pseudo. So histologically, it has great morphological diversity. So that is why we call it as a pleomorphic adenoma. And the second most important thing is why it has a tendency to recur after surgery. So this is the most important question usually we ask in postgraduate examination. Very important. Usually this tumor is encapsulated with small dehiscence in the tumor capsule, and through this dehiscence, small millimeter of tumor get into the normal parotid. So if we do an enucleation, we'll remove the tumor through the capsule, and will leave behind small tumor deposits in the normal parotid tissue, which will cause a recurrence. So if an enucleation which was done earlier, it has around 20 to 40% of the recurrence chances. And facial nerve is usually never involved in the benign cases. Warden's tumor. It has another name, adenolymphoma of parotid, depending upon the histology. It has few peculiar points which are to be noted by PG students. It occurs usually exclusive the tail of parotids. Male-female ratio is very different, 7:1. Usually occurs in smokers. It does not have a pre-malignant potential. One more thing, it has a cystic changes, and sometimes it presents an inflammatory swelling, and 10% are bilateral. So simple excision via partial parotid superficial parotidectomy is the answer, and in cases where very elderly males, we can follow up these tumor also. So typical picture with abundant adenoid, lymphoid, and epithelial components with papillary projection is the histological picture. Mucoepidermoid carcinoma is most commonly salivary gland, as we have discussed. Usually, this presents as asymptomatic swelling in the parotid region, and if the tumor is high grade, if the high grade tumor, it presents at the typical malignant picture. So as we have already said, low grade tumor they mostly behave like they are a benign tumor basically, and high grade tumor are real malignant tumor. 5-year survival rate of low grade tumors is very excellent. So most favorable tumor superficial parotidectomy is sufficient, and more radical surgery is needed for advanced disease. Adenoid cystic carcinoma, second most common malignant tumor. Most important feature, I'll just focus on the main picture things. It has a tendency of the perineural spread, which is usually asked. And second most question is, what is the survival rate? So adenoid cystic carcinoma is an indolent kind of disease. The survival rate is pretty good, but post-op radiation is mandatory in this, and it does not goes through lymph nodes, so prophylactic nebulizer is usually not required, and skip lesions. So frozen section, if the facial nerve is involved during the gross facial nerve is involvement, so we can go for a frozen section during surgery. Carcinoma, explosion adenoma, it gives a typical history. Suppose the patient will typically say the swelling is from the last 15-20 years, and recently swelling has started to increase in size and causing pain also. This is a typical picture of carcinoma exploromorphic adenoma. It occurs in long-standing swelling. So tumor patterns are non-invasive, minimally invasive, and invasive. Treatment is basically, it is an aggressive tumor, so we need an aggressive treatment modality in this. Actinic cell carcinoma, it's also one of the common malignancies. This tumor is usually multifocal or bilateral, encapsulated, lobulated, and slow growing. Polymorphous low-grade adenocarcinoma, it typically present as a swelling in the minor salivary glands on the palate. It is a highly infiltrative, locally growing swelling, which has a very low metastatic potential. Squamous cell carcinoma is very rare. History of previous radiotherapy is usually associated, and it's most commonly associated in parotid region. Salivary duct carcinoma is a very aggressive kind of tumor, usually rare tumor, and it resembles the breast ductal carcinoma. Secondary deposits from different other areas or adjoining areas, for example, malignancy of the pinna, or for example, forehead, lacrimal glands are also present in the parotid glands. How do we evaluate a patient with parotid or salivary gland malignancy? The most important history, as we have already discussed, the duration, rate of growth, and presence of pain, onset of facial palsy, cervical lymphadenopathy, and exposure to radiation. We'll examine the mass very importantly. Bimanual palpation, size of the mass, mobility of this mass will give you a exact idea, or make, I would say, correct idea that swelling, especially in parotid, that swelling, if the swelling is limited to the superficial lobe, swelling will be highly mobile. And if it is going through this retromandibular area into the deep lobe, swelling will be slightly difficult to move. So it will give you a good idea that swelling in treatment. And bimanual palpation is very important in submandibular gland. USG is the first tool of investigation. So it basically, most importantly, differentiates between the extrinsic or the intrinsic neoplasm, so that the swelling located within the parotid or it is outside the parotid. And it also says the malignant features like ill-defined margin, heterogeneous architecture, subcutaneous invasion, and presence of lymph nodal metastasis. So USG is mostly the first line of investigation. If it is, we can add on the FNA into it. So FNAC is the important tool in the diagnosis. It has a minimal morbidity, and if we add USG into it, it also helps in diagnosing a permanent primary tumor, but also aids in diagnosing associated lymph nodal metastasis also. This is an important thing, and is a recent thing. Milan system of reporting a salivary gland cytopathology, like we have a cytopathology diagnosis in the Bethesda system in thyroid. The similar system has been developed, which is known as Milan system, and it is a similar from, it goes from 1 to 6, 1 being non-diagnostic and 6 being malignant. So CT and MRI. Usually they are the personal preferences to go for a CT or MRI, but I would suggest for a PG student, generally if the tumor, if located to the superficial lobe, so we'll go for a CT because it is also a cheaper investigation and readily available also. And if we suspect the tumor is malignant and going into the deep lobe with perineural invasion, we should go for an MRI. So here the MRI is specifically more helpful if we are suspecting the perineal invasion. We can see the foramen ovale here, which is slightly widened as from this side. So it is very important to diagnose and before surgery that patient is having any perineal invasion or not. Grading of the tumor, it is very important in the salivary gland, but sad part of it, grading is only available after the histopathological diagnosis. So beforehand, we don't know the grading about the tumor. So on basis of grading, we cannot usually able to differentiate our treatment. So low grade are adenoid cystic carcinoma, low grade mucoepidermoid carcinoma, and higher grades are high grade mucoepidermoid carcinoma, salivary duct carcinoma, carcinoma exploratory adenoma. The TNM staging is there. I will not go into details. I will just say that T3 tumors more than 4 centimeter with extra parenchymal extension, and T4A are where the facial nerve and other skin and superficial structures are involved. So malignant tumors. So what we need to do in malignant tumors is basically superficial or total parotidectomy or an extended parotidectomy plus minus neck dissection, depending upon the histology and depending on the histology and presence of and absence of nodes in the tumor. So T1, T2 low grade tumors, for example, actinic cell carcinoma, they need a simple parotidectomy with preservation of facial nerve. T1, T2 tumor with high-grade features with adenoid cystic, adenocarcinoma, axillomorphic adenoma, total parotidectomy with preservation of facial nerve, unless it is directly infiltrated. And if the nerve is infiltrated, we have to get a frozen section and cable grafting of the patient, add cable grafting of the nerve, and then and there only. Any T3 or advanced stage tumor, we need a total or extended radical or radical parotidectomy and neck dissection if we have a positive nodal disease. Similarly, frozen section and cable grafting is also there. Similar in the cases of T4 tumors, radical parotidectomy and aggressive surgery is needed. Indication of facial nerve sacrifice. This is a very important question which is asked. So which, as the standard dictum goes, if the patient is having a pre-operative palsy of the facial nerve has to be resected during the surgery and cable grafting of it. And if the pre-operative, the nerve is normal, we will try our best to preserve the nerve during the surgery. Even if we can lose microscopic bits of disease on the tumor, on the nerve, but we should preserve. Basically, it depends. If the squamous cell carcinoma, then we have to definitely resect the tumor. If it is a mucoepidermoid carcinoma, we can slightly small tidbits of tumor can be left on the nerve, but we have to preserve the nerve. Similarly, intraoperative gross invasion, even in cases of presence of normal function, we'll have to resect the nerve. And if the nerve is damaged, immediate cable grafting. Greater auricular nerve is most ideal because it is located in the same site, and otherwise, other alternative with nerve to nerve diameter very good with the facial nerve is a sural nerve. Prognosis: benign salivary gland has a very good prognosis. Recurrence of the treatment after good superficial periodicectomy is less than 1 to 2%, but in cases of enucleation, it rises up to 21 to 35%. Malignant tumors, outcome depends on the stage and the grade. With 10-year survival rate for T2, T1, T2 tumors is quite good, 80 to 90%. Or T4 tumors, it drops down to 33 to 37%. Factors affecting prognosis, as in any other malignancy, T and N stage are most important prognostic factor. Presence of facial nerve palsy and positive surgical margin and perineal invasion and skin invasion. Role of radiotherapy: advanced disease, presence of histopathological adverse prognostic factors, and adjuvant radiotherapy improves local control rate. So these are the factors, these are the conditions where we'll give the posterior stage 3-4 disease, tumor greater than 4 centimeter, extra pericardial spread, positive surgical margins, presence of facial nerve were preserved despite this being, this is very important. If we have left disease adherent to the facial nerve, then it is a clear-cut indication of the post-operative therapy and perineal invasion. It is not integrated in stage 1 and 2 adenoid cystic carcinoma and lower grade mucopolysaccharidosis carcinoma. Primary radiotherapy in patients we can not do surgery or unresectable tumors. Neck dissection, it is quite important. Tumors more than 4 centimeter have a chances of occult metastasis. Then we will do a level 2 to 3. We'll inspect this. If we found any nodes, we can complete the level dissection, or we can definitely do a level 2, 3, 4. High grade histology. Surgical techniques. So first we'll discuss parotid, and then we'll discuss briefly about submandibular anesthesia. Types of parotidectomies. There are n number of types of parotidectomy. Partial superficial. It's a recent concept. Previously, we used to only say as superficial parotidectomy. Partial parotidectomy, when we identify the facial nerve and remove the tumor with a cuff of normal parotid margin. Superficial parotidectomy when we remove entire superficial lobe. Total conservative when we remove the superficial lobe and tumor located in the deep lobe, but we preserve the facial nerve. Radical parotidectomy when we sacrifice the facial nerve also. Extended radical when we remove adjoining areas also. Adjoining part of like pinna or other skin and other things also. Now, there is a new concept, extracapsular dissection. For PG students, I would say that this extracapsular dissection term is not given in Stelmaran. It is there in New Scott Brown. So what is this? Is basically it is a enucleation without identification of the facial nerve, but with the facial nerve monitor. So it is difficult to understand. It is a kind of surgery when we remove the tumor located into the suitable location like parotid tail, very limited. Hello. Mobile lesion into the parotid tail, where we can easily remove the tumor along with slight cuff of the normal parotid tissue, and along with side we use the facial nerve monitor, and we continuously see that we do not injure the nerve. It is called extracapsular dissection. So principles in management of benign salivary lesion. Small adenoma in the tail of parotid, we can go for partial superficial parotidectomy. Large tumor in the superficial lobe, superficial parotidectomy. Deep lobe tumor, total conservative, we have to remove superficial lobe and deep lobe along with the preservation. And parapharyngeal space tumors, we have to do a cervicoparotid approach or transmandibular transcervical approach with or without mandibulotomy. That we will discuss later on. Now, positioning. We all know what the positioning in the parotid tumors: supine, hyperextended, neck turned to the opposite side. This is the incision, which is called modified Taylor incision. Now, there, Dr. Panda from PGI has given a slight modification in the incision where we go slightly. Sorry. Okay. where we can just will not go behind the pinna. We will just come from here and we'll go directly straight line. So it will give a more cosmetically a better scar. Incision and flap, we will have to protect the greater auricular nerve. Flap thickness has to be maintained so that to prevent the phrase syndrome. Anteriorly, we have to see that anteriorly the facial nerve comes more superficial. So anteriorly, while raising the flap, we have to be very conscious of the facial nerve. So it is a partial superficial parotid. If a small tumor, we can see that it is located in the tail of parotid, and here we can do easily. We don't need to resect the upper lobe. We can just resect the parts lower part of the. Yes, sir.
Thank you.
So the tumor localized superficial in the tail, we can very well go with partial superficial parotid. Similarly, here you can see we have just dissected off the lower pole of the parotid or tail of the parotid. Upper branch we did not dissect it. So it has a benefit that chances of injury to the of the zygomatic or temporal branches is very less, as we have not dissected them at all. Superficial parotidectomy is located for the more is there for the more larger lesion located in the superficial, complete entire superficial lobe, as we can see here. Typically at the last tumor.
Hello.
Yes, sir. Indication, it is done in the benign disease of superficial lobe, and when we need to access the deep lobe. Okay. While raising the flap, we have to make ensure the flap is thick, and we have to preserve the greater auricular. Otherwise, the patient will have a hypostasis of the pinna. So, how can we can preserve the greater auricular nerve? There is an anterior branch of the greater auricular nerve which is going over here. We can cut it and we can preserve the posterior branch and retract it posteriorly. So here we can see the similar thing. Now we have to identify later on the posterior belly of the digastric. Here we can identify the posterior belly of digastric. Then we'll start our direct dissection anteriorly. And here we can see the submandibular digastric belly and the facial nerve. So facial nerve usually lies at the level, horizontally at the level of the digastric muscle. So direction of the nerve is anterior, superficial, and inferior. Direction parallel to the we have should dissect in the direction parallel to the nerve, so that we cannot ensure that avoid inadvertent nerve damage. This is very important. It is usually asked in the PG examination. While dissecting on the nerve, there are typical 4 steps of the mosquito fascia. We should insert it, elevate it, open it, and cut it. Insert, elevate, open, and cut. These are the steps are to be repeatedly followed while working on the facial nerve. This is the facial nerve with all the branches you can see. It is going. So most important question which is asked in the PG examination is facial nerve landmarks. Most important is tracheal pointer. We all know it. Facial nerve lies 1 centimeter inferior and medial to the pointer. Posterior belly of digastric, as I've already discussed, it lies in the same horizontal plane as the anterior border of the posterior belly of digastric. Tympanomastoid suture, it is considered the most consistent landmark. Retrograde inferior approach. Lower branch of the facial nerve is invariably lateral to the retromandibular vein or posterior facial vein, the lower pole of parotid. So here we can identify the cervical branch or the lower branches, and then we can trace it upwards. Or retrograde dissection, we can identify the parotid duct, and from the parotid duct, within 1 centimeter of that, we will find the buccal branch of the facial nerve. And other are styloid process and mastoid drill out. Mastoid drill out is a very important question asked in the Viva Voce examination, when we say that we are not able to identify facial nerve in the parotid gland or parotid area. What we will do? What we can do, we can drill out the mastoid, identify the facial nerve from there, and then we can trace it towards the facial parotid gland. Facelift incision, this incision very helpful when we need a cosmetically better scar. Here we can see the cosmetically concealed scar is there. Deep lobe tumors, here we can see this is a tumor located in the deep lobe. Similarly, so here we have to do a total conservative parotidectomy. We initially superficial parotidectomy will be done, then we retract the facial nerve into branches, and then we can remove the deep lobe. This is the basic steps of the superficial parotidectomy. Here we can see. Ravi sir, please let me know when my time is getting over. So I I think I'm not past the time.
You have 5 minutes more.
Okay, sir. I'll just breeze through. I have a few cases to show. This is basically surgery of the submandibular gland. I will, most importantly, in the surgery of submandibular gland, most important question is asked: how would you preserve a marginal mandibular nerve? So there are three important steps. Hayes-Martin maneuver. We will go to the, we'll ligate the deep facial vein, which is just behind the subplatysmal flap, and ligate it and lift it upwards and work below the facial vein. So the, here we can see this, this marginal mandibular is going over the facial vein. So if we ligate it here and retract it upwards, so obviously nerve will be protected. And we'll go deep to the capsule and do a subcapsular dissection. This is the second method. Third method is direct and retrograde identification of the nerve. These three are most, one, second, and third. These three are the most important methods to identify to preserve the marginal mandibular nerve. And so for that, what we can do, we do an incision 2 finger breadth below the body of the mandible, and we can use the nerve monitor if it is available also. So these are the basic steps of the submandibular. I will just breeze through because we have 5 minutes left here. I want to discuss complications of the parotidectomy. We can use the facial nerve monitor. The electrode placement of the facial nerve monitor is important. One electrode we apply near the orbit in the orbicularis oculi, and then the other in the angle of the mouth. We can use the microscope. Cadaveric dissection is also important, and complications of parotidectomy. Facial nerve injury is the biggest concern. Temporary is common in 10 to 50% of cases, and permanent is 0 to 5% of cases. Risk always depends on the extent of disease, type of resection, and experience of the surgeon. Common in difficult cases, and especially large tumors, deep lobe tumors, malignant and revision surgery. Reason of injury: trauma while dissecting right on the nerve, traction injury to the nerve, thermal injury when we use the cautery too close to the nerve, and prolonged operating time. Marginal mandibular is most susceptible to neuropyrexia because it has thinner and more fragile nature of this region, but this typically recovers in few weeks. This is a mild marginal paresis, which usually recovers. Complete recovery following paresis. You can see palsy of the single branch. Here we can see the diagomatic branch is going there, and so you can see the lower trunk is sacrificed. Hypoesthesia of greater auricular nerve, I have told you we can preserve that if we preserve the posterior branch of the nerve while dissecting over the nerve. Here we can see that we see the posterior branch of the greater auricular nerve is well preserved, and all the facial nerve of the branches of facial nerve we can see here. Amputation neuroma. It's a late complication which is present as a localized tender swelling on the superior part of sternocleidomastoid. Simple local excision is sufficient, burying the fresh end of the cut nerve in the muscle. Cosmetic deformity is surgical pivot, surgical depression over the parotid. It can be most noticeable just immediately after operation. What we can do, we can just rotate the SCM muscle and put it in the parotid fossa. It will be large pleomorphic adenoma. Here we can see. So you can see we have planned the incision. This is the dissection of the nerve. Post-op here it is fine, but this is the what I could have done as better as I could have removed this much of the skin. So there has been this much of the skin, and I would have rotated the flap. If I would have rotated SCM flap, so this kind of defect would have not been there. This kind of cosmetic deformity would have not been there. We are still in the learning process. Frey syndrome is the most important syndrome. Auriculotemporal syndrome, or other names are Dupuis syndrome or Belarja syndrome. It is named after Ludwig Frey, a Polish neurologist. So what happens? Transaction of the cholinergic secretomyelin to the secretory units of the parotid gland. Subsequently, it sprouts new axon, and it innervates the sweat glands and the skin flap, which are also responsive to the acetylcholine. So what happens is whenever we eat, it starts to sweat. So incidence of the fractional, it is a very important question. It is reported that the 10% of the patient who undergo periods will complain of gustatory sweating. On questioning, if we ask them, 30 to 40% will reply that there is a gustatory sweating. And if we go and demonstrate, 95% of the patient will have the gustatory sweating. So we do a starch iodine test in this minor starch iodine test. What we do in this test is we cover the affected skin with the iodine solution, and once this is dried, it is dusted with starch powder, and then we give some lemon sweet to the patient. As a result, patient will be sweating, and as a result, absorption of wet iodine by starch in the affected area will turn blue purple. So this is the starch iodine test. How we can preserve? We can raise the thick skin flap, rotation of the superficial temporal artery based temporoparietal vascular flap, rotation of SMS, and rotation of SCM muscle flap. Treatment, most important question asked in the PG examination: injection of the botulinum type A toxin. This inhibits the neurotransmitter release and give it the relief to the patient. There are few surgical treatments also there in the text: cervical sympathetic tympanic neurectomy. Alloderm, this is a acellular human dermal graft which interposition which causes a physical barrier. It prevents the Frey syndrome. Salivary fistula, it is very common after superficial periodictomy, but it is usually a self-conservative thing. If you go on for a pressure dressing, it usually resolves. This is a picture of seroma. Trismus or frostbite syndrome occurs mild trismus because of the dissection around the masticator muscles. Is usually mild and transient thing. Complications of the submandibular gland excision are hematoma, wound excision, marginal injury, lingual and hypoglossal injury we have already discussed. Ravi sir, my presentation is finished. I have few cases to show as the time allows. If I am done with the time, I am ready to finish right here only. I think 9:30 is there.
I think we can finish it now, and
Okay,
we
sir.
can take few questions if there are any
Yes, sir. Yes,
questions.
sir.
We can take
Okay.
that.
Okay. I just had few cases to show, but my presentation is more or less finished, sir.
So, are there any questions from the faculty?
Thank you very much, sir, for an interesting talk.
Thank you so much. Thank you so much, sir.
So I would request faculty for any question.
There is no question, but I said this hello, Weber, well presented. I want to make a small comment.
Yes, sir. Yes, sir.
This depression following total me in a young patient should be taken care. In elderly, it can be managed, so he's not bothered about the cosmetic appearance. But one should start practicing, rotate this partly cut for the
SCM flaps
mastide or detach from the mastide process and rotate and stitch at the anterior part of the incision or in the soft tissue, so that the depression is not there post-operatively. That needs to be practiced so that you give a better quality of life.
Sir. Definitely, sir.
Cosmetical acceptable appearance to the patient.
Yes. Yes, sir.
Plus, practice this facelift incision. That is a good. That will give you more control or more exposure of the sternocleidomastoid, so that cosmetically scar will not be there in the neck. Plus, this depression will also be taken care.
Okay, sir. I'll keep that in mind, sir. Thank you.
Thank you very much, sir.
Thank you, sir. Thank you, sir. I'll stop sharing my screen.
Thank you, Dr. Weber, for a nice presentation.
Thank you so much, sir.
And we can go ahead with the next speaker.
Now I must welcome Dr. Manish Munjal. Hello, sir. Hello, good morning, sir. Now our next topic is evaluation of dysphagia. Sir is a senior consultant in Sir Gangaram Hospital, and he's also an ex-MMC, and his special interest is in laryngology. So I would request sir to start the proceedings.
Yeah, am I audible to everybody, please?
Yes, sir. You
Hello?
are audible, sir.
Sorry, yeah. Sorry, there was some problem with the internet connection. I would really like to thank uh, at the onset my uh, teachers at the Maulana Azad Institute, and a few of them still there who had been guides earlier. Also, some of them have retired, starting from Dr. Professor Director A.K. Agarwal, Dr. Anup Raj, Dr. Atul Gulati, Dr. J.C. Pasi. The list is a long, and now Dr. Ishwar Singh, Dr. Rathore, so many, and Ravi also. Dr. Ravi, I call more of a friend now. He was just 1 year senior to me, but it is always a pleasure to be back with you. So I would not take much time because I get nostalgic when I talk about MAMSI, and like to talk about a very conceptual topic, that's dysphagia. Unlike the excellent topics of specificity and objectiveness, dysphagia being a tri-compartment disease is very poorly understood, and also the treatment modalities are very vague. So we'll try to do and put my own thought process into it a little bit and see if I can help out our PG students to probably answer a question on it if it comes in the question paper. So when we talk about dysphagia, uh, we first of all would say why we are fussing over such a simple task. It is something that we do every day, and we see people doing it in various ways. But well, the problem is not that straight. We have issues with over almost 17 to 20% in adult population in India suffering from some form of oropharyngeal or lower down dysphagia. Aspiration pneumonitis remains one of the single largest reasons for post-stroke long-term mortality in ICUs or people coming out of it. US figures, we don't have too many figures. I had to quote almost like more than crore, almost like coronavirus. There are millions affected due to dysphagia. There's still no single modality of treatment, and rehabilitation is a long drawn and a tedious processes. There are a wide range of issues that are associated with dysphagia, the most predominant in tertiary care hospital being neurological cases, stroke, Parkinson's, sclerosis. Then there are issues which directly affect the area, that is head and neck tumor, malignancies, radiotherapy, diseases with a immune base like lupus, Sjogren's, very common. Then things lower down which cause esophagus and the upper oral cases like laryngopharyngeal reflux. Then of course infection, other diseases, vascular abnormalities causing obstruction, and not to talk about psychological issues, this various dysfunctions and all that come in the picture. So many modalities we would might even tend to think whether it's an ENT thing at all, and it requires multimodal support. Well, it does, but an ENT should take a lot of lead in the matter, because the whole problem starts where you start putting your lips together. There's the oral cavity, and then the whole area prepares itself, which is called the oral transitory phase. These two are voluntary parts. Then the thing comes down into the palate, where the soft palate rises and the food goes down. The tongue base depresses a little bit, accommodates the bolus. This phase is a secondary phase of swallowing and starts to get involuntary, and then it is all involuntary after that into the esophagus when the food finally goes down to the stomach. So, who controls it? Well, the oral mechanisms are largely voluntary, but their inputs are mostly from the cortical and the subcortical brain. The pharyngeal phase is largely involuntary and therefore is controlled to a large extent by brainstem. Esophageal is totally involuntary again, with both inputs, brainstem and subcortical, but also a lot of autonomic input. But of course, these are required to be consistently close in nature and work in tandem. So it actually conceptually needs to be considered as a part of a pressure generating system. From one high pressure, the food is pushed into the lower pressure, muscle compressors and expanding the other compartments going down. So any structural or neuromuscular function in any area will result in the loss of pressure gradient, and as a result, transit of bolus will be impaired. Well, who is a candidate who is required to be assessed? First of all, that's a big question. There are so many patients coming in. So first of all, you must see whether the candidate is worth assessing in a particular format. Is he an outpatient candidate, inpatient, ICU? Is it a recent onset? Is it happening for a long time? Is it happening and improving or going down? Does it look like a structural problem, functional problem, or it's just happening like that? Would a clinical examination, a tongue depressor, watching in, talking would be enough? And is the patient at any risk where you want to take care? So general condition, comorbidities, what is the history of previous surgeries? Is there a coughing after swallowing? Does the patient choke on food? Very vital points. Is the voice, listen to the voice, is the voice gurgly? Is it wet? Is a patient telling you that there is a sensation of food stucking in? Maybe it doesn't stuck all the time. Is there a lump in the throat? Is there pain sensation? Are there recurrent chest infections happening? Go back to the history. And finally, is there any weight loss and fatigue? So this kind of patient where the emaciation has just started to set in, he starts talking about a good history is a few questions would be very helpful. And the way the patient is staring at you, his eyebrows moving well, but there is still a little bit of slowness, starts pointing out to the possibility of a neuromuscular disease like a motor neuron disease. And then he starts pointing to the particular site also where the problem is happening. Make him count some this thing. For younger patients, this is a post corrosive injury patient, and sorry, for these kind of cases, how they are breathing, what is the kind of voice is there, what is the effort that is coming in the throat. These are important points. Therefore, the history taking becomes a very important part, and each and every question, like I mentioned in the first two slides, must be asked in great detail. Later on, the tools that would be employing are the need for a bedside examination. There are various history and various questionnaires that determine the content of the problem and also where the situation is taking it into a diagnosis. Then, of course, there is always good to do a oral challenge test with plain water. We'll talk about it or something. And then later on, various modalities, these are available like FEES, video fluoroscopy, high definition manometry, transnasal esophagoscopy, and of course, biofeedbacks. So this is a sort of questionnaire that we use, and a very simple questionnaire which was developed by the company of Peter Belfasky et al. In University of UC Davis. And it just basically asks you to go through, the patient asks to go to 10 various questions, and there is a score from 0 to 4 in this, and any score over 17 is considered very significant. So this is a score which is we really employ these days because it's so simple. Whereas if you go by the handicap index scores approved by ASHA and ASHA, this American associations, then you have more elaborate scores which employ up to 35 questions. I'll not go into detail, where each and every detail is discussed with small points, and then you go and do a system scoring. So 46 and above is the score where you start talking about the severity. Examination is at most important. As I said, the patient is based in a OPD, based in a hospital. What is the level of alertness? What is the voice? Are they associated pathologies? What is the nutrition, hydration? What is the chest respiratory status? Is at most important. And then we start with the examination. So, for example, if this kind of patient, many head and neck cancer surgeons send patients like these who have got issues with the phases, and where you see right from the lip where there is incompetence, there is such a poor development and weakness of buccinator muscle. How is the tongue control, which is going back? Look at the muscles of the neck, the and look at the blowing capacity and the neck stability and all. Then you must give such people, if they're not aspirating, how they take in the water, are they already employing any compensatory? So like this lady is already employing a compensatory method. She is taking it to the weaker side and swallowing. So, at the oral examination, what we saw was the range of motion, strength, and symmetry of mouth, starting from the lips. How was the tongue protrusion? What was the buccinator support? Palatal movements I had checked later on. Her mouth opening was poor in this case, so we could not see in this particular cases. And then the phonation is very important. And of course, throat clearing, any secretions heard during the course of normal breathing must be noted as abnormal. First, initiate a dry swallow, that is absolutely important. Then watch the neck for higher laryngeal elevation. And watch for any delays, compensatory maneuvers that could come in. For example, in this child who is there in the admitted, how he's talking, you can almost hear the secretions stuck in the throat and the lower respiratory tract. It's a clear indication that there is also something neurological wrong. Whenever he speaks, you can hear the secretions along with that. In this youngster case, a person who is in the adolescent or maybe adult age group, you also see the incoordination occurring while doing a swallow, in the sense that there is a guarded, short, shallow swallowing. There is control, but the patient has fear of coughing every time when he starts to swallow. Of course, whenever he says something, he is not able to control his vocal cords too well, you can see. And later on, although I would be sharing the feast video later on for some patients, when you see there's a considerable amount of secretions, and he has to use a lot of pharyngeal squeeze to make the vocal cords come and stop the aspiration. So immediately your mind comes down to bulbar weakness in such cases. So what is oral challenge? I find it very useful to do oral challenge test in some patients. We use plain or colored water. Sometimes we use beetroot red dye. We always use coloring agents when the patient is tracheostomized. And most of these cases require, when you get a call to start them oral feeding or see the side of it. So 2 ml feeds on the side oral fornices. We again observe the same, how the patient is holding, what is the transit time, how is he taking in, was there any cough. And then later on we do a short examination after giving this dye in the mouth. This patient has fortunately done well, and once he swallows, you see his neck, ask him to swallow. They are sometimes not very well conscious. You must do later on a suction after deflating the cuff. It is a good time to observe a cough reflex and also see how much secretions are coming. If there is a green color dye coming in, then obviously we are looking at macro aspiration. And sometimes there is a limitation when you give this dye. This is by spoon also you can give. You see the patient has got such, it is a Guillain-Barré syndrome case, and the patient is unable to even initiate the first swallow. So you immediately know this is a hopeless condition at this moment of time. See, the patient is bringing it out, not able to swallow. So although the tools that we talk about, the questionnaires, we can write umpteen number of times, but the relationship between this, the objective problems, the GUS scores, how much the neurological fitting was there with our test, is not a very objective tool. So we need some objective tests, we need some risk scores, we need to prognosticate so that we need some biofeedback, because rehabilitation is everything. So there come the investigating tools, and one of them, which is very important, is video fluoroscopy. Why I put video fluoroscopy, although it is not number one in our category, is because of the chronological order. It was initially video fluoroscopy. It's still very helpful, where you use successive X-ray films in a form of a movie running at 30 frames per second with a thick or a thin dye inside. This is the kind of setup which you use. You have to use the radiology colleague to use them. These are the successive dyes that we use. Dilute barium into various parts. That's the console. The only problem is that you have to take special time because it has to be done in sitting position. And once the dye is given, you record the whole frame and see, point out. This is of course only one time you can do, and you can play the video recording of the video fluoroscopy on and on. So sorry, I missed the important part, but anyway, I'm just sticking to. So these are the various type of findings that are very important that you can get. For example, this was a aspiration case, and as soon as the fluid, the barium dye came into the vallicula, you saw a large part going into the esophagus, but a lot got spilled through the vocal cords and went into the trachea. This is a case where probably some other modality would have helped, but it is so beautifully seen. There was a normal PFS opening taken down to a slightly strictured way into the esophagus, but at the same time ended up into a huge pouch, which is a Zenker's diatom. This is a treatment of choice for these conditions. And see this. This is beautiful. I've preserved it for many years now. The dye went in, and then you can see various constrictions all over the way, very unlikely to peristaltic movements. Unfortunately, this is only film I have, and this pointed out to the esophageal motility disorder. So it is a very useful phase, especially for oral phases and for esophageal phases, because oral phase also you can't see with any endoscope. Besides the clinical thing, this is helpful, and it can screen the esophagus, and you can make out aspirations into the airway well. But radiation exposure, limitation, duration, you have to do it in a short, then you got to take the patient out of the ICU or the hospital room, which might not be possible most of the time, and you need to really challenge your X-ray directors to help them set up the gantry for you, but because it has to be done in sitting position, otherwise there is no use. The second investigation that we use with our gastrointestinal colleagues is called high resolution manometry. And in this, we use a water perfusion based system. So anybody can go, there's no dye needed. There is a system of electrodes through a catheter that is placed up to the stomach beyond the lower esophageal sphincter. It has got approximately 10 electrodes, which have got appropriately 36 sensors at 1 centimeter in interval, and you have to place it very correctly so that you get a idea of the pressure problems at each level. Once the patient is asked to squeeze, an XYZ axis is in a 3 dimension in high resolution is created, where pressure, topography, and the site is taken care of very well in the system, and you can see the reddened areas with maximum pressure, the green areas with relaxation, and therefore you can make out from the cricopharynx down to the lower esophageal sphincter, and in between whatever the esophageal part is where the motility problem is coming. So they're very helpful for pharyngeal and lower disorders. I wanted to come quickly to my examination, which I consider the gold standard now. Was bought by Susan Langmore from University of Pennsylvania, and it has a two-part assessment. It is the endoscopic swallowing assessment, and the first part without the dye pertains to examining the structure and functions of the larynx and pharynx and how normal secretions are managed. The second part is the challenge test, where swallowing different sizes of consistency of liquid as boluses are as solid boluses are seen. So what do we see in that? We see for oral persistence, time and residue. We see the transit time. We see for pharyngeal contractions, are they weaker or strong? What is the cough reflex when you are doing it? All in view. What is the laryngeal injection, which means is the dye touching the vocal cords and causing a cough? Is the patient actually aspirating? And then you see once you are done with this, how he is responding to semi-solids, dry solids, and then finally liquids. Always check liquids later on. It's a simple setup, and you all only have to have a camera best and place this, see the thing on the screen and how the things are happening. And in the similar same case who had a bulbar palsy, I use this is a bedside endoscope, usually that we use, or sometimes even a setup where it is in the OPD, and then you put the dye, a white dye or a green dye, and then see what is the aspiration level. Is the fluid actually going into the throat itself? So here you see there's a lot of residue. There is a very poor contraction, and because of the motor neuron disease, the patient also has involuntary contractions happening at the same time. So the fees helps in visualizing not only the mucosa, the structures, whether there is any also association of esophagus helping in, because there is, if there is a regurgitation also happening there, you can make it out, but actually you cannot go down into the esophagus. There is obviously a little bit of discomfort that can occur with doing the nasoendoscopic examination, and sometimes it is also not very feasible to make the patient sit up and do the face examination, but still much better than video fluoroscopy. The further improvements in this course, of course, are the inclusion of now transnasal esophagoscopy, where you can actually take the, it has got a suction channel, it's got interventional ports, where you can take the endoscope down into the area where it matters even more, and that is the cricopharynx, because the muscles of the cricopharynx, that is the cricopharyngeus muscles, the longitudinal muscles, they are very important in controlling aspiration symptoms in neurological patients. So the cricopharynx and its strength is only assessed best with a transnasal esophagoscope. Of course, you can go down further to see causes of further dysphagia that might be due to the wall defects like esophagus. You can screen head and neck cancer patients. You can do biopsies if you find suspicious lesions, and also evaluate for any foreign bodies that might be happening in that. Earlier, it was gastroenterologies that were doing most of the things, but now, because it's a ENT issue, we must do that more and more. These are the various things that you can do. You can even do dilatation and all. But it is important that dysphagia is not just left at the just watching what is happening. It is important that evaluation of dysphagia takes you to these three important facts. That is, what is the compensation that you could do for the patient in terms of feeding, what is the facilitative intervention that you can do for the patient, and finally what you can do actively. So the food materials that you can do is by changing the physiology, change the taste, change the texture, by controlling temperature. A little bit of cold food is always better for dysphagia patients than hot ones. Then what is the total food intake and what is the time? These are the things you can manage with the thing. And then our speech therapists do a great job by checking on these maneuver, by bending the throat down, various compensations they can do.
And feel your Adam's apple. It is the voice box. Okay, feel the larynx.
These two ladies are the backbone of our swallowing therapy program.
Hold it up with your neck muscle.
How you clear the throat. I'm running through this because I don't think that there's too much time.
10 times at least. Tongue should be held between your.
Anybody who wants to have a look at these demonstrative maneuvers is most welcome later on.
And then chin should be.
This is a chin tuck maneuver. So basically 5 or 6 maneuvers that we do to not only evaluate but also to treat dysphagia. If the patient can do all these things, And then, of course, for cricopharyngeal spasms, we sometimes use Botox injection therapy. And here you do it under EMG guidance, where you want to see the strength of the thyroid muscle, whether there's good closing happening, and then also inject Botox in these situations if required. Cricopharyngeal myotomy, it is not my own slide. I don't do too much of direct except during laryngectomy procedures. It's very helpful. But CP myotomy has to be a very good helpful tool in these situations. I do a lot of fat injection, laryngoplasty, and medialization procedures to control dysphagia in patients with isolated vocal cord palsy or even vagal palsy. And in some cases, especially where there is a poor hyolaryngeal elevation, a cricothyroid approximation is a fantastic procedure. And I owe this to Dr. Alok Thakkar, who had used this procedure a lot in dysphagia patients and also voice control patients, and we are using it a lot in dysphagia control these days. Of course, dilatation with balloons, and later on, unfortunately, surgery for intractable aspirations such as tracheostomy, laryngeal diversion procedures, even a laryngectomy. You will be surprised to know is now the gold standard for intractable aspiration in the US. It is done more for aspiration than it is done for cancer surgeries these days, cancer situations. Well, where are the future directions? The reinnovation of the affected vagal and laryngeal functions by doing a hyoid to hypoglossal anastomosis. These are one of the ways where future direction lies. Electrode stimulations through things like Vita Slim and EMG equipment is on the anvil. There are commercial things that are available for this. In the end, I would like to say that when I have a case of suspected dysphagia, that is how I would like the youngsters to remember my algorithm, because I find it very helpful. You get a suspected of case of dysphagia, you see the setting in which you are in, whether you are an outpatient, an inpatient, or an ICU setting. See for what is the general condition, history, what is the local examination tell you. If there is an aspiration risk associated with your dysphagia patient, you must immediately go down to protection, go for protected measures like the possibility of a Ryle's tube insertion. In extreme cases, you might have to go for a tracheostomy, a percutaneous gastrostomy. You might have to do things like reassessment till the macro aspiration actually stops. And if you have cases where there is no obvious aspiration risk immediately, then you first take out those cases which are due to globus, which are due to anxiety, because and some of them could be malingerers in the situation. And then you must design an appropriate psychotherapy and support. Sometimes speech therapy or swallowing therapy helps. But these are the cases where you need to work harder. In structural cases, try and neurological cases, try to find out the site and cause which has caused the dysphagia. Oral phase, pharyngeal, esophageal, where the affected subsite is there. These are the methodologies. In oral phase, clinical examination is paramount, followed by video fluoroscopy. In pharyngeal phase, you must rely more on face examination, as I showed. What is the die? Where is the die going? What are the contractions? Then go on to the video fluoroscopy if it is inconclusive. Then high resolution manometry we of some use. In esophageal phase, go for video fluoroscopy initially because you want to see the lower part first, and then transnasal esophagoscopy is of great help, and high resolution manometry which will tell about physiology. Appropriate management, as I said, compensatory, facilitative, or interventional can then be designed for such patients. So I would like to say in practice, if a patient is conscious then and he's having a disorder, that he requires a swallowing assessment. The younger the patient, the better the prognosis. Acute neurological events must be assessed as soon as possible and rehabilitated because it could be a killer. Tracheostomy patients also frequently fail the dry test due to structural restriction. You must not give up. Keep on doing it every 1 week or 2 weeks if you have such a patient. Do not leave. Oral channel clearers also must be subjected to other objective tests, because micro aspiration is also deadly as macro aspiration. So don't miss it. And a holistic multi-system team approach and a patience with empathy to the patient must be there. So I thank you all from Gangaram, and this is a place where I learned a lot of dysphagia. That is with Peter Belaski and Melanie Kuhn in University Davis. They were helpful in great insights. Anybody who wants to learn more about lower dysphagia, cricopharyngeal and lower, must visit this place. Thank you so much. Am I audible, please?
Thank you, sir. Thank you, sir, for an interesting talk.
I think I stuck to time. Thank you.
Yes, sir. Yes, sir. Thank you very much, sir, for an interesting talk.
Yeah.
So I would request faculties for any queries, please.
Hello.
Hello. Good morning, sir. Hello, sir. Dr. Rathore. Sir, how are you?
Fine. Very well presented topic.
Thank you,
Actually,
sir.
my query was, is there any role of GI surgeon who are doing OM in dysphagia, lower esophageal? So, is there any role? Because it is slightly like.
Fantastic role, sir. In I mean, my greatest fear while I was preparing the talk was that Ravi had given me such a vast topic which I had to try to cover. But of course, I still could not go into the lower esophageal causes of dysphagia. But whenever there is a problem of hiatus hernia, as you are pointing out, which is from obviously grade 1 to 6, and there is a problem of the lower esophageal longitudinal versus circular musculature problem causing the things to come out. There is a great thing that the gastroenterologist had brought, and they do a submucosal dissection and radiocautery of removal of this constriction, that is the Schatzky ring and lower down. So by giving a cut on this and relaxing the lower esophageal sphincter, a lot of GERD complaint leading to LPR and upper esophageal complaints are also cured. So POEM is an excellent treatment for this situation. But of course, it is pertaining to complete lower esophageal dysphagia, which is a very important topic, and it affects us because our upper esophageous sphincter that starts to compensatorily close down when we have a lower esophageal dysphagia. So the symptoms are here even for a lower esophageal thing. So POEM also helps upper esophageal dysphagia or upper throat symptoms. But of course, we are not yet into it because it requires a great endoscope, it requires great equipment, and above all, it requires somebody to take care of gastrointestinal perforations and complications that may occur due to the procedure. So ENT surgeons should not get into it, at least at this moment of time.
Okay, Dr. Manish, excellent presentation. It was a difficult topic because not many people have started dysphagia clinics, and it's an important topic for our postgraduate students also, and you have covered it very nicely.
Yeah.
I have one question which is there in the chat box by Dr. Abha.
Yes, sir.
Yeah.
She wants to ask how cricopharyngeal spasm is diagnosed clinically.
Okay, fantastic. So there are basically two types of basic cricopharyngeal spasm. One is a physiological primary spasm, and the other is a secondary spasm consequent to causes. So if we are talking about primary cricopharyngeal spasm, we are mostly talking about globus pharyngeus, the condition that occurs in many people, and because of, as I mentioned, the esophagus is also controlled by cortical, subcortical fibers with inputs from autonomous system. So these, there is obviously a problem in this pathway, and this causes also due to anxiety and all, it is accentuated, causes a spasm in these areas. The primary modality treatment is by treatment of the underlying underdiagnosed anxiety, and also to give supplements like easier foods and temperature foods to with consistency to help out the cause. But at the end of the day, breathing exercises more than just swallowing exercises really play a great role. I have found that by holding breath and doing humming exercises, releasing slowly the breath, that really helps in treating primary cricoesophageal spasm. Also, in anti-anxiety drugs, the antispasmodic action drugs with lesser anticholinergic effects like prothiodine, and also a little bit of you can say benzodiazepines, they are helpful. Secondary cricopharyngeal spasm, I hope I answered primary. Secondary esophageal spasm is a total different entity. Like you have in post laryngectomy, you have secondary to reflux, and in that, for diagnosis, when you see while doing a transnasal esophagoscopy, while bringing the scope out, you must see what is the constriction or final constriction and dilatation difference of the cricopharyngeal muscle. If the cricopharyngeal muscle is in its best width while coming out in relaxation is less than 1.3 centimeters in diameter, it's a rough thing, but is left less than that, or it holds onto your scope while coming back or going down. It's, mind you, it is a 6 to 7 external diameter TNE scope. That means there is a significant issue of spasm. And in such cases, if the same first primary modality therapies are not working, there is a role of number one, if you find more of a constrictive spasm, there is a role of Botox injection. Sometimes you have to dilate it with a double balloon, that is size 16 into 2. Two balloons have to be put into the cricopharynx, the bionics balloon, Boston Scientific, I mean, and by dilating him, that you can give relaxation. And of course, which I don't do, I have not done it, I'll be very honest. In you might have to do a cricopharyngeal myotomy surgical in such cases also at by a transcervical approach. But thankfully, most of the dysphasias, if not by primary therapy, they have responded very well with Botox. But mind you, in neurological cricopharyngeal dysphagia, where it is not the spasm, but the incoordination of the muscle or laxity of the muscle, if it is happening, or even due to primary extreme reflux, if it is often the putting of Botox and all could be counterproductive, because a weak cricopharynx will bring the aspirates into the vocal cord. So this is also a big problem that you have to make out. So Botox has to be handled very carefully in cricopharynx, much easier in vocal cords.
Okay, thank you, Manish. And something about the objective parameters of fees. Can you just
Yeah,
enumerate what are the parameters you actually observe during functional
yeah.
evaluation of swallowing?
So I could go about back to that slide also if required.
Because I think that is very important for
Very
our
important, very
students.
important, very important. So the parameters, I think, yeah. So when you are you able to see the slide? Huh?
Yes, yes,
Yes, sir.
yes.
Yes, sir.
So when you see the when you do the parameter, of course, I have not dwelled upon the objective scale because I don't believe in the objective scale. Susan Langmore has brought in the objective scale; it's very difficult, but parameters are very important. What you observe is very important. When you place an endoscope, right from there in the nose, your examination should start. How you're placing the endoscope, even nasal secretions give you an idea where there's a possibility of nasal regurgitation. After that, we make a patient say do ah and see the elevation of the palate. You ask the patient to say pa 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 pa, and you see whether the palate is rising with the command of the patient, whether it is rising symmetrically or it is rising involuntary or not rising at all. Very important thing, because immediately the velopharyngeal insufficiency has to be dialogued as a part of piece. Going down further, you first of all observe the whole three-dimensional look, whether there is any atrophy or there is any hypertrophy of the musculature that you see around. Obviously, a weakness which is more commonly seen in patients of post-stroke will point out to an obvious neurological weakness. Again, look for symmetry, how the tongue bases are elevating. ask the patient to immediately first do a swallow. So in this, there is a period of whitewash. You want to see a whitewash happening. If there is a whitewash happening and it is happening with a good, strong intent, it means that things are happening the positive way. But if you are able to see most of the oropharynx, or if God forbid you see the hypopharynx or larynx, even during a swallow, that means there is something really wrong. Then you see for secretions, where are the secretions collecting? Is the vallicula full of secretions? Are the sides, the piriform sinuses having collection in spite of you asking the patient to do multiple swallow? This is the observation period. And finally, you ask the patient to say a loud hey on the top of the word. Say hey, because when he says that, you actually see the pharyngeal contraction and the higher elevation occurring at the same time. So you can see the measurement at this time, and you can mentally make out how much weakness or strength is there. After this, done this, you come down to the second part of the test, the parameters of objective swallowing. So in this, when you are sure that there is no frank aspiration, of course, sorry, I forgot the vocal cord mobility, and seeing where the closure of vocal cords is so equally important. So after this, when you are sure that these things are being compensated a little bit, you give the patient 2 milliliter of dye on the oral pharynx, visible dye. You can go for white colored dye, or you can go for green, even better. And then you see, first of all, in what did the patient hold the dye when you asked him, and after holding the dye, when you asked him to swallow, did he do it at the right time? When he swallowed the dye, did it reach in appropriate time? It can be varying again for various people, but appropriately in about 1 to 1.5 seconds, it should reach the lower part of the. You start seeing the dye, and after seeing the dye, is it did you see the whitewash immediately? How much of the dye you saw? A little bit of hurried swallowing even in normal person will see, you will see traces of dye at various multi spots, no problem. But if you see a consistent presence in the vallicula or the piriform sinus, that's a problem. If you see the dye bubbling up with air, it's a problem. If you see the dye touching the vocal cords anywhere, it's a problem. That's laryngeal injection. If you see the dye going down into the thing, then obviously there's a big problem. And if the patient felt the dye retaining there or not is a problem, whether he coughed it out, and then only after this you would go down to thinner consistencies of the dye. So with this you can make out, and you can score it in a way, in a way you want, and then you finally give the score whether this patient is worth going for a own swallowing. He wants We want to go in for compensatory or swallowing procedures, like I showed you the 5 techniques, very fantastic techniques, and allow him this thing, or he goes back on a Ryle's tube or a PEG. So this is the way it should go, and it's fantastic for neurological cases. You don't have to go beyond fees at all.
Okay, thank you, Dr. Manish, for the explanation. Thanks a lot. I think we can go ahead with the next speaker.
Now I request, thank you very much, sir, for interesting talk. Uh, Now I request Dr. Amit Shiron. He's an additional professor in AIMS Delhi, and his special work of interest is in head and neck surgery and reconstruction and pre-flap surgery also. So, sir.
Good morning, all. Hello, can you hear me? Good morning, all.
Sir.
Yes, we can hear you and we can see you
yes,
also.
Sir. Yes, sir. Okay. So you can start with the proceedings.
Okay, I'll say this. Okay, in the next half an hour, what I'll be discussing is about the head and neck reconstruction. This is a big topic. I'll try to cover most part of the reconstruction in head and neck, but we will not be able to discuss in depth because this is a single flap is going to be a big topic. So why surgical side defects after excision of head and neck tumor require proper reconstruction. Why do we? How do we do it? Means we need to maintain the integrity of the structures wherever we excise, whether we have excised the skin, mucosa, soft tissue in terms of muscles or bone. So if we don't reconstruct it properly, especially in head and neck, where there is a in areas where there is a like mucosa, we have a saliva, and if we breathe it and we don't reconstruct it properly, then there can be salivary leak, and they can have pharyngocutaneous fistula or oropharyngeal fistula. And this leak, if it prolongs for long durations, then it can lead to the patient will have a morbidity in terms of they'll have a long hospital stay, and they can also have um, dreaded complications like carotid blowout. Not only that, it is also important to give a good functional outcome, as well as also most one of the important aspect is to give a good cosmesis. So there are certain reconstructive principles in head and neck surgery. We need to replace the like tissue with another like tissue, like we replace the skin with a skin, or we replace the epithelium, that is the or mucosa with a mucosa, or a skin, or bone with a bone. And also where there is a mobility, we need to have a thin pliable tissue so that the mobility is not hampered. If bulk is required, we need to fill it, especially in oral cavity like in the tongue. When we excise major part of the tongue and we don't give a proper bulk, then the patient is going to have difficulty in swallowing. And if possible, we should also consider for color matching and practice excellent tissue handling skills. And wherever we take the flap, we need to minimize the donor side morbidity. So if we compromise in planning and reconstructive principles, this can result in short-term morbidity, like I have mentioned before, like a salivary leak, fistulas, and even bleeding, and long-term morbidity, like the patient may not be able to chew, swallow, or have a cosmesis. Like even if we do a proper reconstruction, and even if the wound is healed, and if we don't reconstruct it properly, like in these patients, the patient is not able to close the mouth, or even patient is not able to chew or swallow. So there are certain reconstructive ladders. This is the basic. Starting from when there is a defect, we can leave it as such for it to heal secondary by secondary intention. And in the top of the ladder, we have a free tissue transfer. But in head and neck, what we mainly use is, for the smaller defect, we do a direct primary closure. But we should keep in mind that the closure should be a tension-free closure, as well as after primary closure, the mobility of the structure should not be hampered. Also, we should also consider about the cosmesis. But in most of the defect, we can do by local regional flaps or by the free flap. Some centers, they prefer to use directly free flap regions, because most of the defect in the head and neck area are a complex defect, and using a free flap allows them to reconstruct in a proper way, because they have a adequate tissue size and they can plant it properly. But if, in a situation in the institute like us, we always prefer to go for local regional first. Then only if we are not able to perform local regional, we prefer to go for free tissue transfer. So most of these local regional flaps and the free flap, which we routinely use in the head and neck surgery, these are becoming with the specific size defects. I'll start with the oral cavity reconstruction, because most of the defect what we encounter is after excision of the oral cavity tumors. Being oral cancer one of the commonest cancer in India. So in the oral cavity reconstruction, coming to the tongue reconstruction first, the major goal of tongue reconstruction is we maximize the mobility of the residual tongue. We have to eliminate the dead space after resections and maintain the shape and position of the new tongue within the oral cavity. These are important. If mobility is hampered, they'll have problem in speech as well as in swallowing. If you don't give a proper bulk, when the patient chew and try to push the bolus from the oral cavity to the pharynx, if the tongue cannot approximate to the palate, then that function is going to be hampered. So we need to give a proper bulk. Um, the main flap used in the tongue reconstruction is, firstly, we prefer to use a local flap. What we are using in our institute is most of the defect which are moderate size. We are using about this infrared flap. But for the bigger flap, we prefer to use anterolateral thigh flap or pectoralis major, even pectoralis major myocutaneous flap, locoregional flap we can use. So coming to one of the flap we use for the defect, which is an infrared flap. This flap is a locally available flap in the surgical field. It is mainly based on the superior thyroid artery, and we can take the skin from the level of the hyoid up to the sternal nodes, from midline up to around 4 to 5 centimeter laterally. So when we elevate from below, we need to include the skin, subcutaneous tissue, sternohyoid, and sternothyroid. And once we reach, then we elevate the flap above the thyroid gland. When we reach in the superior pole, we tie the superior thyroid pedicle and elevate the flap along with the pedicle. And we can bring this flap by making a tunnel in the floor of mouth to the surgical side defect and suture it. The main problem with this flap is the arterial supply is very robust, but we can have sometime problem with the venous drainage, because the venous drainage can sometimes drain directly into the internal jugular vein in the level of the upper pole of thyroid gland. So if it's so, then it is sometimes difficult to bring the flap up to the desired surgical defect area. Another concern about this flap is, since we harvest the flap from the anterior part of the neck, sometimes it can leave a scar in the, which is a visible scar in the anterior part of the neck. But in terms of tongue mobility and speech, this gives a reasonably good result. But for the larger surgical tongue defect, say for example near total glossectomy, we need to put some form of flaps which are bigger in size. And when we put a flap there, we need to put slightly bigger, because during over a period of time, say in 1 year, it is going to shrink up to 30%. Even so, it will shrink more if the patient is receiving adjuvant radiotherapy. So in such situation, we can use the preferred flap. What we are using is anterolateral thigh flap. Say in this patient's major part of the tongue is excised, and what we have done is we have harvested the anterolateral thigh flap. This is a faciocutaneous flap, a perforator flap, which is the perforator is from the descending branch of the lateral circumflex femoral artery. And after bringing the flap, we can make the flap a bit bigger in size. So in the immediate period, around 1 or 2 months, it is slightly bulky. But during the over period of time, then the flap shrinks and it gives the desired bulk, so that at least the swallowing is going to be better in this patient, but the speech is not going to be that good. Since the major part of the tongue is excised, the mobility to produce speech will not be that much. There are certain literatures which compares about the free flap versus local flap in tongue reconstruction. Mainly in this article, they have compared between the submental and the radial forearm flap. The tumor size, the
I
resection
know
amount
what they
are
wanted. मैं
more or
वो
less
थोड़ा मैं
same.
weak रह गया. They wanted more on endoscopy. I was more developing on generalization.
Manish, can you just switch off your mic?
But
All right. Shit, I have put it on.
But in terms of the outcome, comparing between this loco-regional and the free flap, in terms of speech and the swallowing, they are more or less the same. But the complication in the free flap is a bit high, mainly because the donor side problem will be there with the radial forearm flap in like the skin graft partial loss or the restriction in the arm movement, forearm movement. Is there a role of sensate flap in reconstruction? There are multiple studies which you try to anastomose the sensory supply of the radial forearm to the lingual nerve in the aim to provide a sensation to the flap. Though it can give some sensation in terms of temperature, but this doesn't directly correlate with the functional outcome of speech and swallowing. Coming to the next subsides of the oral cavity, that is the buccal mucosa reconstruction. Our goal here is to, when we reconstruct the buccal mucosa defect, to prevent trismus as well as to prevent dimpling of the cheek. Smaller defect can be caused primarily, or we can use a small buccal pad of fat which is locally available there, or we can even use masseter rotation flap. But the larger defect may require loco-regional flap like supraclavicular flap or free flap like a radial forearm flap. So this is a small defect in the buccal mucosa where we have used a buccal pad of fat to cover the area. So this will, over a period of time, will mucosalize and heal the area. So we can see the buccal pad of fat, which is vascular and is there in the surgical defect. Reconstruction for the upper alveolar and the hard palate reconstruction. For the hard palate defect, we can either use obturator or we can use a flap to give oronasal separations by some form of flap which is locally available. We can either use a mesenteric flap or we can use a temporalis flap. Mesenteric flap is mainly supplied by the mesenteric branch from the internal maxillary artery, though some supply comes from the facial artery. So it is a robust flap, well vascularized, and we can bring to the palate and suture it, which is within, along with the fascia if we take it, and it will help in mucosalization, early mucosalization. So, but for the bigger defect and when we want to fill the palate or the maxillectomy defect area, we can use a temporalis muscle flap. So in which we can take the temporalis fascia along with the muscle. And once we come anteriorly along with the fascia, when we see the fat lateral to the eye, so we have to go deep to the fascia not to injure the frontal bands of the facial nerve in order to preserve the eye closure. After that, we can give a posterior cut and we can elevate from the temporal fossa. And we can release from the zygomatic arch laterally and temporal fossa medially. And we can make a tunnel, and through this opening, we can pull the flap down and suture to the palatal defect area. This will only give a oronasal separation, and the dental rehabilitation in such cases is going to be difficult. For the true and true cheek defect, the main idea here will be we need to give both the internal and the external covering so that the wound heal faster. For that, we can use, if we are using a free flap, it's better to use a thin free flap like a radial forearm flap or the anterolateral thigh flap, or we can use a outer we can use a cervical rotation flap, and the inner we can cover with another flap like a temporoparietal or the supraclavicular flap. So this is where we have used a radial forearm to give both the inner and the outer lining. And here we have used a cervical rotation. If there is a defect here, we can rotate it after excision. We can rotate the whole flap, and we should take care that it is not the base which is more important. It is we should not elevate more posteriorly, because the supply of this flap is going to come from mainly from the perforator from the masseter. So if you elevate more behind, then the necrosis around this tip can occur. So, but for the inner lining of the buccal mucosa defect, this is one of the flap where we have not done the dissection in the supraclavicular area. That is a lower level 5 area. If we haven't done the dissection, then we can take this flap. This is a thin pliable flap, robust flap, which can be used for various purpose reconstruction in head and neck. It is mainly based on the perforator from the transverse cervical artery, supplying this part of the skin of the supraclavicular area. So here we have used this so that we can bring it up and cover the inner lining of the defect. But for the complex defect, it is better to use free flap, because that will give a liberty to use the flap to insert the flap in a desired way, so that the function of the oral cavity lip is maintained. One of the important thing about oral surgery is these patients after oral surgery, they tend to develop trismus. So post-operative trismus can range from up to 71 to 80%. But there are certain ways which we can do to prevent this trismus. One is intraoperatively, we can excise the coronoid, we can do coronoidectomy. We can incise the temporalis muscle, masseter, as well as the middle pterygoid. And most important is post-operative, where we have to give intensive post-operative rehabilitation in the form of stretching exercises of the jaw. We can either use a stack tongue depressor, terabyte jaw motion rehabilitation system, or we can use a corkscrew devices. Till the wound is healed, we need to give these stretching exercises so that the patient doesn't develop trismus after this. Even if we put a flap, they can still develop trismus if we don't do these exercises. Another important aspect of head and neck reconstruction is lip defect reconstruction. There are only two concerns about lip reconstruction. One is when we excise more, they will have a small oral opening. So we need to give a good oral opening, as well as they should have an oral competence so that the patient doesn't drool while eating or swallowing. So if the defect is less than half of the lip width, we can do primary closure. Half to 2/3, we need to do some form of rearrangement of the remaining lip in the form of what we call it as a base slender flap, or the carapenzic flap. But if the defect is more than 2/3 or the whole width of the lip is excised, then we need to bring some local flap, or we need to do a free flap to reconstruct that area. So this is what we call it a slender flap, in which this is mainly used for the lateral defect, which is more than half, in which we can bring the if say this is around 4 centimeter defect, we can bring around 2 centimeter of the upper lip. We can switch it down, lower down, which is mainly based on the superior labial artery. The vascularity comes from the superior labial artery, and we can cover this area. But they can have a reasonable mouth opening, as well as the oral competence is going to be maintained. If it is a midline defect, so we can mobilize the remaining lip from the laterally and then bring medially and then suture it, what we call it as a caraphensic flap. But if it is a total lower lip reconstruction, then we need some form of a flap, because we cannot mobilize the remaining lip. If we mobilize it, they are going to have a small oral opening and they will not be able to eat properly. So for a younger patient, what we can do is we can use a radial forearm flap, and in order to make a competence, we can use a palmaris longus so that it gives a competence. But in the older elderly patient in which the skin is lax and even the buccal mucosa is lax, we can use this type of a modified Bernard Webster flap, in which in this patient the whole of the lower lip up to the some part of upper part of the mentum subunit is also excised, in which we can use this part of the skin to cheek to bring it medially and reconstruct the lip, what we call it as a modified Bernard Webster flap. So first we can close the mucosa with the skin to give a vermilion border on the border side, and then after mobilizing it, we can bring medially and suture it medially. We can also maintain the vascularity of this area by preserving the facial artery. This is the facial artery where we have preserved it. So in the when it heals, the mucosa where we have sutured it, this will look like a vermilion border, no exactly like a vermilion border, but the patient can have a reasonable mouth opening and he can have a reasonable oral competence. This is a less time consuming, shorter way of reconstructing the total defect. But for that, we need to have a ample skin of the cheek, as well as the mucosa of the buccal mucosa also should be it should be lax. There should not be, if there is submucous fibrosis, then it's going to be difficult. If there is a bony defect in the form of mandible defect, then the aim of mandibular defect is to maintain the dental occlusion and of the remaining teeth, preserved teeth, then to restore the mandibular continuity, and to allow, if possible, for the dental restoration. So we can classify the mandibular defect given by Erken, like HLC, which is, H stands for lateral defect, including the condyle. L is only the lateral defect, condyle is not included, and C is the central canine to canine defect. So there is a reconstructive ladder. So, first is there is no bony reconstruction. This is if we can do a soft tissue reconstruction, which we mainly do for the posterior mandibular defect, not for the anterior defect. Anterior defect, bony reconstruction is the must. The free flap bone, which is used for the mandibular defect, most commonly used is the fibular flap, and the next is the iliac crest flap. Why fibula? Because it gives a good length, because most of these oral cancer, they have a huge mandibular defect like hemimandible, and sometimes it comes to the anterior arch, then the iliac crest might not be able to provide that the length of the defect. Or less commonly is the composite radius flap and the scapular flap. What is the problem of not reconstructing the anterior mandibular defect? Is the worst form of deformity, what we call is endogum deformity, in which the patient chewing as well as the drooling can occur after the surgery. The lateral defects are easier to reconstruct. This is a defect in which is anterior as well as the posterior defect, which is reconstructed with a pectoralis major myocutaneous flap, in which we can see that the remaining mandible is tilted to the defect site, causing malocclusion. What if we use mandibular plate? There is only around 62% plate survival in 5 years follow-up, and the anterior mandibular defect are likely to fail than the posterior defect. Like this, after reconstruction, this part of the skin, most of the oral cancers is going to be thin, and we put a plate there. After radiotherapy, then they tend to come out in long term. Even we can use a plating for the anterior arch. This is a plate for the anterior arch, but in long term they tend to extrude. So the most commonly used flap is the fibula osteocutaneous free flap, which is based on the peroneal vessels, and it can allow multiple osteotomies since we can harvest around 25 centimeter of the bone, and up to 25 centimeter of bone can be harvested. And after putting the fibula, there is also options of osteointegration with dental implants. Since the fibula is in the lower leg, so we can use 2 operating teams to save time during surgery. But the disadvantage is the fibula is a thin bone, so it lacks the height. So for the shorter defect, we can do a double barrel to give a height of the bone. So this is a reconstructed of the anterior arch defect with a fibula and with the skin here. And the skin is used for lining the defect of the oral cavity and also for the monitoring of the flap. And this is lateral defect, which is body and the ramus, which is reconstructed with the fibula osteocutaneous flap. So anterior defect is one of the patient which anterior defect in which the patient has undergone dental rehabilitation by putting titanium implant, through which the dental implant is anchored. Bony versus for the posterior mandibular defect, even if you use a soft tissue, then in like the soft tissue flap, like the pectoralis major myocutaneous flap, in terms of the mouth opening and the diet, they are more or less the same. Slightly, there is a difference in the mean course bright. Coming to the oropharyngeal reconstruction, defect of the oropharyngeal reconstruction. So base of tongue function, we have base of tongue is important because it is responsible for the pharyngeal closure during oral phase, and it also helps in pushing the bolus into the pharynx. And for this, when we excise the base of tongue, at least one of the hypoglossal and lingual arteries should be preserved so that the remaining tongue on that side is mobile, because that is the one which is going to, even if you put the flap, and that's muscle is going to drive the move the flap where we have put it. So we need to maintain the airway also, as we want to patient to have a physiological swallowing function, and if possible to have intelligible speech. Smaller defect can be closed primarily, but larger defect requires some flap, some form of flap. Like locoregional, we can have latissimus dorsi or pectoralis major myocutaneous flap. Even infrahyoid flap has been used for the base of tongue defect. And free flap, we can use radial forearm or lateral arm, anterolateral thigh. Soft palate defect. This soft palate serves as a dynamic muscular structures to effectively separate the oral and the nasal passageway. That what we call is a belopharyngeal competence. And resection of the soft palate will result in hypernasal speech as well as nasal region of food while swallowing. So our goal will be to create a functional myomucosal velum and to establish a closure of the oronasal communication. So this is one of the patient who had adenocystic carcinoma of the base of tongue and the tonsil and soft palate, tonsil soft palate, in which it was excised with after doing a mandibulotomy, and the defect was used covered by using radial foam, which was designed in such a way that it can cover the different part of the area, say nasopharyngeal area, oropharyngeal, and the tonsillar area, and we can put to cover the whole area. As such, we have operated in these cases because the histology was adenocystic carcinoma, but had it been squamous cell carcinoma, this patient would have gone for radiotherapy or chemoradiations. So lastly, I'll talk about this hypopharyngeal reconstruction. If there is a residual pharyngeal circumference of at least 6 to 7 centimeter, we can close primarily. But if it is insufficient, then we need to put some form of flap so that if we close it, then the patient will have difficulty in swallowing. So we can use a patch pharyngoplasty. The most commonly used flap for doing patch pharyngoplasty is the pectoralis major myocutaneous flap, which is closely available to the surgical site. Also, why we prefer this is, other than covering the defect area, it can also cover the muscle, can cover the great vessels, so that even if there is leak, then that muscle is going to have a protection from the saliva. If it is a circumferential defect, the whole 360 defect, there are two conditions in which one is if the cervical esophagus is resected, we don't have a lower stump to anastomosis flap, then we need to excise the whole esophagus and do a gastric pull-up. But this comes with certain complications and morbidity, mortality, even mortality. But if we have a cervical esophagus to anastomosis, then we can use regional flap like a pectoralis major myocutaneous flap or supraclavicular flap or free flap. We don't prefer much of a pectoralis major myocutaneous flap to tube it because sometimes the muscle is bulky and tubing of this PMMC may be difficult. For the free flap for circumferential defect, one is the free jejunal flap, another one is a faciocutaneous flap like a radial forearm flap or an anterolateral thigh flap. Good about radial free jejunum is the size of the jejunum is almost as same as the esophagus, and the problem with doing this circumferential pharyngeal reconstruction is the lower anastomosis side is at the risk of developing stenosis, and the patient can have dysphagia. So it is less with free jejunal flap, but the drawback is we need to do a separate surgery. Patient will require reprotomy, as well as if you use TEP, then the voice is not that good. But the preferred one for us is a tube radial forearm flap or the supraclavicular flap. And speech comparing to this jejunal flap is going to be better, but they have got a slightly higher risk of developing stenosis at the esophageal anastomosis site. So this is not a cancer patient. This is one patient with a corrosive esophageal stricture in which a colonic pull-up was done and the distal part of the colon has necrosed, and this is the colon opening, and this is the pharyngostomy opening. So previously, what the GI surgeon in our center used to do is they used to open up the thorax, mobilize the colon, and then pull up. That is a morbid surgery. And here what we have done was we have harvested a radial forearm flap, we have tubed it, and then this side of the vessel was depleted because of the previous surgery. So we have anastomosed the vessel to the other side, and the tube, this is the pharyngeal, the upper part is anastomosed to the pharyngeal opening, and the lower is anastomosed to the colon opening. and small skin, what we see here, we have bring it out for the monitoring of the flap. This is after the post-operative, in which the flap is well taken up, and we can see the lower anastomotic side with the suture, and this is the colon, and this is the skin, and the patient is able to swallow after this. Lastly, there is also a regional flap options for reconstructing the total hypopharyngeal defect. In this, we can see this is a tracheal opening after the total laryngopharyngectomy. This is a patient with a carcinoma hypopharynx with post-cricoid area involvement, post-RT, with a residual disease, in which we have done a total pharyngectomy, and upper part of the cervical esophagus is also removed. This is a esophageal opening, and this is a tracheal opening. And we have harvested the flap based on the supraclavicular artery. The artery, the pedicle, the perforator is based on, this is the posterior part of the sternocleidomastoid muscle, external jugular vein, and the clavicle. The perforator is seen in this triangle, roughly around 2 centimeter posterior to the posterior part of the sternocleidomastoid, 3 centimeter above the clavicle, or around 8 centimeter from the sternoclavicular joint. But we don't prefer to to find the perforators. We prefer to base it on the entire soft tissue in this area. So after harvesting, we can bring below the skin, and we can deepitalize it. We can suture this has been sutured to the esophagus posterior wall, this to the pharyngeal posterior wall. Then we'll rotate it and then suture it to this deepitalized area. So we have sutured to the deepitalized area, making a tube supraclavicular flap. This is a post-operative gastrographin study in which we can see the patent lumen, and the patient is able to swallow. So to conclude, functional and the cosmetic rehabilitation are crucial for the physiological and psychological well-being of the patient. Successful reconstruction can be achieved by understanding the patient expectation and also understanding the attainable reconstructive results. High success rate possible with proper patient selections and proper planning. Thank you.
Thank you, Dr. Amit, for such a wonderful presentation. You have tried to cover up the whole of the area. I would like to ask you regarding this mandibular reconstruction.
Yes, sir.
We do reconstruct with the help of this plastic team.
Yes.
But they are not available, so we do use plate also, and almost 100% plate extrusion is there.
Yes.
Then it becomes difficult. I have used even pack measure flap in the posterior part of the mandible reconstruction, and patient lands with the cross bite. How to take care of the cross bite? Because posterior part where the defect is there, that can be reconstructed with the putting a pack measure flap, so that bulk is there. So have you any experience of the cross bite?
Yes, sir. If we excise the mandible more enterally, say we come to the premolar and the canine area, then they are going to have this cross bite. But proper, like the last molar or second last molar and the ramus, they don't have much of cross bite, provided we give a good rehabilitation. Rehabilitation is required in terms of jaw stretching, and our dental colleague also use some processes to prevent this cross bite.
Even I went to the dental people, and they were harvesting clavicle for the reconstruction of the minor defect of the mandible. Do you have, based on the sternocleidomastoid, do you have any experience?
Sir, we don't prefer to push non-vascularized bones. Sir. The problem with
it is based on the sternocleidomastoid. This clavicle partial thickness. So I saw them harvesting. So they exposed the clavicle, and the sternal head was attached to the clavicle on the middle aspect. medial end of the clavicle, and partially it was taken up, and then they put some bone graft, and that a small part of the clavicle was put as a cover up the mandibular defect.
So,
Because a lack of this free fibula facility in the dental side, so they just complete the mandibular continuity with the help of clavicle. You have any experience?
so
Because you do with the free fibula, so no need to do clavicle.
So clavicle, I have not have experience, but I have seen people doing this rib graft along with the pectoralis major myocutaneous flap to put into the mandible. But the issue is the vascularity of this bone is not as good as the free flap bones vascularity. But these patients, which we are doing, this cancer patient, they will go for radiation.
Radiotherapy.
And if the vascularity is not that good, then they can have problem. But if we are doing for benign cases in which we are not giving radiation, then that can be helpful.
If you, Dr. Tiwari from Bangalore, he has in his book has recommended or devised this partly sternum also being used as a part of myocutaneous flap in back major, and that was used as a reconstruction part, because earlier this pedicle flap were used as compared to the free fibula, which was not that popular. It took up later on, and now the free fibula is that flap of the choice for reconstruction, including any defect. Then I want to ask, this submental flap and infrahyoid flap and the suprahyoid flap, which you had used for the reconstruction of the floor of the mouth, since this is the drainage area, are these oncology sound? What is your opinion, since your is a high volume turnover center as compared to other centers?
So in our center, we don't prefer to do submental flap for the oral cancer because this is the directly draining site. But there are literature in
But
this.
you showed in the this thing tongue reconstruction, so you don't do for the tongue. You do for the tongue, not for the floor.
So that is the infrahyoid flap, sir. That is the infrahyoid flap. So
Infrahyoid
infrahyoid is that is not in the dissection lymph node draining area, but the submental flap is a lymph node draining area. We don't prefer to do it, but there are literature in this in which they say that it is oncologically safe if we do a proper neck dissection, preserving the perforators to this flap and then using it to reconstruct it. But that is a technically challenging surgery to do to preserve the perforator as well as do a neck dissection and then bring the flap to the oral cavity defect area. But we have used submental flap for mainly for the oropharyngeal, in which we don't expect the lymph node to be draining into the
not to come in
submental 1A. For that we have used this posterior oropharyngeal defect. We have used a submental flap.
Hello, Amit. Hello.
Hi, sir. Good morning.
Amit, good morning. Dr. Rathod this side.
Good morning, sir.
Amit, now you are using scapular flaps or you have stopped using that?
So scapular we are not using. So we have used in only one patient. Mainly we are using this fibula.
So what was the problem? Means why it was discarded out of practice?
Sir, it is not because of that. Because we need to harvest in the patient in the certain position. We need to change it, as well as if we are doing it, I mean it prolongs the surgery a bit more. But the fibula, if you are doing it, we can do it in the simultaneously harvest it, and then the primary surgery for the cancer also can be done at the same time.
Yes. Thank you.
One small little question. Can I ask?
Yes, sir.
Yeah.
Yeah, Amit, this is Dr. Manish Manjal. What is, I recently came across this problem. A lot of people now, after head and neck cancer, as a part of reconstruction, are also doing dental implants in the fibula that they're putting. In our, I mean, my exposure to head and neck, had no exposure to these titanium dental implants during the course of primary reconstruction. So, do you have any insights on that? How should they be encouraged, or it should be left as a second stage?
So in primary, if we can do it, we can do in the primary setting. There is no harm. Means it is also described, and there is no side effect or no disadvantage to it. The only issue is this costly thing. If the implant means something happens to the flap and the implant also goes along with it. That is the only concern which we are not able to do in our center. Also, what we are doing is only mainly secondary, and only very few patients are able to afford it.
But Amit, these patients have to go under radiotherapy. So how, what is the effect of radiotherapy on the viability of these implanted teeth or the viability of the fibula after radiotherapy if you do in the primary setting?
Sir, it can be done, sir. The implant is a very, means it's not a big, this thing like I have shown that it is a small, like a screw only, it's just projecting out of the skin.
In lip reconstruction, you said the palmaris longan tendon is used to improve the competency, but it is, where do you anchor it? Because soft tissue, we also, this plastic people in our Dr. Bhandari did a case of varicose carcinoma, lower lip extensive from one side to the other angle, and one commissure to another commissure. And then he tried to anchor it, but it didn't work. And he reconstructed with the radial forearm flap. Ultimately, the patient had a drooling problem, and at least we gave him a tumor-free this thing, but saliva and this drooling was a problem.
So we tend to anchor it a bit more. First, we need to anchor to the orbicularis oculi, oris, what is preserved, and we need to bring it up, if possible, a bit higher up, and then otherwise, if we don't suture it to the, and we need to make it more tight. In due course of time, it lax, it become a lax a bit, but we can revise it later on also. If there is loose, then we can revise the flap and make it a bit tight enough.
And this separating the oral cavity from the this nasal cavity using temporalis fascia. What about subsequently using a prosthesis, because it will not allow, nowadays people do reconstruct maxilla with the help of fibula also, then that modified, and fibula is being used as a reconstruction. Do you have any experience in reconstruction of
Fibula, I have not.
maxilla with the fibula, so
The
that
fibula,
you
I have
create
not.
a upper dental arch?
Sir, I have not. We have not started doing it, but we were thinking of starting reconstructing mandible with the fibula, at least for the lower defect, that is the alveolar defect, not the entire defect. So we were thinking of starting it, but we have not yet started it. But it is a good option because it will provide the cosmesis, as well as there is option of dental rehabilitation if we put a bone there.
I was there in America for 6 months. There they use rectus abdominis to reconstruct the palate.
Sure. One input for the lower lip. Ishwar?
Yeah.
One input for the lower lip, which you were talking that radial forearm was used. Actually, bilateral modified carapace with temporoparietal inside cover is sufficient to give a reconstruction. Loco-regional flaps are coming as a big way in these surgeries. I have done a lot of such cases.
Like nasolabial.
No, no, bilateral modified carapace. Hello.
Yeah, go ahead.
And inside cover by a temporoparietal, you can cross, when you take this flap, you can cross the midline in the skull. You can cross it. It is a very long flap. Means you can use from one end to another end to give a inside cover. So on bilateral carapace is also possible for almost whole lip you can replace. So no, I don't think there is any need of this any sort of such a advanced surgery, because patient has to go for radiotherapy. Then all these flaps they get devascularized to a large extent. So that I have already done in a lot of cases.
What about the palate reconstruction with the help of rectus abdominis muscle?
So rectus we have not used much. What we are using mainly is anterorectal thigh flap.
And since you, go ahead.
Bigger bulk, and we can cover the maxillectomy. That whole area can be covered with a big flap. So healing is faster, and they can be means the subsequent treatment can be done earlier.
So, Amit,
Yes.
actually, this palate reconstruction I have done just like you. We used to give that Wilson incision, na, palatal reconstruction. So that rotational flap based on one greater palatine artery, you can use for a reconstruction. Means you can rotate it fully, and if the need arises, you can rotate the mucosa from the anterior pillar of tonsil or the lateral wall of the pharynx. So this is sufficient to give a covering on the palate. Means you try sometimes. It is very handy and easy to do. Okay.
Yes. Yes.
Amit, you talked about the supraclavicular flap. That is based on which muscle, or say that Dr. Capre he does for oral submucous fibrosis to increase the reconstruction or lining of the cheek in case of oral submucous. Though it's a benign condition, but because of this submucous fibrosis, patient is not able to open the mouth. It is based on platysma. Is it a robust? You said robust flap, the
So this is
supraclavicular.
supraclavicular is not a muscle flap. So it is a fasciocutaneous flap. It is based on the transverse cervical artery perforated. So the patient we prefer to do in patient in which we have not done lower level 5 clearance. So if we have done level 5 clearance, then we don't do that. And the perforator are very small, and we don't try to see for it. Instead, we preserve the soft tissue connected to that flap in the triangle of the which is bounded by the posterior border of sternomastoid, EJV, and clavicle. And this flap can go up to the level of the deltoid insertion. So it is a long flap. It can very well cover the buccal mucosa defect.
Say after maxillectomy, the eye gets sagged. There is a sagging, and then prosthesis is not able to have. It has been described that you cut out the coronoid process of the mandible and make a hole in the nasal bone, and in that based on the temporalis, cut from the coronoid process of attached with this temporalis muscle and suture it, so that becomes a sling out kind of thing and helps in sagging. That prevents that deformity which a patient post radiotherapy has. Any experience?
We also do the same thing only, sir. But sometimes the bone, it lies row in the cavity, so it can become necrosis. So the concern is only about the bone, but then we bring it and then suture to the nasal bone, like you have said it. We routinely do if we have removed the breached the periorbita and we have disturbed the canthal ligament. So in those cases, if to prevent this sagging, we tend to we prefer to bring this temporalis tendon.
And then short palate reconstruction. You talked about temporalis fascia. Even I have done few cases, and in this thing, then patient do have some nasal regurgitation because it becomes a dynamic kind of thing. It only gives you a patient some nasal voice was better as compared to, but regurgitation was still a problem.
So it is still means we prefer to suture the flap to the posterior pharyngeal wall, like we do for the belopharyngeal incompetence surgery. So those sometimes help. We can cover at least half of the posterior this velum opening, so that only the functional soft palate is there as an opening. So they can help in preventing this regurgitation and hypernasality. But this flap, whatever we have used it, that patient also which I have shown, in due course of time, the flap shrinks during follow-up after radiotherapy, and this incompetence, it increases after some time.
So base of the tongue, is it dynamic? Because you need swallowing, for swallowing you have to have a dynamic, or I mean say innervation. You take in radial forearm, flap do you take now also along with it, so
No,
that
sir.
it becomes
No.
more sensation and improve
It
the
is
swallowing part?
that sensation is it is just for the sensate for the temperature only, but it doesn't help in the mobility. Mobility of this flap is going to be provided by the opposite base of tongue, which we have preserved.
Hmm.
Hello, Amit. Hello.
Yes, sir.
Amit, for the base of tongue where you need the bulk, it is better that while taking pectoralis major, we preserve a longer thoracic nerve, which is just in the line of the lateral end of the pectoralis major. So it keeps the bulk of the muscle for a longer duration. If you preserve that nerve and take it as a part of flap, don't cut it, then the bulk will be for a longer duration, and the space occupation by this functionality may not be possible, but space will be easily occupied for a longer duration. That's what I have observed in lot of such cases.
Yes, sir. Well, the muscle supply, if we preserve it, the bulk remains for a longer duration.
Even forehead flap.
For the reconstruction of the lining, this thing, Amit, I have used. Hello.
Yes, sir. Yes.
I use forehead flap, though it gives an ugly scar postoperatively, but in an elderly patient where you want to give at least get rid of the tumor, and a patient is not bothered or he's more worried about the tumor, I use forehead flap for the lining as well as for the cover. That is also very robust, sturdy flap and can be done without help of any other specialty, since you are practicing exclusive reconstruction. So the excision must be done by somebody else.
So we are still doing in few cases in which we have no options, like the vessel is depleted and there is defect and we cannot use a pectoralis major flap. So still we are using this forehead flap. Recently also we have used in one patient, which is a salvage cases where we cannot bring other flap. So this is a very robust flap, forehead flap. We can use for the inner lining as well as outer lining.
Okay.
Hello.
Okay, Doctor.
Such cases.
Okay, Dr. Amit, thank you very much. I will request you to please stay back.
Yes, sir.
And we have a few questions in the chat box, and I will call. Sir, उसको बंद कर दो ना अपना mic. नहीं किया. I will call Dr. Manish for answering that. There is one question by Dr. Jitender Singh from Panchkula. He wants to ask about osteophytes causing pressure osteophytes in elderly patients causing dysphagia. So how do you diagnose and how do you manage these patients?
Yeah, it's a question that is many times pointed out as one of the
Manish, we cannot hear you.
Hello. Am I audible now, Dr. Ravi?
Yes, sir, you are audible.
Yeah. So what I'm saying is that
I think you can just remove your earphones and maybe then try.
All right.
Can you hear, please?
Yes, sir.
I'll just try once more the earphone because
Yes. Now we can hear you. Yeah, we can hear you.
Then I'll answer the question. See, osteophytes formation is a very physiological kind of situation in most of elderly patients, and sometimes it is a overdiagnosed problem because an elderly, as he's aging, will also form more osteophyte. The compression of the vertebral bodies anteriorly does cause osteophyte formation in most of the people. Sometimes they cause enough to very rarely cause dysphagia, but it is more due to neuromuscular causes that it is actually the case. So one must carefully, first of all, rule out the other causes, like a motor neuron disease or a dry mouth syndrome, a dentalist patient. All these things do have, these kind of patients do have a phenomena of having food stuck in their throat. And sometimes by getting x-rays and all done, we are just complicating the picture. However, having said that, if in such a case you need to investigate and all the things are moved from the view, then endoscopic examination after seeing the x-rays is important. I do not merely treat osteophytes on the basis of radiology alone, but if I feel that on a fees examination there is a considerable bulge, there's pooling of secretion around it, and there is a painful dysphagia associated with it, then we do have a role of surgery. The surgery, although external approaches have been designed, but we have done mostly surgeries in osteophytes or anterior body protrusions by doing a transoral approach for higher osteophytes, like in the area of C2 and C3, and for rarely for a C6, C5. I remember doing one. We had to use a curate through this laryngoscope, the Vita's laryngoscope, the suspension laryngoscope with a posterior blade. So the laryngoscope that you use, if at all you have to do an osteophyte removal, cannot be the normal laryngoscope because it has a very narrow aperture and no fulcrum to do a surgery. So you have to do Store's Vitam's scope, in which the flanges open up and you can see the posterior pharyngeal wall in front of you, and even the side wall opens up. So giving a clean linear incision, separating the muscle, getting the osteophyte, and then gently curating whatever you could do. This is a way osteophytes are treated. But please rule out neuromuscular causes. And in this case, one important modality is video fluoroscopy. I really rely also on video. I will not do it on the basis of fees examination. It is important to functionally see, but actually the video fluoroscopy will see the osteophyte, how it's coming in the way of the dye going down. So I hope that answers this.
Acha, Manish, I got another question. You talked about neurovascular and post-surgery and all. There are vascular causes also, and dysphagia luxuria is an important cause.
Yes,
so it's not picked up early. Patient goes from one place to another, does all doctor shopping. And what have you got any experience? And what is the, if there is a left main
subclavian artery and even bronchocephalic veins, the artery, this thing. Well, I have never been able to, frankly, understand too much of dysphagia luxuria. I have been sent patients, but the problem is that we have too much of a situation where the esophagus is so such a thin muscular tube anyway that it finds its way down too easily, and blood vessels may cause theoretically an obstruction, but I frankly in the clinical setting, I have not seen esophagus being distorted badly by a dysphagia luxuria. And if at all this diagnosis again can be made, then because it is in the it comes in the motility disorder of esophagus, I would really say that VFSSS would be one of the best investigation to diagnose it. And yeah, post-op cardiothoracic patient situations. There is a very famous cardiothoracic surgeon in Gangaram who has done arterial grafts and things like that. And you can say it's a situation mimicking dysphagia luxuria, where they had done bypass for this surgery, the heart situs invertus surgery. In that case, we did have a child with the esophagus calm. Actually, the esophagus going down like this, then the diet lynching up and then going down again, almost at a 90-degree angle. But of course, since the child did not have, was regurgitating a lot, but his mother and father were able to maintain a normal growth curve in the child. There was no loss of this thing. We chose to remain a little bit this thing because it means another cardiothoracic surgery. As a ENT surgeon, you can't do too much about it. You can't go into the thorax. You can only recommend that if it is too bad, then needs to be treated. So I have not primarily treated it, but I've seen 2 cases of this sort in my practice that I can remember.
Another question, Dr. Manish. Commonly, we do laryngectomy, that is a salvage laryngectomy or post laryngectomy patient, and we try to facilitate the swallowing by doing cricopharyngeal myotomy. But if there is a narrow or a tight repair or neopharynx constructed is tight, and even the patient goes for radiotherapy, subsequently patient do land up with the dysphagia, and you get a barium swallow, see patient is only takes on liquid, and then do dilatation. How frequently you come across such cases, and what is your take on this?
Well, with the linear Y-shaped closure, this thankfully problem is less, but T-shaped closures many people do for pharyngeal reconstruction, where there's a tri-suture closure. We have seen this a lot. And one thing I would say that we always do this intra-op cricopharyngeal myotomy in cases, but the myotomy has to be really deep. It has to be going down till the mucosa. You should see the transparent fingers through the when you're doing it, and the muscle, many people just do it arbitrarily, but it has to be a really
It should be
deep,
done at two places on two sides.
sorry,
at two places it can be done.
Absolutely,
on the
two places, and so the
9 or 3 o'clock
you should have the fear. You should have the fear that you could in the next cut you will rip off the mucosa. That fear should come. Till that time you have to do a myotomy. So if you are doing it, hopefully things. But I have had very bad situations where more than dysphagia. Of course, I'll tell you what I did. But people have absolute failure of secondary TEP prosthesis because of the severe constriction of cricopharynx muscle. And of course, none of them till now, because they were not symptomatic for cancer again, so they did not have to go for external approaches. Thankfully, the closures were not that bad, but we had to do Botox injection. I do a lot of, I have started believing in doing Botox not only for spasms, but I've started doing Botox for fibrosis also, because the VEGF factor in recent studies of Botox has shown significant inhibition in fibrosis also management. So we now do Botox a little bit and more. Botox has become more affordable. There are some companies, Indian companies, that are having very good Botox. I would say this is a very helpful thing in such cases. But yes, you do have to do this thing, balloon dilatation. We can do it in intra-OPD balloon dilatation. It's very safe in post-laryngectomy, safest that you can imagine. There is no airway risk, and therefore we kept balloons, and such patients do well. But TAP I have not been able to solve because of somehow there is a spasm which they have got used to, and swallowing they manage, but they are not able to manage speech well, such cases. So the post laryngectomy, swallowing always goes with a speech problem also, rehabilitation. That is also a very big problem that you see. But thankfully, open surgeries have been avoided so far. I've not seen, I've seen more of regurgitations than this.
Even insertion of a TP post this thing RT secondary TP becomes difficult. Even I had to, in 3-4 cases I remember with the Kavita Goel, we had to dilate the this thing with the help of esophagus was not being able to insert. Then we, since bronchoscope had that narrow lumen that we used, and then ultimately with the buoys we dilated, and only then we with the that we could insert.
I'll actually consider it a relative contraindication of a TEP processes. I mean, you would have problems in managing him later on also. I feel that I would rather see the dilatation working well for him for some time, and then maybe take him up again for such a procedure, because it clearly means that there's incoordination of the musculature or fibrosis developing in, which will have an impact on his speech.
Dr. Manish, what is the dosing schedule for this Botox? What you are giving for the
for what? For which situation?
Spasm, for the spasm.
For spasm in post laryngectomy patient.
Yes.
Okay, because I thought there were two situations. One is intact muscle, like a primary or a cricopharyngeal spasm, or a secondary spasm where you have not done any surgery previously on a spasm. There, the amount of Botox injection is done in 2 stages. One stage is the testing dose. Botox is a very unpredictable neurotransmitter. 3 units might do a total useful work in some patients, and 6 units might do a lot of overwork in the sense that patient might start aspirating. So whereas there are cases where they have done before, or because of the resistance already, inborn resistance, even 50 units might not work, and then doing it in the normal muscle plane. So if you are doing it, start with a low dose, and concentric doses of 3 units in the cricopharyngeal circular muscle is something I recommend. And coming to your question, post laryngectomy, it is very important to start with a low dose, because you would imagine that a person has already done the myotomy and there is very little muscle that you have to work on. So a low dose thing would be working well. And sometimes, especially in cricopharynx, I have found the use of an intra EMG guided needle very helpful. And once giving from the lateral side, when you reach the cricopharynx or the constrictor muscle, when you are giving it a strong signal, automatically incites you to give a little bit higher dose than a lower signal. When you get a lower, or it's all audio based signal. So if you get a lower crackling, you give a little bit less, knowing that the muscle bulk is less. And if you have a significant temporal high based creak crack, then you tend to give a little bit more of the Botox muscle. So varying from 3 into 4, 12 units concentric in cricopharynx. I have gone to 60 units in some cases of syndrome called Meeks syndrome, where I've given it for 60 units. Yeah.
Okay, thank you, Dr. Manish and Dr. Amit. We have Dr. Shamit now with us. I have 2 short questions which are there in the chat box. So I think we can take those 2 questions and then go ahead with the Dr. Shamit's talk. One of the question is for Dr. Vaibhav, if he is there, Dr. Vaibhav, or anybody, any faculty can answer. There's a question about...
Yes, sir, I'm there, sir.
Dr. Vaibhav, a question about adenoid cystic carcinoma. How do you manage facial nerve in a case of adenoid cystic carcinoma of parotid?
Sir,
short you can tell.
Answer will be similar to the every malignancy. In cases of adenoid cystic carcinoma, chances of perineural invasion are high. So if the gross tumor involvement is there and gross facial involvement is there, we have to resect the facial nerve and do the cable grafting. If the preoperatively nerve is normal, which is in most of the cases, then we will leave it as such. And if there is a perineural invasion, MRI is suggesting, then we have to reject the tumor.
Okay, right. Another question which is not related to any of the presentations. There is a question from Silchar by Dr. Fakrul. How to remove a button from nose if the child is uncooperative? I think any faculty can answer this.
Answer will be straightforward. They will have to take him to GA, sir.
Yes. So that is.
Please send to a patient to a private practitioner. At least you'll make his day.
Right.
A nasal foreign body removed in the clinic will give you no money. If you take him to a GA, you do all the tam jam for an uncovered, then only you'll be able to make some money.
Right. So I think we are here with Dr. Shamit. He has joined, and Dr. Hitendra, please introduce Dr. Shamit.
Thank you very much, sir, for an interesting talk. Now I request Dr. Shamit Chopra. Sir is an chief in the head of the department, Patel Hospital, Jalandhar, and he is also an ex-MEMC and is a fellow of the American Head and Neck Society. So, sir, would you please start with the proceedings?
Sure. Thank you, Hitendra. Am I audible? Is my voice clear?
Yes, sir, you are clear.
Perfect. And please make me a co-host so I can share my presentation.
Yes, you can share your presentation.
Great. So greetings to all. Good morning, and thank you for your patience to the faculty and delegates on a Sunday morning. Congratulations to Dr. Ravi and his dynamic team. I can see Dr. Ravi and Hitendra here, but congratulations to everyone. So without further ado, we'll move on with the allocated topic. Of all the things that Hitendra mentioned very quickly, I think the most important one was ex-MAMC. This is something that has mattered a lot to us, and It's always been a pleasure. I'm sorry I could not employ the virtual background. It looks very fancy behind Dr. Ravi and behind Dr. Hitinder. But yes, I see the wonderful building that we have, and all of us have fond memories of that. The topic allocated to me today is neck dissection, and we will remain sufficiently basic, but we'll also talk about some aspects, and we'll talk about some surgical pearls and techniques that will help us take this forward. If at any point of time the videos pixelate, or at any point of time you think that the sound or the video quality is not good, kindly feel free to interrupt me so that we can move forward. So it's a very basic presentation outline. We'll talk initially about what makes us do neck dissections. We'll talk about head neck squamous cell cancer, the disease biology of the same. What are the concepts which help us decide what patients need a neck dissection, which ones do not? For the most part, our discussion will remain limited to head and neck squamous cell cancer. We'll also talk a little bit about India, how we typically try to extrapolate our practice philosophies in patients when we are talking about treating the neck patients, and to see how our compliance kind of works out, because compliance is very, very sobering when it comes to the Indian subcontinent. Of course, it is a postgraduate training course as well. So we will talk about the questions that you'll get asked, I presume, in your vivas, about incisions and types of neck dissections, the classifications, because they're all important. And finally, I think the most important part is that we'll try to talk about surgical technique through some videos. We'll talk about a selective neck, we'll talk about a recurrent neck, and if we have time, we'll talk a little bit about central compartment as well. So, regional lymphadenopathy in head neck squamous cell cancer is the single most important prognostic factor. And I'll try to give some pointers to answers to the questions that you'll typically get. So just the presentation is a very basic one, but at the same time, just pay attention to the pointers that we give. Any positive node is going to decrease the prognosis by 50%. What it means is that if a patient would otherwise have a survival, let's say in T2 of about 70% in the head and neck, it will be decreased by a factor of half if he has a lymph node positive. So it is the single most important prognostic factor in treatable head and neck squamous cell cancer. Yes, of course, there is a subset of untreatable. Distant metastasis make a huge impact. Unresectable disease makes a huge impact. But only remaining within the realm of head and neck lymphatics, a positive lymph node in head and neck squamous cell cancer has very high prognostic significance. It also has a direct bearing on distant relapse and recurrence, and that's important to know. If you have a node, the chances of you having distant diseases are higher. If you have a node, even if it's treated appropriately, the chances of you have a recurrence in that area is higher. A lot of current research has focused on extranodal extension, which used to be called extracapsular spread initially. So ECS and ENE are terms that you will get in your exams. And for the early practicing oncologists, these are things which warrant a lot of consideration. These days, we divide extranodal extension into microscopic and macroscopic. We don't treat them differently in terms of adjuvant therapy, but remember that these patients are the aggressive actors which need more aggressive adjuvant therapy. You need to intensify treatment in these patients, and maybe with a look towards the future as to whether microscopic and macroscopic can be different. This is a study we did way back in 2013. At that time, there was no surrogate to literature in this. We tried to predict extracapsular spread, which used to be called extracapsular spread at that time, and subsequently, like I mentioned, it's called ENE. And very interesting findings, again, very predominant to the Indian subcontinent, as to whether you could use just clinical factors without really using a lot of high-end detection tools to predict what patients are going to have extranodal extension and therein move forward. The answers that we got were fairly simple. Patients with large nodes tend to have extranodal extension. Patients with aggressive primary tumors like hypopharynx and oral cavity, especially the oral tongue, tended to have more extracapsular spread. So when we talk about management of head and neck lymphatics, remember that is driven by the choice of primary modality. By that, we mean that any head neck squamous cell cancer, based on the site or based on the extent of tumor, is typically decided to be managed based on the table on the right. You are seeing in the table on the right, in the left column, you are seeing a list of sites of the head and neck, and on the right column, you're seeing the primary initial modality of treatment. As you can say, the role of the head and neck surgeon, contrary to a lot of opinions expressed currently in the West that our role is being relegated to salvage settings, that's not really true. Not just in our country, but across the world, most evidence does indicate that the surgeon will have the primary role in the management of head and neck cancer. This is just to put things in perspective. when we start talking about management of neck metastasis vis-a-vis the management of the primary. By that, I mean that if a patient has early stage oropharynx disease and you don't think the patient is amenable to transoral robotic surgery, then in that case, you have to give radiation to the primary. It is a given that the head and neck lymphatics will typically be managed by the neck, by radiation as well. So there's no point doing a selective neck dissection in that patient. However, the disease on the top, the one that we see the most often, oral cavity, if you're managing it surgically, which we do for all resectable oral cavity head neck squamous cell cancer, you will typically address the neck electively as well by surgery. So there is one modality that needs to be employed for the neck. And of course, we'll talk about more extensive disease as we go on. So when we talk about initial treatment modality selection, there are only 4. Remember, we're talking about initial treatment modality. We are not talking about deciding the treatment modality after the initial treatment has been given. Surgery, of course, which is relevant to all of us because all of us practice head and neck surgery. And of course, the other 3 treatment regimens can also be prescribed depending upon what the site of the tumor is, what the disease biology is, what the setting is. And unfortunately, we offer upfront systemic therapy either in neoadjuvant settings or in the subset of patients who are already metastatic at presentation. When we talk about surgery, the surgery, and this is relevant to the neck. So there is surgery in which the primary and the neck are managed together. Let's say an oral cavity cancer in which you're resecting it and doing a neck dissection and a flap reconstruction at the same time. It's a given that they'll be managed together. There is a philosophy of staged management of the neck and primary as well. By that, we mean that the neck and primary are managed on different days. There is going to be a short-term staging and a long-term staging. An example of short-term staging is TORS. When we do transoral robotic surgery, a lot of us, even though we do synchronous as well, but some philosophies advocate doing a neck dissection first, controlling the pedicles, making sure that there is a seal between a potential pharyngo or a neurocutaneous fistula, and then taking up the patient for TORS 3 to 5 days later. An example of a long-term staged primary neck management is a planned neck dissection. This is a concept that's more or less relegated to the past, but in the age before we had better detection tools like a PET-CT, we used to be doing the initial management and usually chemoradiation, and we used to do a planned neck dissection. Now, what we realized with the planned neck dissection is that viable nodal disease was only present in those small necrotic tissues in 25 to 40% of patients. So the morbidity of doing a neck dissection post-radiation was not really offset by the small survival advantage that we had. Thankfully, that question is now relegated to the past, like I mentioned, because disease detection modalities like the PET are able to detect a much higher percentage of those patients who actually need a neck dissection as opposed to otherwise. There is also another philosophy of the neck when it comes to surgery, which is the upfront neck dissection, in which we address the neck disease upfront by means of an isolated neck dissection, and we give organ preservation treatment or non-surgical organ preservation treatment to the primary lesion. This is typically employed in small volume oropharyngeal and hypopharyngeal disease, mostly hypopharyngeal, which has large volume neck metastasis, where we think that the necrotic hypoxic center of the neck will not be amenable to radiation therapy. So we manage the neck surgically. We give adjuvant therapy to the neck, but at the same time, the primary treatment to the primary lesion. So these are the 3 ways in which we manage the neck vis-a-vis the primary. What is the rationale of addressing the neck in head neck squamous cell cancer? Remember that micrometastasis in the neck happen in greater than 20%. All of you should know this 20% cutoff, because this is the cutoff beyond which we typically recommend elective neck treatment. Whether that elective neck treatment is neck dissection or whether it is radiation therapy typically depends on the choice of modality of the primary lesion, like we've already discussed. And more concerningly, occult metastases have similar prognostic implications as manifest adenopathy. So if a patient has N1 disease clinically, which is CN1 disease, versus a patient who has CN0, but on pathology, he gets a PN1 disease, they typically have similar prognostic implications. One Bulwark paper in 2015, which has proven that, is the De Cruz paper, in which they looked at 2 subsets of patients. One in which they waited, a watchful waiting philosophy was employed, and a neck dissection was only performed if the patient became node positive, versus elective neck dissection being done otherwise. What they realized was if we waited for the neck dissection to be done in the face of recurrence, the overall survival and the DFS was significantly lower, which indicates that elective neck treatment is here to stay, and that elective neck dissection forms a very integral component of the management of head and neck cancer. When do we address the neck electively? We already have just discussed the rationale of elective neck dissection, but how do we decide what neck we are going to address based on what primary? So of course, these three criteria, to put it very basically, help us decide what patient gets an elective neck treatment. The site and the subsite of the disease is going to help us decide elective neck treatment. The T stage of the tumor in a large majority of cases helps us decide as well. And of course, depth of invasion, which has now been incorporated into the AJCC classification. This graph on the right shows you as the depth of invasion of a tumor of the tongue increases, the risk of occult nodal metastasis, manifest nodal disease, as well as mortality increases, which is why we typically need to address the neck in an elective setting. But there are problems, and there are problems which are specific to our subcontinent, and there are problems which are not specific to our subcontinent. The things that are specific to our problems are infrastructure and setting limitations. Appropriately addressing the neck might be an issue in a non-cancer center. All of you, I believe, are experienced proponents in neck dissection, but there is a big gap, and that gap is based on the heterogeneous training level. We try to make sure in our own way that we bridge the training gap. So now there are fellowships. There are MCHs in 6 centers across the country. I saw Dr. Amit in the audience. His center has one of the MCH programs in head and neck surgery. And all of you, especially the younger associates who are attending this, should know that that training is essentially what is going to eventually result in a standard of care for your patients, and therein translate to better patient outcomes. So infrastructure and setting limitations are paramount in a country like ours, where a patient may just come to us after an open neck biopsy, and we have to then address the neck. The problem with that scenario is, based on older literature, and this is from the McGuirk era, we know that an open neck biopsy for head and neck squamous cell cancer is associated with inferior survival. There is also an entity which is very common. We've reported on that in 2014 on concomitant granulomatous lymphadenitis in a country where pretty much all areas are endemic for tuberculosis, and head and neck cancer is also a fairly common entity. It's difficult to sometimes predict as to whether a node which is in the primary nodal drainage basin represents granulomatous disease or whether it represents head and neck squamous cell cancer. Yes, there are clinical criteria. You can look at matting, you can look at the nodes in whatever levels they are. But based on the conclusion of this study, our rate was about 6%. And our recommendation, of course, is to make sure that any node that is not in the primary nodal drainage echelon is FNA'd separately, not just a mucosal biopsy, but the neck should also be sampled. All that adds is the small inconvenience and cost of an FNA to a patient. What it does, it avoids potential neck overtreatment. Detection of micrometastasis is also an issue, and that we'll talk about in the upcoming slides. But yes, it's correct that we have to address a neck electively, but how do we use the data at our disposal to make sure that we're really going to do a neck dissection? So these are the tools that we utilize mostly in cancer centers or in medical institutions or in large volume centers for detection of metastatic adenopathy. Clinical examination, we just mentioned how we differentiate a metastatic squamous cell cancer node from a non-metastatic node. And that detection is preoperative and it's also intraoperative. A fine needle aspiration cytology, a guided fine needle aspiration cytology is typically more sensitive and specific. But in case you have waiting times at your institution, I remember our time in MAMC, and I'm sure it's the same case, I think Professor Ravi would agree, that the waiting times for real-time investigations are much higher because of the huge, immense patient load that you have. So yes, try to get a guided FNA, but don't by any means delay the diagnosis just because you want guidance for an FNA. So an FNA is typically a very important tool for detection of metastatic adenopathy. The solid component should be sampled, and that is something that you can probably figure out on if you're doing image guidance. High resolution ultrasonography has limited role. A lot of intraoral probes and everything are being used for primary, but for the neck, you need an experienced sonologist. And as a head and neck cancer surgeon, when I'm not really seeing the images of my patient, it makes me slightly uncomfortable about planning the treatment. Therein comes in the role of cross-sectional radiology, which is either the CT, the MR, or the PET CT. A CT is, again, this is alluding to a study in oral cancer that we did, taking off from what we initially had discussed about preoperative prediction of extracapsular spread. We found that no modality was really superior, one versus the other, in a subset of about 200 odd patients. But when we look at multi-detector CT, it still is employed the most across the country, and we do the same. We are no exception in that regard. we believe the CT gives us enough information about the primary and about the neck, unless, of course, you are committed to an MR for soft tissue detail of the primary lesion. So for the neck, typically you don't need both. You will only need both if you want a CT done and there is borderline resectability of the neck disease. You might want an MR angio in that instance. You might really want to see the tailing of that area, the T2 levels of that area right next to the carotid, and prevertebral muscle involvement. But for the most part, you'll only need one of these three modalities. The PET is usually not recommended in the initial treatment setting of head and neck squamous cell cancer. It's indicated in specific situations like nasopharynx, where anyway the disease is not being addressed primarily by surgery, and in the hypopharynx with low level 4 and level 5 adenopathy, because the chance of systemic disease is high and you want to systemically stage those patients. But for the most part, CT or based on the primary detail that you need, an MR would be the way to go in terms of detecting cervical lymph nodes that might be metastatic. Coming back to basic concepts, we've talked about squamous cell cancer and what needs to be done and what does not need to be done in terms of our patient selection. But before we embark on neck dissection, it's extremely important to know certain anatomical boundaries. There are multiple classifications in place. I've alluded to one of them, the Robbins classification and the MSKCC classification. We know that there are lymph node levels in the neck. They're limited from 1 to 6. One is divided further into 1A and 1B, and it's divided by the anterior belly of digastric. Ipsilaterally, 2 is divided into 2A and 2B, and they are separated by the spinal accessory nerve, the proximal part of the spinal accessory. 3 and 4 are undivided levels, and 5 is further divided into 5A and 5B, again limited by the distal accessory. Level 6 is your central compartment, which typically does not get involved by squamous cell cancer unless we're talking about larynx, hypopharynx, and cervical esophagus. There are multiple anatomical boundaries which define the neck levels and the sub-levels to help us decide as to what the extent of our dissection would be. In the interest of time, I'll probably go over it. This is a standard literature or a text that you can otherwise obtain, but there are defined anatomical boundaries that you use to define the lymph node levels and thereon. After knowing about the lymph node levels, it's important to know what kind of cancer goes to what part of the neck. So see the table on the right. Level 1 is typically oral cavity and anterior oral cavity. Level 2, 3, and 4 are typically common echelon lymph nodes for oral cavity, oropharynx, hypopharynx, and larynx. Level 5 is typically for cutaneous primaries of the postauricular suboccipital region of the scalp. Also, the involvement of thyroid cancer and laryngeal cancer is pretty predominant in level 5. Typically, there are no skip metastasis from oral cancer in that area. Again, you see these diagrammatic representations as to how the levels are divided and how we choose our neck dissections based on what primary is likely to go to what area. When we talk about neck dissections, there are older classifications and there are newer classifications. This is the AAOHNS classification that we're talking about. And remember, and again, for the younger folks in the audience, it's important to know these definitions, especially when you get asked questions in your exam. But remember that if head and neck oncology is a career that you're willing to pursue, we've moved quite far away from these definitions. We employ a more standard terminology. So in our center, for instance, we do about 250 neck dissections every year. We don't go by supraomohyoid, posterolateral, lateral, and most of the more senior proponents of head and neck oncology advocate the same. So we address the neck based on standardized nomenclature, the levels which are addressed and the structures which are preserved. So typically, a supraomohyoid neck dissection in our discharge summaries and in our operative notes gets labeled as a neck dissection levels 1, 2A, and 3, depending upon whether we address 2B or not, preserving whatever structures are the main 3 non-lymphatic structures are preserved. That gives a great impetus to any other person who's reviewing our notes. He or she knows that the extent of surgery has been standardized. They also know what structures have been preserved. And we also pay attention to mentioning what vessels have been taken, even the smaller vessels, the peripheral vessels, whether the facial was not perfusing, whether it was ligating. Because in our microvascular reconstructive practice, it becomes extremely important. But to talk about classification of neck dissections, remember lateral neck dissection is 2, 3, and 4. We'll have some pictures for you shortly. A posterolateral neck dissection is 2, 3, 4, and 5. A supraomohyoid is 1, 2, 3. There's a term called extended supraomohyoid, which is 1, 2, 3, and 4, which is also referred to as the anterolateral neck dissection. There is a radical or a modified radical neck dissection where all 5 levels except 6 are incorporated, and there's something called an extended neck dissection. You are seeing the differences between the 1991 and 2001 classification. When an extended neck dissection is when the confines of a neck dissection extend beyond the anatomical boundaries defined. There are other classifications as well, and again, you should know this. There is Spiro's 3-tiered classification. There's also Jesus Medina classification, and you must have come across all this: comprehensive, functional, and otherwise. Remember that for the purpose of discussion, try to limit your neck dissection nomenclature to the levels that you address and the structures that you preserve. Talking about how it looks like, this is a classic extended radical neck dissection where you can see the carotid and you can see the vagus right next to it. You can see the phrenic and the brachial plexus. You can see branches of the cervical plexus which are divided because the nodal disease was more posterior, level 5A and level 2B, where you can see the prevertebral fascia has been taken, but the muscle has not been incorporated. You can see the hypoglossal hair and the other boundaries of the neck. Remember that this, however, is the minority at this time. This kind of neck dissection is required, but it's required in a select percentage of individuals only. For the most part, addressing a level 1 through 5 neck dissection has become like this, in which, in addition to the structures that we talked about, the ansa hypoglossi, the proximal accessory, distal accessory, the sternocleidomastoid, the branch of the accessory to the sternocleidomastoid, it's extremely important. They've all been preserved to make sure that there is minimal functional deficit. Again, from a reconstructive surgeon standpoint, it's extremely important to preserve this tissue envelope because that gives a vascular cover over the anastomosis or over the pedicle that we're planning to have, also provides great vessel coverage. For the most part, this is the neck that is defined as a contemporary neck in which we're addressing all levels. We did an audit over 2 years at our institution in which we looked at 550 odd neck dissections, and the proportion of neck dissections in which at least one non-lymphatic structure was preserved was 93%, which means that only 7% of our neck dissections were true radical or extended radical neck dissections. So by all means, you need to be familiar with the classic radical neck dissection, extended radical neck dissection to be able to be oncologically feasible. That being said, if a non-lymphatic structure does not have manifest disease involvement or engulfment, please make sure that you preserve them, and please make sure you train well enough to make sure that the neck dissections are only not defined as radical or otherwise. They should be something in which structures which are non-lymph node bearing are still preserved after giving due emphasis to preservation of fascia, preservation of the neurovascular structures, which are typically the hallmark of an elegantly performed neck dissection. Talking a little bit about selective neck dissections, this is what used to be called the extended SOHND. It's now called levels 1, 2, 3, and 4 neck dissection, preserving all non-lymphatic structures. We moved now to, this is just before the specimen is going to be divided into different levels. We send our levels separately so that our pathologist has more clarity on what kind of levels they have to report on, other than them fishing it out and just assuming where the digastric would have been and where the omohyoid would have been. It's extremely important to do that. The only exception to that would be if you have large nodal disease and cutting through a lymph node will entail actually dividing levels, in which case you send the contiguous levels together and you mark them with sutures like we've done in this case. This is another kind of neck dissection. It's a lateral selective neck dissection, which used to be called earlier. Now it's a level 2, 3, and 4 neck dissection. Again, you can see not only one, but multiple ramifications of the ansa cervicalis have been preserved in the bottom left. The fibrofatty tissue has been raised off its fascial envelope, preserving the prevertebral fascia on the side. This is superior and this is inferior. And the omohyoid does not need to be divided. You can easily skeletonize the omohyoid, go under it. Remember, when you're doing it, especially when you have limited experience in head and neck cancer, you need to be very cognizant about the thoracic duct and where the structures lead on from there. Again, another question that you will typically get, which is now fast becoming redundant, is the types of incisions that you get. These are some of the incisions that have been used historically. This is 1950s and beyond literature. I'd be the first one to tell you that these incisions are utilized in a minority of my as well as most contemporary head neck surgeons practice. The only incision that is used is a single skin crease incision. And the reason for that is that you want to respect the vascular watersheds of the neck, especially in recurrent disease. The only exception would be when incisions have already been done. In that case, you can't make new incisions. You have to respect the existing vascular watersheds. Sometimes you might need to drop a perpendicular in the neck to make sure that you incorporate all the disease. But for the most part, we have not really required that in the large majority of instances. Try to avoid trifurcations. It's extremely important because you might do a great surgery, but you don't want your incision to let you down. But from historical perspectives, the Y, the McPhee, the Schobinger, the double Y, the Conleys, a lot of them are eponymous with the surgeon who conceptualized them. The modified Schobinger, the apron, the half apron, and the H incision, they are all important in terms of knowing how we've come a long way and how neck dissection has evolved typically. Moving on, we've talked about the need to do neck dissections. We've talked about the classifications of neck dissections. Given the half an hour duration of this talk, I had decided not to cover complications and morbidity. Maybe we'll have a couple of minutes at the end. This is going to be a vessel-preserving selective neck dissection performed of levels 1, 2, and 3. So you can see in this case that there's a prominent skin crease. The shoulder roll is under the patient. The shoulder is pulled to the opposite side. This patient already had a CABG, so we really want to make sure that we have we're doing it in good time. You might have noticed the thoracic incision. You're seeing the EJV, good landmarks. This incision is the one that we'll be using. It's a skin crease incision, and a selective neck dissection, in our opinion, can be done with an incision that is as small as about 5 centimeters. So we always make the initial incision with a 15 blade. It's important to do that. We don't use a cautery for incising the skin, but once we are at the level of the subacute, and once we've identified the structures of the which would mean the greater auricular and the EJV, at that time we would typically go ahead through the incision. In this case, we're using a blade for demonstration so that you can see the platysmal fibers decussate, see the retraction that we are giving. All head and neck surgery is about retraction, traction, and countertraction. So currently, you're seeing retraction. The hand on the left is providing the countertraction, and the traction is being provided by the dissecting, by the main surgeon's dissecting hand. When you go anteriorly, this is the submental tunnel. You can afford to take a cautery because the marginal mandibular would typically not be in your way. This is again looking superiorly from inferior, and you divide that tunnel through a relatively smaller incision, and you still would be able to get your soft tissue between the two digastrics, the two anterior bellies, to be able to deliver level 1A. So remember that level 1A, after elevation of the flaps in a level 1, 2, 3 neck dissection, is the first level that we go after. You can see a small lymph node over there, and but not enough for us to consider sending for frozen section. We talked about intraoperative criteria that we utilize to decide whether or not we're going to send a frozen section, whether or not we're going to incorporate the main specimen. Once you pull that specimen back, you identify the ipsilateral anterior belly of the digastric. So the whole specimen is reflected there. And once you raise with your rakes, you're now at that point where you can start dissecting along the lower border of the submandibular gland. This is called the Hayes-Martin maneuver, and this will be followed by ligation of the posterior facial vein, which you are seeing in this location. Again, this is posterior and this is anterior. You are seeing the fascia on top of the submandibular being dissected free. You are seeing the posterior facial vein, which is being ligated, and it will be used along with a fascial flap to retract the entire specimen up. Once you do that, in this case, we're using a harmonic. Again, you can use any thermal device. One common mistake that I've seen our fellows do is to not pay attention. They'll elevate the entire Hayes-Martin flap without really incorporating this lymph node level, and that's important that we do. So the Hayes-Martin maneuver and the subsequent flap, if you are committed to preserving the nerve, and if there's no manifest 1B nodal disease, in that case, you should be able to get all the anterior tissue out of the interface of 1A and 1B, which means the tissue lying on top of digastric. Here you can see that the Hayes-Martin maneuver has been completed. The posterior facial vein has been ligated and retracted for the time being. Make sure you avoid unnecessary retraction. Once the submandibular has been ligated, you retract the anterior border of the mylohyoid. This is anterior, and then you were able to see the lingual as well as the hypoglossal. Earlier in the dissection, you were able to also see the submental branch of the facial artery, which forms the basis of the submental flap. It was ligated in this case because a submental flap was not planned. But for non-squamous histology, we can use it, and that in that case, the neck dissection gets appropriately modified. Now, in this case, we have almost finished the dissection of the submandibular triangle. You're seeing the bed formed by the mylohyoid and the hyoglossus muscles, and this dissection is now on top of the digastric. Remember, the digastric and the omohyoid are called resident friends because you can be on top of them, superficial to them, and you will typically not have any injury to major neurovascular structures. We are not a fan of taking the tail of parotid every single time, but the infradigastric tail of parotid is typically incorporated in our neck dissections just to make sure that you get a full level 1B and a 2A clearance, and you're also able to identify the interface. Here you are seeing the greater auricular and the EJV again, both of which have been preserved. Here, the digastric has been identified, and once you see the retraction, you'll be able to see a silhouette of the internal jugular vein. Now we're looking from up top. This is the omohyoid going all the way down to the junction of level 3. Remember, you don't elevate your flaps excessively. You only elevate till what you need, because otherwise you're going to get skin anesthesia. Following that, you skeletonize the sternocleidomastoid. Here you can see the vascular supply of the middle third of the SCM. You get your fibers retracted posteriorly, use an atraumatic Babcock's. That's what we typically do, till you identify the jugular and you identify the omohyoid in that area. Again, looking superiorly, this is the digastric that's being identified. You do two Langenbecks at right angles to each other, and that helps you identify an accessory, which is usually, in 80% of cases, lateral to the internal jugular vein. You skeletonize the accessory and look carefully how there's a branch to SCM also here, which needs to be preserved, and everything else is dissected off. Here you can see the main trunk, which is going to go posterior into the trapezius, and the anterior branch. You skeletonize the accessory a little bit more, preserving both branches. And in this case, we were committed to doing level 2B because you might have noticed a small borderline lymph node in level 2A. So the philosophy of addressing 2B electively is, if you have borderline lymph nodes in level 2A that you're concerned about, you either send a frozen. If you have a frozen positive, then the standard is to actually do all 5 levels. But if they're suspicious and if they're borderline and you're concerned about micrometastasis, which may not get picked up, in that case, you do level 2B alongside. So in this case, we did that. Subsequently, once the level 2B and 2A is done, then you go down to the prevertebral fascia. These are branches of the cervical plexus. Sometimes they lead into the distal spinal accessory nerve. Make sure that you don't get into a distal looping accessory. This again is posterior and this is anterior. Here you can see the interface between the fibrofatty tissue and the floor of the neck. You dissect, and your retracting assistant will have to do a good job so that you see the vagus first. You should be able to see the vagus before you see the carotid and the jugular in this case. As you can see here, you dissect the vagus because you don't want to just see the jugular and then come on top of it, because that way you leave lymph node levels in this tissue behind. Once you're done with that, you are dissecting now the inferior most part of the neck, and you are able to get tissue of the anterior belly of omohyoid. Another common mistake that I've seen trainees do is to go very anterior, therein damage the superior thyroid vessels. It's not required. It is something that should only be done if you have manifest nodal disease that is positive in this area. Again, looking from up top, here you are dissecting the rest of the carotid sheath, and you're bringing up the specimen as it comes up. And as you can see, there is no fibrofatty tissue in levels 1, 2, and 3, which we are committed to dissecting. This is just a demonstration of how you can address level 4 also with an intact omohyoid. So don't be in a hurry to take omohyoid every single time if you're doing a level 4, because there is some data on hyoid excursion being affected if you take an omohyoid. We are now getting to the anterior most part of the dissection. Typically, a jugular vein is addressed from posterior to anterior because there are less tributaries on the posterior aspect and there are more tributaries on the anterior aspect. Another reason that you want to do it this way is because you want to preserve the appropriate tributaries. In this case, it was an oral cancer, so we wanted to do microvascular reconstruction in this patient. So as you can see, you're retracting, and you'll typically see a relatively constant common facial vein heading up over here, and you will see the ramifications and the tributaries thereof. Just below the common facial vein, you see the hypoglossal, which is here, and this is the digastric, just to orient you again. The common facial never needs to be taken, especially in patients with recurrent cancer, in which there is no nodal disease in that area. Once we do that, we retract the jugular posteriorly to get the last packet. That's another common mistake that we've seen. There is enough data now on where the lymph node bearing tissue or the fibrofatty tissue tends to get left behind. So please make sure that you pay appropriate cognizance to all those areas. Now your common facial and your other branches are also skeletonized. You can see the ANSA heading up, and you can see the specimen pedicled only anteriorly. Sometimes you might not need to preserve such an extensive tree of the common facial. There are multiple classifications on common facial anatomy, but this is something which would enable you to not only preserve your neck dissection for your microvascular colleagues, but also place clamps appropriately. Generally, you put your clamps on the vessels that you've decided. We've moved more away towards doing end to side IJV anastomosis. Is also helpful to have multiple options. Like I discussed, once you deliver the specimen, the surgeon is the best person who has an idea about what levels we are addressing. As long as there is no manifest nodal disease crisscrossing multiple levels, you should be able to address it, label them separately, and send them. Remember that these will be submitted in buffered formalin. The last part of the neck dissection, remember this is single skin crease. We're using a Jackson Pratt, and the Jackson Pratt typically would provide adequate level suction, especially if you're using any anastomosis in that area. You go ahead and do a platysmal suture. A platysmal suture is important, and in this case, because the patient was cosmetically concerned, we did a subplatysmal and just one single drain. And this is how the incision looks like. It's about a 5.5 centimeter incision, and it's covered by one single length of steri strips. So just one representation of how we do it, and how we are able to tailor our practice to make sure that we do a justifiable job in treating these patients. Hitinder, how are we on time? There is a 4-minute video I wanted to show. Should I go ahead and show it, or should I not do that?
Sir, you can show it.
Dr.
Sir.
Shamit, you can go ahead.
Okay, great.
You can take 10 minutes extra.
Okay, great. So does that mean, Dr. Ravi, I have 10 minutes from now?
Yes.
Yes, sir, you can have.
Perfect. So what we'll do is we'll discuss one recurrent neck scenario. And I think there will be enough experienced oncologists in the audience also. And for the faculty, I thought that might be helpful. So this is a patient who had multiply recurrent head neck squamous cell cancer and had disease in the root of the neck. This is the tip of the iceberg, I would call it. So this is the manifest disease that we had to resect. And this was the skin component. We marked out a single stage deltopectoral flap. It's an easy flap to do, and it's right in the vicinity. And multiply recurrent cancers typically have their thing. If you looked carefully in the initial setting, the patient also had an anterolateral thigh free flap for oral reconstruction on the right side. But let's focus on the neck dissection at hand. Remember, this is a completely dissected neck. Everything has already been done. The best way to do is to define the limits first. This is the medial limit of the neck, and this is PET-based planning basically. When we are lateral, then we identify the brachial plexus early on during the dissection. Remember, the jugular has been taken, so we identify the subclavian vein early as well. So looking from top to bottom, you're seeing the brachial plexus, you're seeing the subclavian. You need to identify those two structures before you do a claviculotomy. In this case, the clavicle will be mobilized and removed because it is stuck to the disease in the root of the neck. And here you can see the sternoclavicular joint capsule and the articular disc that you have. Again, it has no relevance currently, but you try not to leave exposed bone in a multiply radiated area, so you can choose to leave that capsule if it's not close to humor. This is the IJV subclavian junction. After removing the clavicle, you can access it. Remember that your interventionists typically use that for central line insertion. So that's the area that you need to ID. Again, you have to be extra careful about the thoracic duct. Once you come in this area and the subclavian is over here, you see your transverse cervical vessels and you identify them early. This again is repeat carotid space dissection. Again, we are assuming that the carotid space has already been dissected in this patient. So we have to skeletonize the vagus completely so that we are able to get good control. We do have to ligate the IJV again in this case to be able to make sure that we get adequate distal control in this area. And here you can see the ligated TCVs again, the transverse cervical veins. You can see the tumor coming intraluminal into this area. And this is the lower part of the subclavian as it leads into the brachiocephalic, so that will be preserved. If you see this now, you have your ligated transverse cervical vessels over here. We are looking superior to inferior. We have the common carotid here. The central compartment did not need to be dissected. Here you see the vagus. You see all the trunks of the brachial plexus which are delineated. Again, the distally ligated transverse cervical, the subclavian over here, the lateral claviculotomy, which was mandatory for resection of disease. And of course, the medial end of clavicle you're not seeing because the manubrium is the structure that's over there. When you see this, again, it's extremely important, like we discussed already, to find out where the low end of the IJV is so that your thoracic duct can be identified appropriately and preserved. And you can see the silhouette of the phrenic here as well. Remember that there are somber outcomes in these patients. So fancy reconstruction is not something that we do very often in these patients. It was easy for us in this case. This is a modified deltopectoral. We used a perforator which was here. We did not need to divide it. Again, there's no point for following a compartmentalized philosophy in reconstruction. The more perforators you can preserve, the better it is, and it will typically form single vessel coverage. Since it's a female, she will not need a skin graft, and this is about 2.5 years back, if I remember correctly. And the patient had a subsequent recurrence, not in the neck, but otherwise. But remember that there are select situations of PET negative disease where you might choose to go ahead with a more extended dissection, which does not have the morbidity that you would typically anticipate in a recurrent neck dissection setting. This patient, again, you can see that the patient is already tracheotomized. The tracheotomy is epithelial, so it's from an old disease. Here you can see the anterolateral thigh free flap, which has been done for oral cavity reconstruction in the past as well. But I think Amit spoke about reconstruction, so I will not go too much into it. So this is how we typically address manifest nodal disease in the face of recurrence. But remember that the morbidity of resection should not be unacceptable. The disease-free interval cannot be too small. Otherwise, you'll not really be able to do much benefit to these patients. But now we have a series of about 350 odd salvage resections that we have done for nodal as well as primary disease. And the results are not as disappointing as you would think. Based on data from Goodwin, Adelstein, and other people who published on recurrent in a level 1 or a level 2 evidence setting, we know that the 3-year overall survival is about 35%. And for a patient where we're aiming for a symptom-free survival, it becomes important. The last thing that I wanted to cover about the neck is the central compartment. And it's important that you know about your anatomy. Now, we don't want to make it a lecture about thyroid. I believe that has already been done by Dr. Varghese probably yesterday. But this would be focusing on aspects of management of the neck, because neck dissection is our topic, within the realm of what we do recurrently. Remember, as all of us know, thyroid cancer is something which has a great prognosis, and we typically hope to be able to achieve a good outcome in recurrent thyroid cancer to the extent of about 80% 5-year DFS, sometimes even higher in favorable histology. So we'll talk about one patient where a central compartment was redone. A central compartment neck dissection is something that all of you should be familiar with, especially if you're treating thyroid cancer. But sometimes you get thrown a googly. You get a recurrent disease in the central compartment, and you're now concerned about parathyroids. You're now concerned about your recurrent laryngeal nerve because there's only fibrosis over there. Tiger country, as one of my program directors called it. A redo central compartment also lends itself very well to defining limits, which is why the title of this video is Defining Safe Limits of Redo Open Central Compartment Surgery. Remember, redo, we are a robotic center as well, but we would not do a redo neck dissection of the central compartment with a robot. We typically use an incision to do that. In this case, just to give you some clinical details about the patient, this patient was a middle-aged female. She was retrospectively staged a low-risk DTC, and she had total thyroidectomy at an outside center. Initially, when she came to us, we did an initially stimulated thyroglobulin, and that was okay. We did a radioactive iodine scan because there was raised anti-TG antibodies, and it was normal. But 6 months later, we repeated it, and the thyroglobulin was stable, but there was paratracheal nodal involvement. We did anatomical as well as scintigraphic workup, and the ultrasound as well as the radioactive iodine scan showed uptake in the same central compartment. So the challenges that we had was what incision to utilize, how to preserve the recurrent laryngeal nerve, how to preserve the parathyroids, and also identify all disease foci. So the plan was a disease-directed left central compartment clearance by delineating the limits. And you'll realize at the end of this video that it is something which is not tiger country. It lends itself well to identification. So sometimes in females, the scar migrates pre-sternally, but in this case, we were lucky it had not done so. So we utilized the same incision as had been utilized at another center. Remember, there's no raphe now, but there's a neo-raphe. So you identify your neo-raphe. The anterior jugular veins might not be a landmark because they might have been ligated, but if they are, then you're lucky. You get to your neo-raphe and you start skeletonizing your muscles of the straps on the left side, which is your anterior limit. We would typically take sternothyroid. So the sternohyoid is your anterior limit, which you're identifying here. At some point, when you get lateral to the trachea, you want to make sure that you shift to a bipolar instead of using cautery because you don't really know. You have not defined the limit of the recurrent laryngeal nerve yet. Like we mentioned, you take the sternothyroid, which is why the anterior limit becomes the sternohyoid. We are looking superiorly and inferiorly, just to orient you again. Now we are dissecting the sternothyroid to get to your lateral limit. And the lateral limit of your dissection, as all of us know, is the carotid. So you identify your great vessels as part of the lateral limit. So I'll reiterate, You identify the sternohyoid first through your neuraphae. You divide your sternothyroid, and then you go lateral when you identify the carotid. This constitutes the lateral limit. And because you want to look a little bit at the lateral component also, you're seeing the jugular and the vagus. This is only for demonstration purposes. The dissection happens medial to that. You define, once you've identified your lateral limit, you go down on it and you identify your inferior limit. And the inferior limit is the brachiocephalic artery. This is the brachiocephalic artery. Like we mentioned, in this entire video, we'll be looking superior to inferior. There are some tributaries of the innominate vein which will need to be identified and taken. In this case, we'll be taking it once we deliver the specimen. The medial limit is easy. The medial limit is the trachea, and you can be on top of the trachea and just be careful and cognizant about not compromising its vascular supply. So now we've identified our limits. We have not identified our deep and our superior limits. We'll talk about that. This is the thymus, which is typically incorporated in a level 6 dissection when it is really coming up into the neck. You can see the innominate, and you can see it leading into the right common carotid. It's a high riding innominate over here. Here you see a lymph node, and you want to distinguish it from parathyroid. Here there's really no diagnostic conundrum. Morphologically, it looks like a lymph node. But if you have any confusion, you can just take a small sliver while leaving it perfused, and you can send that sliver for frozen section analysis. Once these limits are identified, the next limit is the cricothyroid joint. Remember that for redo central compartment surgery, the best landmark of the recurrent laryngeal nerve is the cricothyroid joint. As you could see, we were dissecting the nerve in that location, and see how banged up the cricothyroid is. It doesn't really look as good as it looks in a virgin thyroidectomy. You get small branches of the cervical plexus and the ansa, and you divide that. And this is the cricothyroid joint again. This is the patient whose recurrent has been skeletonized. The recurrent is completely being skeletonized here, and the specimen is transposed from under. If you can avoid 360-degree skeletonization, it's okay. But for the most part, you will have to do a 360-degree skeletonization in a recurrent disease setting to be able to make sure that you remove all the disease foci. Remember, the way we distinguish parathyroids from lymph nodes is usually morphological, and you can use frozen section in that instance. This is our delivered specimen. As you can see, the lymph node packets are here. We saw 2 positive lymph nodes at least. Eventually, the patch showed 4 positive, and you saw the thymus as well. And you can still see that the vasa nervorum on top, on irrigation, is still intact. So just to encapsulate this, I know we were talking mostly about head and neck squamous cell cancer, but I wanted to, especially for the younger colleagues, take it a bit further and talk a little bit more about central compartment dissection when we might think that we might not be able to handle it. Remember, in any city that we might practice, there's always a senior colleague around the corner. So if you're doing recurrent disease and neck dissection for recurrent disease, make sure you enlist the expertise and the experience of your senior colleagues. That brings me to my encapsulation last slide, and hopefully I'm within the 10 minutes that Dr. Ravi gave me as well. Remember that neck dissection for head and neck cancer has specific indications which are driven by site, stage, and histology. And these statements are generalized. There are exceptions. Having said that, these would be the take-home points that I'd want all of you to take from this presentation. Also, it's notable that in elective settings as well as therapeutic settings, and these encapsulations apply to head and neck squamous cell cancer, survival benefit has been proven in high-quality evidence, including the evidence that has come from our subcontinent. Also, the treatment has to be individualized while keeping in mind the evidence that we currently have. So a disease-directed and compartmentalized approach to neck dissection is integral to comprehensive head and neck cancer care. You don't want to be in a position where you do an incomplete neck dissection and have to deal with recurrences in the neck, where you could be managing it in a much better way. And this is a window to the future. We are currently looking at, I talked about microscopic and macroscopic E&E. We also should be talking in another talk, maybe in MAMS ENT update to the next edition, about disease biology and how the biological markers of aggressiveness dictate how we can offer our patients individualized therapy. And neck dissection morbidity is a topic which has not been covered as well as it should have been in contemporary literature. I hope that all of our colleagues, young colleagues, contemporaries, would be able to add much more to data on shoulder dysfunction and other specific morbidities that we get from neck dissection. Thank you so much for your attention. And again, it's a pleasure to be part of this setting. I think Dr. Ravi, his team, I see Professor Ishwar there as well. I think all of them just do a great job every single time. I saw Professor Rathore earlier in making sure that these updates and knowledge sharing continues despite whatever change circumstances we are part of. And you guys have proven yet again, just like so many of our colleagues and ourselves, that you can be remote and still share more knowledge. I think knowledge sharing has actually increased over the last 8 or 9 months. And congratulations to all of you for a wonderful meeting. And thank you again.
Thank you very much, sir, for an interesting talk. And now I would request faculties for any queries.
मेरा वो चला ही गया यार.
Thank you, Dr. Shamir. It was an excellent talk as usual. I have just one query in the chat box because you have not actually covered the complication. How do you manage kite intraoperatively and postoperatively? So that is the question.
Yeah, no, and again, I was hoping, like I mentioned earlier, that some morbidity discussion would come up. So the best way to treat a chyle leak is to avoid a chyle leak. So we talked multiple times when we were discussing the videos as to where the thoracic duct comes in from, especially in the left neck. The cisterna chyli is T12. At T4-5, it crosses over to the left side of the neck. And the area where we are concerned about is where it loops deep to the jugular and then loops and joins the internal jugular subclavian junction. That area has to be dissected very carefully. When we are dissecting that area and you have a big node in that area, and that happens very often in thyroid cancer as well as head neck squamous cell cancer. When we're dissecting that, we'll see some radical leak, but you will not see a full-fledged chyle leak. Some people tend to ignore it. The most important thing is to identify it at that particular point of time instead of waiting for the end of the neck dissection and the hemostasis to do it. Yes, if the node is in the way, then you finish the dissection of those nodes. What we normally do is we put a small hemoclip on top of it, and then we get back to it once we've addressed that. Intraoperative identification is paramount. The two ways in which we can pick up a latent chyle leak is one by Valsalvas, because all of these surgeries are done under anesthesia, so it's possible to do that. There is also something called the Zernia maneuver, in which we do abdominal pressure on the epigastrium, and we do that every time now, routinely. There is some evidence that the Zernia maneuver is additionally helpful. You do anteroposterior abdominal pressure, that increases the pressure on the cisterna chyli, therein making a latent chyle leak manifest. If you find it, then at that time, you want to use a suture which incites an inflammatory reaction of fibrosis. Typically, silk is what all of us go by. We don't like ligating a manifest chyle leak with a clip. But yes, if we've identified a good, robust thoracic duct, in that case, we don't go after silk because silk is typically a suture ligature that we use. We don't really want to start a radical leak. So if you identify a thoracic duct which so far has not leaked, then we use multiple hemoclips on that, and we use SS stainless steel clips. In case the leak has happened, then we always use a suture ligature with silk. Whether or not you use 2-0 or 3-0 will depend upon the size of the radical that is leaking. We talked about the maneuvers already. Now another important aspect is management post-operatively. Intraoperatively, the last thing that we need to know is if our maneuvers so far have failed to control it, there is always vascularized muscle around you. So make sure that you put some vascularized muscle. There is some evidence on TISIL and BioSeal. We typically don't use that. We've not needed to, as long as you pay attention to the intraoperative measures. Now, an undiagnosed chyle leak, despite all these measures, is also a reality. It can happen in 1 to 2% of neck dissections. If it happens, then you have to categorize your chyle leaks into low volume and high volume chyle leaks. If it's low volume, it will typically resolve with a medium chain triglyceride diet. You might want to send your drain output. If you still have serosanguinous and you're thinking there is some milkiness, but you're not really sure if it's a flocculent aggregate in a drain or whether it's actually chyle, you can send your drain output for chylomicrons or by triglycerides. Chylomicrons are not available everywhere, but you can send triglycerides to prove the diagnosis. A low volume chyle leak, depending upon what you read, is either below 400 or below 600. We take a 400 criteria at our institution because a lot of these necks already have had anastomosis, so our threshold for intervention is very low. So we take 400 as a low volume chyle leak. You change the patient's diet to a medium chain triglyceride diet. Any dietitian would be able to do that. Even we can do that. A coconut oil based diet is something, an MCT oil based diet. Now there is something called MCT oil available. So we can actually make it an oil diet. And pressure dressings if your surgical resection allows you to do that. Taking the drains off suction or putting them on half vacuum pressure is also good. Don't put them on complete suction or fully charged drains. If that fails to resolve, then you have to intervene. And again, vascularized muscle is an option. Again, TISIL, BioSeal are options. What we've realized is we've now audited about 1,200 neck dissections done at this institution. The neck dissections where we had to go in for a chyle leak were only 3 of them. And it's important that you have all these measures that we have in place to make sure that we avoid it. there are very few high volume Kyle leaks that will actually require re-exploration. But yes, sometimes when residents are operating, sometimes when fellows are operating, there is always going to be a little bit of a training gap, and we talked about that. One last thing about Kyle leak management is the use of octreotide. SMS Jaipur has a good paper on 19 odd patients, if I remember correctly. We use octreotide and we go up to about 100 microgram TDS if there is a recalcitrant Kyle leak, and we use it in low volume if there are no specific contraindications. It's a molecule that we are generally not familiar with, but our medical oncology colleagues are very familiar with, so they are actually okay with us giving up to 600 micrograms also. We've been able to do that in only one patient. But remember, you have to do everything one, before the patient is nutritionally depleted from a high volume Kyle leak, and two, you have to employ your conservative measures in succession. You need to have an algorithm to make sure that you are able to avoid further leak in these patients.
Shamit.
Yes, sir.
Great presentation as usual. You are set a very high standard. I had a case in Nepal where almost 2200 ml was the Kyle, and we just managed conservatively. I re-explored, again it recurred, and then ultimately with the pressure bandage and kept tetracycline powder there, and with pressure we could manage. Luckily I was able to save my skin. There is a term like supraselective neck dissection. You talked about selective. What do you say about supraselective neck dissection?
So that's a very loaded question, and before I get to that, I will in
exam the PGs are given that kind of question.
So, but to add to that, congratulations to your team to be able to control such a high volume Kyle leak, because 2200 is enough to nutritionally deplete a patient within 2 or 3 days, regardless of whatever we do. We might use TP and we might use MCT. One option is that if you have a good thoracic surgery team, a lot of them are able to do a VATS ligation. Initially, it used to be a thoracotomy, but that's too morbid, in my opinion. Any center that's doing video-assisted thoracoscopic surgery will typically be able to identify the cisterna chyli, and that has been shown to have enough benefit in a series of situations. All of them are anecdotal because it's a rare scenario, but yes, for the benefit of the PGs, because they will probably not have the level of your experience in case they're by themselves. A very high volume Kyle leak, you want to consult your thoracic surgery colleagues. And like sir mentioned, some talcs and fibrosing agents, tetracycline, bleomycin. As long as there are no contraindications, you can use it over the root of the neck. To come back to super selective, sir. Super selective neck dissection essentially arose in the age when the PET was in its ascendancy, because we were able to identify positive nodes with a very high negative predictive value of more than 95%, and those results have remained consistent across meta-analysis. The philosophy was to just address one level, or just to do a little more than an excisional biopsy to be able to do that. We do it in patients with recurrent disease, and we're only talking about head neck cancer now, head neck squamous cell cancer now. In recurrent disease, when there is isolated and focal FDG uptake in only one level, where a nidectomy would not have the morbidity that a full neck dissection would have. The Tata group has now taken out some papers on super selective neck dissection, which are site specific also. They are worth reading because they avoid a selective neck dissection in a patient who does not have manifest nodal disease. In the elective setting, there is no role of super selective. In recurrent disease, low volume disease, well isolated disease with focal FDG avid uptake, in that case, there is a role, but the long-term data on that is still lacking. So it has to be done with caution, and it has to be done by very experienced surgeons.
Like nodes, group of nodes which are not addressed, like retropharyngeal nodes. Have you ever happened to address them somewhere?
So tomorrow we are doing unknown primary who has a level 2 metastasis, squamous, and he also has a high paranasopharyngeal, paraoropharyngeal region, which is off the pharyngobasilar fascia, sitting on the carotid. The experience in retropharyngeal and parapharyngeal lymph node dissections is limited for any subset, because we typically see them either in unknown primary, or we see them in lesions where the primary has unpredictable patterns of nodal drainage, like the maxilla, for instance. If we have to address them, it's much better to involve our non-surgical colleagues, because they will always have to give adjuvant therapy to sanitize that basin. We might go into the space of Gillette, we might remove nodes of Rouvier, but it's not possible to do a full retropharyngeal without perforating the pharynx, which we try to avoid. Since we are now a robotic institution, I think in one of the upcoming meetings, there is also a talk on parapharyngeal robotic dissection. So there is a definite role. It avoids the mandibulotomy. in a fixed percentage of our patients. But parapharyngeal lymph nodes are easy to access, especially if they are in the pre-styloid parapharyngeal space component. Then you can just do a transcervical approach. If they are contiguous with parotid, then you have no option but to do a transparotid approach. Retropharyngeal, yes, you can probably resect the ipsilateral space of Gillette. Our experience has shown that if you really push the envelope and try to go to the opposite side from the same neck incision for a retropharyngeal resection, the problem is that you end up causing too much pharyngeal edema, which results in long-term tracheotomy dependence. So yes, a unilateral retropharyngeal neck dissection can be done. A unilateral parapharyngeal can be done. You might use the new technology at your disposal. You might not. But usually there are areas that we can clear. The problem is if they happen in a recurrent setting in an already dissected neck, then the prognosis is very poor and the patient has to be counseled appropriately because it's essentially a waterfall into the mediastinum. Once the disease has gone into the retropharyngeal lymph nodes, the superior mediastinal lymph nodes will get involved and then the patient will become metastatic.
Thank you. Great talk.
Thank you, sir. Thank you. Means a lot. Thank you.
Thank you, sir.
Dr. Samit, one question, very nice talk.
Thank you. Thank you, Amit. Thank you.
What do you do for the carcinoma, squamous cell carcinoma of the upper alveolus or hard palate for the nodal N0 node?
So if it's, I'll give a T-specific answer. If it is a T1 hard palate or a T1 maxillary sinus, and we have already proven by the appropriate radiology that there is no manifest disease, then we don't do a neck dissection unless we are committed to a free flap reconstruction and we have vessels, we need vessels in the neck. For T2 or higher, the problem is slightly more. I would do my best to try to make sure that I assess. If it's a lateral disease, I want to assess the intraparotid nodes. If it's central disease, I want to address or see the retropharyngeal nodes. If it is manifest nodal disease, then depending upon what kind of access I'm going to get from the maxilla, I would probably address retropharyngeal at the same time. But like we just discussed, even a T2 patient in that case would be a candidate for adjuvant therapy. Electively, we don't address retropharynx, if that's your question. Electively, there is no role of doing a retropharyngeal dissection in a patient, even with maxilla, even though we know that it's one of the primary echelons. If we are anticipating retropharyngeal disease, we're looking at least a T3 primary in which adjuvant radiation therapy would anyway be required. In that case, I would just speak to my non-surgical colleagues and ask them to focus on the retropharyngeal lymph node basin as well.
Because there are some literature saying about the alveolus or upper alveolus and the hard palate going for the selective neck dissection in the advanced cases.
So, you know, so in our experience, our T1, T2 hard palate in a young patient will typically go for free flap reconstruction. I don't know how your institutional experience is, but we typically like using vessels in the neck. I'm not very happy with superficial temporal. So in that case, especially since for T1, T2, we're talking about a radial osteocutaneous, and I'm speaking into the territory of your talk, but I think it's a combined answer. If it's a T1, T2 hard palate or upper alveolus, and I'm committed to giving the patient dentition, then I'll use a radial osteocutaneous flap to at least give that contour of the premaxilla, especially if it's anterior disease. In that case, my pedicle is going to be long enough to go into the neck. So I will do a neck dissection for that purpose, and I'll do a 1, 2, 3 neck dissection. Of course, that is after the appropriate preoperative radiological modality to do it. If it is a T1 hard palate, let's say it's in the midline T1 hard palate, in that case, I will not do a neck dissection if my radiological workup does not show any lymphadenopathy, because those patients are well rehabilitated with obturation. Also, the unpredictability of nodal drainage is quite high. I would not do a bilateral neck dissection for a T1 hard palate, for instance, because the elective metastasis is anyway less than 20%. For T2 or higher, I agree with you. I would consider a selective neck dissection. T3, T4 will typically get it anyway because that breach is then crossed. Like I said, if it's lateral upper alveolus, I will always try to pay specific attention to intraparotid lymph nodes because you know that the drainage goes that way. If it's central hard palate, I would always be more concerned about retropharynx and of course the submental, which we're going to address anyway.
Dr. Shamit, can I ask one question which could be exactly not in the purview of neck dissection? But the thing is, since we have not had any radiotherapy session in this PG seminar, so what is the this latest thing that proton has come in for the treatment? Dr. Sapna came to your center last year when we had that beautiful head and neck cancer seminar.
Yeah.
So has proton therapy had any bearing on the surgical prognostication or on the some changes in the way we deal with neck, especially these retropharyngeal and the parapharyngeal areas, the soft tissue sensitive areas? Has it caused any changes statistically so far in your approach to these patients?
I'm glad that you asked this question because I think proton beam therapy is the new kid on the block, and probably it's good to clear the air to some extent. So I think it is very relevant, and thank you for asking that question. So the philosophy of heavy particle radiation therapy, be it neutrons initially or now protons, is based on something called the Bragg peak, which the protons are. What it says is that the therapeutic effect is maximum at the Bragg peak, and again, in the absence of a radiation oncologist in this forum, I'll probably, and if there's anyone, then they can probably opine on that. But in case there aren't, we are assuming that there aren't, so we'll try to answer. Heavy particle radiation therapy is supposed to have therapeutic benefit also, not just obviation of side effects. Remember that there is no randomized controlled trial for IMRT, IGRT for photons also in terms of therapeutic efficacy. There is now randomized evidence for toxicity obviation, but protons claim to be the particle which can probably change it all. Historically, protons have been used in chordomas and chondrosarcomas of the clivus. And the large part of that was because the skull base needed that radiation, but again, the dose limit of photons was that way. Now, protons are being advocated beyond these rare histologies into sinonasal tumors and areas of the parapharyngeal space. Just because we have proximity to the skull base, so they believe that they can get enough therapeutic efficacy while obviating the side effects of treatment which photons were historically associated. The limitations are availability, of course. There's only one proton therapy center currently in Chennai in the country. Hopefully, Tata will be coming up with a second proton therapy center very soon. From an administrative standpoint, the investment is staggering. It's huge. If I understand correctly, it runs north of 200 crores. The cost that a patient has to bear is also significant because it has to be offset in a private center. So, to the best of my knowledge, I think there was some exchange going on in a social media group where Dr. Sapna and a couple of other head neck surgeons were talking. It's 25 to 30 lakhs per patient. And the kind of patients that we see in Punjab, because we are draining a lot of area north of us as well, we don't really have that mindset. I've committed to Sapna that, if there are patients, then we'll probably have them benefit from the expertise. And they are a very good team indeed, the Apollo Proton Cancer Center. But I think that that cost trumps everything in the current scenario. Even when I was in the US, I was part of a neutron therapy center, Wayne State. But then the heavy particles were just so toxic that neutron therapy has fallen away now. Protons have that Bragg peak advantage, so-called. Now there's Indiana, Loma Linda, and a couple of other institutions which really pushed it. And now there are, if I understand correctly, about 10 to 15 proton therapy centers in the US. Anything that's covered by insurance is obviously worth. So I'm really looking forward for some insurance schemes which will be able to cover proton therapy. Otherwise, I don't see wide applicability, at least for the next few years.
Okay, I think we have had enough discussion on neck dissection, and we have actually exceeded the time allotted to it. Thank you, Dr. Shamit, for excellent presentation and discussion. We have our next speaker, Dr. Ramandeep Singh Vark. Dr. Hitendra, you can introduce Dr. Ramandeep.
Thank you, sir, for an interesting talk. Now I welcome Dr. Ramandeep Virk, sir. He's a professor in PJ Chandigarh, and his special interest in surgery is in endoscopic sinus surgery and otosclerosis surgery. Sir, would you please start with the proceedings?
Hitendra, your voice is not very much clear, but let me introduce Dr. Ramandeep. Dr. Ramandeep is professor at PGI Chandigarh, and he has special interest in endoscopic sinus surgery and also otosclerosis. So I invite Dr. Ramandeep Singh Vark to start his presentation on CSF rhinorrhea. Right, that is a very important topic for our postgraduate students, and I'm sure Dr. Ramandeep Vark will present a good presentation. Thank you very much.
Thank you, Ravi. Good afternoon, everyone. Let me start my slides. Okay, is the voice clear and is the...
Yes, Dr. Raman.
Okay. Good afternoon, everyone, and everyone who is logged on. I am Ramandeep Virk. I'm an ENT surgeon at the PGI MER Chandigarh. My talk today is on CSF rhinorrhea. So I'll be trying to make it a very basic talk so that it gets easy for you to understand. I will not be touching in too much theoretical aspects because theory is something which you guys and girls can go back and read from your own textbooks. I will also be showing a couple of videos, time permitting, of the common areas where CSF rhinorrhea occurs and how we in our institute tackle them. So classification, just basic, based on onset, there is a classification called Omaya's classification, which for many years it has held its own sway. Omaya divided it into traumatic and non-traumatic. Traumatic could be accidental, acute or delayed, and it could be iatrogenic, acute or delayed. Non-traumatic could be either high pressure or normal pressure leaks. High pressure is usually from tumors or hydrocephalus, and normal pressure leaks from congenital anomalies, etc. So why do we worry about a CSF leak? It is a serious and a potentially fatal condition. That's why we worry about it. No matter the underlying etiology, what happens is that there is an osseous defect at the skull base. So whether it is traumatic, whether it is spontaneous, so why does the CSF come out? Because of a bony defect in the skull base through which the CSF starts. This results due to tear in the dura and the arachnoid, and it communicates with the nasal cavity and the paranasal sinuses. So trauma, takes up the big bulk of all CSF leaks. About 80 to 90% of CSF leaks are due to trauma. Major head trauma, if it happens, 2 to 3% patients will have a CSF leak, and if there's a skull-based fracture, 15 to 30% patients will have a CSF leak. So what are the most common sites for CSF leak? This is taken from a Journal of Neurology Surgery, 2013. Cribriform plate accounts for around 33%. Sphenoid also accounts for around 33%. Ethmoids for 22%, and frontal sinus for 11%. So the question arises, why do most CSF leaks occur in the interior cranial fossa? Well, the answer for that is that dura in this area is tightly adherent to the thin skull base and easily torn with injury. So whether the injury is a road traffic accident or it's iatrogenic, a surgeon operating, the bone is so thin and the dura is so tightly adherent that it is very easy to traumatize this area. And like I said, the cribriform plate is thin and fragile, and it is covered only by the arachnoid layer and missing a true dural investment. And delicate arachnoid layer easily violated by even a small fracture or with instrumentation when we are operating. So what are the most feared complications? So CSF leak increases the risk of meningitis tenfold. So meningitis is a feared and a dreaded complication of CSF leaks. And overall, about 31% patients have a risk of meningitis before surgical repair. Recurrent meningitis is seen in 12.5 to 50% with a 29.4% neurological complication rate. And there's a risk of 1.3% per day in the first 2 weeks after injury, and 7.4% per week in the first month after injury. So if we look at the cumulative risk, there is a cumulative risk of 85% at the 10-year follow-up. And now risk of meningitis is 5 to 10% with modern techniques and modern surgical methods. And other complications like pneumocephalus is about 20% in CSF leaks. So pneumocephalus normally happens like a ball valve mechanism. There is an opening in the skull base, and the air starts to get sucked in from that osseous defect and goes inside. Pneumocephalus mostly don't trouble, but sometimes large pneumocephalus can be troublesome. And how do leaks get closed? We see that we get a lot of trauma patients, and many times the leaks just spontaneously close. So they probably get covered by a layer of fibrous tissue or regenerated nasal mucosa, since the dura mater does not regenerate. Now, this is the key. The dura mater is not going to regenerate. Even when we are going in and repairing it, we have to make sure that the graft we put, whether it's by underlay or the overlay technique, and the fat we plug in, the nasal mucosa tends to grow over it and around it and seal off the leak. Then we come to something called a spontaneous CSF rhinorrhea. Majority of us here would have seen, tons of CSF rhinorrhea being operated. And what exactly is spontaneous CSF rhinorrhea? Spontaneous CSF rhinorrhea occurs in the absence of any inciting event like trauma, congenital skull-base malformation, skull-base defects from tumors, etc. So a normal patient will suddenly start having white, clear, watery fluid running from one side of the nose. So that is how these patients present to us. And there is a strong association between spontaneous CSF leaks and idiopathic intracranial hypertension, which is a disease which is associated with increased intracranial pressure without other causes. So what happens? There's a sustained increase in the intracranial pressure. There is remodeling and thinning of the skull base, and ultimately it's nature's way of reducing the pressure in the brain. So a defect takes place, the CSF flows out, and the pressures return back to normal. And 30% of patients with spontaneous CSF leaks will have multiple skull base defects. So what are the most commonest site of leaks? This would be purely my data. I'm not talking about international data. Various institutes, various places which have done studies, they can have, depending on the types of cases that are being referred to you, your data can be different. The most common leaks we have seen, or I have seen, are spontaneous CSF rhinorrhea are from the cribriform plate. So that forms the main bulk of my surgical workload. We have had leaks from the lateral lamella, about 12 cases. I have not seen a spontaneous leak from the frontal sinus till now. I've seen 11 from the sphenoid groove. I've seen 16 cases of lateral recess in the sphenoid sinus in the 8 years we have been doing these procedures. And I've seen 2 cases of clivus leaks, which are very, very interesting because they are difficult to diagnose. And now we come to the management. So many times by the time the patient reaches our institute, they have already been put on drugs. That acetazolamide has already been started, and that there would be a reduction in pressure and the leak would stop on its own. So decrease of CSF pressure alone for the treatment of CSF rhinorrhea constitutes a level 5 evidence and a grade D recommendation, meaning that it is not the first line of management that should be taken for spontaneous CSF leaks. Endonasal endoscopic repair of CSF rhinorrhea is the standard of care. Now, once the leak has been stopped, the patient is continued with the medications which would reduce the CSF pressure, because we will plug the leak. But if we don't do anything for the raised intracranial pressures, the leak will start from either the same place defect you have repaired or from some other part. So it will be an endless cycle. So patients have to be put on long-term medical therapy, which is one of the most, it is one part which is not very well studied, and patients are not followed up long-term with these drugs. So we usually give acetazolamide or topiramide. I will explain a bit later which drug we use for spontaneous CSF leaks who have had a leak repair done. So acetazolamide lowers CSF production by 48%. It inhibits the conversion of water and CO2 to bicarbonate, and it causes a mean reduction of 10 centimeters of water in CSF pressure, and it decreases the pressure like headache and pulsatile tinnitus, and long-term benefit remains unproven till now. The other drug is topiramate. It is a carbonic anhydrase inhibitor. It has an added benefit of weight reduction. Why it causes weight reduction? There are a couple of theories, like there's loss of taste, and then it causes suppression of appetite, but the mechanism is unclear. And it inhibits an enzyme called synthase, which is involved in the transformation of free fatty acids and glycerol into triglycerides. So we, for the last many years, have shifted on to topiramate because many of the patients of spontaneous CSF leaks are also obese. And telling a patient to reduce weight, patient will say, I mean, this is what my experience has been. You tell the patient you drop 10 kgs, 15 kgs, they will say, give me some medication, do surgery. Weight loss is the toughest thing they have ever come across. So for a patient who has, had a CSF leak repair, who's recovering, reduction in weight or loss of weight is not a very easy thing to achieve. So what topiramate does, it helps patient lose those first few kgs. And once the patient loses those first few kgs, then from there it is easier to take weight loss forward by regular exercise and diet management. So this causes a loss of taste. Many patients come back to us and they say they can't taste the food. The food does not taste very well. They have lost their appetite and they, of course, lose weight because of this. What are the investigations which are most commonly done? Beta-2 transferrin is the gold standard. It is non-invasive, it is repeatable, sensitivity is up to 99%, specificity 97%, and it is a protein detectable only in CSF, perilymph, and aqueous humor. So, for all practical purposes, beta-transferrin is the gold standard for diagnosis of CSF leaks. The disadvantage, it is expensive. Of course, it's a very expensive test. Costs range from anywhere from 6,000 to 30,000 rupees, depending on which lab is processing it. It is labor intensive and time consuming, and expertise required is high. It usually takes about 24 to 48 hours for the reports to come in. The other investigation which can be used is a beta trace protein. Beta trace protein is found in CSF, heart, and serum. It is not routinely ordered as it may be altered in many cases. It is elevated with renal insufficiency, multiple sclerosis, cerebral infarctions, and some CSF tumors and bacterial meningitis. But again, sensitivity is quite high, and so is the specificity. It takes less time to perform and is a cheaper alternative. So if your patient does not have any of these diseases which I have listed or renal insufficiency, beta trace protein can be an alternative to beta-2 transferrin. Other testing like glucose testing and all, they have all been outdated and are not to be done anymore. As far as radiological investigations are concerned, HRCT thin cuts is the current investigation of choice. I will come to the gold standard also, but this is the first investigation that should be done. Again, I would say many times we get patients in our centers who come to us with an MRI. MRI is not the first investigation of choice. A high resolution CT, narrow cuts on DICOM files, which you can access or see on your own computer systems, is the current standard we follow. It is the mainstay in the workup of CSF leaks. It helps in diagnosis site of fracture or the site of the defect or the size of the defect. It is non-invasive. Sensitivity is quite high, greater than 90%. And accuracy is approximately 90% also. Then the other investigation which we can get done is an MRI. So what is the advantage of doing an MRI? Again, it is non-invasive. Accuracy is 100% in detecting site of CSF leaks according to literature. It distinguishes CSF from perimucosal discharge, and it can easily pick up herniation of brain parenchyma or meninges through the bone defect. It can detect mucosal disease, but it has a high false positive rate. It is also effective in assessing the contents of meningoencephalic sacs and helps in diagnosis an empty sella syndrome in spontaneous CSF leaks with IIH. And it can pick up abnormalities of optic nerve, arachnoid pits, skull base flattening, specifically posterior globe flattening, and dural ectasia, which are very well visualized with an MRI. These are all part of criteria which we call Dandy's criteria for idiopathic intracranial hypertension, and an MRI helps in picking up all these. What are the limitations of an MRI? It doesn't give us an osseous detail. There is a decreased ability to visualize subtle fractures or osseous defects. And it is reserved for patients having encephalocele or meningoencephalocele, or in complex cases when multiple fracture sites or osseous defects are present. So for all practical purposes, thin section CT remains the initial examination of choice for possible leaks. Now I'll explain why, if there are multiple defects or multiple fracture sites, why we should get an MRI. So even in trauma cases, if you look at a CT, you will see multiple places in which the skull base has fractured. But 99% of these skull base fractures and the leaks are going to stop. There is only going to be 1 or 2 places where the CSF leak is continuing. So in those cases, let's say a skull base fracture is showing us areas of 6 fractures. We are not going to go in and plug all those 6 areas because nature has already taken care of 3 or 4 of those areas where CSF leak was coming from. we are only going to go and plug the area which is actively leaking. So a CT is going to show us 5 areas which are fractured, but an MRI cysternography will tell us which out of these 5 areas is actively leaking CSF, so that we can have a targeted surgical exercise. We reach directly up to the point where the leak is coming from and plug it, rather than messing with the whole skull base. So that is the place where a where a MRI cysternography comes in. Now, if we read all our literature and our books, the gold standard was always given to be, in the past and even in many current guidelines, gold standard is a CT cysternography. But due to its invasive nature, other imaging modalities should be considered first. So the literature has already told us that if because a CT cysternography is invasive in nature, we have to try other imaging modalities first. It is only indicated for patients with active CSF leak and multiple skull-based defects. But again, for those, we have a MR cysternography, and now a new system is used in the West where they do a MR-CT hybrid, which has a very high sensitivity and a specificity. So basically a thin cut CT, they make a hybrid with a MRI file. So you can see multiple defects also. You can see the osseous detail also. The only problem is, the expertise in doing this, and of course the cost. Also, a problem with CT cysternography is because the radioapic dye which is used, like metrazamide, diohexyl, or ipamidol, it is also affects patients who have renal dysfunction, so it cannot be used in all patients. Number two, many times this dye is going to plug the leak because it is a viscous kind of dye. The leaks are usually a few millimeters. This dye goes and causes granulation at the site and plugs the leak temporarily. So if you are about to operate a patient and you do a CT cysternography, there are chances once the patient is taken into the OT, you will not be able to define where the leak is coming from, which many times helps us, we can follow an active CSF leak to where it is coming from. And when there is no leak present, it is inferior to a normal thin slide CT. Another very important questions, which I think all the postgraduates should know, you will see that rampant misuse of antibiotics for patients who are having CSF leak. Like patients get referred to us, they are already on 2 or 3 antibiotics. So should prophylactic antibiotics be given or not? So the incidence of meningitis after post-traumatic CSF rhinorrhea is higher in the first few weeks. Prophylactic antibiotics for at least 7 days from the time of injury was the previous recommendation. But commonly used antibiotics poorly penetrate the non-inflamed meninges. They are unlikely to eradicate potential pathogens such as pneumococci from the upper respiratory tract. They increase in the rate of meningitis soon after the antibiotics were stopped, and they may lead to colonization with strains that are resistant to antibiotics, complicating the management of any future episodes of meningitis. So what do we learn from all this? And if we review the literature, that the current available evidence from randomized control trials does not support prophylactic antibiotic use in patients with traumatic or spontaneous CSF rhinorrhea. So there are articles for basilar skull fractures also, articles for spontaneous CSF leaks also. So preoperatively, there is no indication of giving a patient antibiotics. Then the next question is lumbar drain. Many surgeons would operate and then they would put a lumbar drain. So various studies again have shown that there is no association between lumbar drain placement and recurrence rates after endoscopic repair of CSF rhinorrhea. So the key is a good repair of the defect that is going to decide how the patient behaves post-operatively and how well the leak is closed. Giving high dose antibiotics or putting a lumbar drain is not really going to help. Now we come to the surgical approaches. I will be dealing only with the endoscopic surgical procedure. So endoscopic is the treatment of choice currently. It helps in accurately identifying the site defect. It gives us a better access to wide areas. Most importantly, there is no brain retraction when we go endoscopically through the nose. And various studies, this was study published in Laryngoscope, it has shown that the endoscopic approach is highly effective and associated with low morbidity. and the literature supports the endoscopic approach using a variety of techniques and materials for the repair of CSF leaks. So again, it doesn't depend what material you are using. It is how well you are closing the defect that is going to matter. Whether it's fat or muscle, it's really not very important. Now I'm going to show you a few videos. Dr. Ravi, how much time do I have? Then I can accordingly show the most appropriate videos. Hello? Can everyone hear me?
Yes, sir. You are audible, sir.
Great. So I'm going to show some videos. How much time do I have? So I can accordingly...
Sir, you are
Dr.
having...
Raman, you please present at your ease.
Okay.
We have enough time.
Thank you so much.
We will not break for lunch and we'll just continue with the presentations.
Okay. I'm just going to show you the leaks where I have seen these leaks come from: the cribriform plate, the lateral lamella, the lateral recess of the sphenoid sinus, roof of the sphenoid sinus, and the clivus. So I'm going to show you about 5 videos. This is a video of a leak from the cribriform plate. So this is the left nasal cavity. So to access the leak from the cribriform plate, we work between the septum and the middle turbinate. Okay, so you lateralize the middle turbinate and you go directly up to the cribriform, and in most cases after decongestion you should be able to see this meningoencephalocele. So we use a lot of Merosil packing and adrenaline to give us a nice access into the surgical area. So once the meningoencephalocele is identified, we make sure the decongestion is proper. Then we have shifted to coblation. I do all my CSF repair with the coblation, not with the bipolar cautery. And I will come to the advantages of it later on. We ablate away the meningoencephalocele. And along with the meningoencephalocele, we also ablate away a few millimeters of area around the defect. This is very important because we need to create a raw bony bed for the graft to sit in. So once the defect is identified, I do not use fat alone. I've shifted to fat wrapped in Surgicel. Surgicel helps me to make it easy for the fat to be inserted into the small defects. So defects are usually 4 to 5 millimeters. After the Surgicel and fat plug is used, we put a fascia lata graft, which we have harvested from the thigh. And many times we just use a small piece of Surgicel over it so that the graft doesn't fold on itself, and a spot of fibrin glue. As you can see, the surgery with coblation is very clean. There is no bleeding. We do not use any nasal pack in our CSF leaks. And we use the fibrin glue to cover this graft and a piece of Surgicel. And that completes the surgery. So just a spot of glue and no nasal packs are used. Now, this is a very interesting case. In this, we have the CT and the MRI images both. You will be able to appreciate the fracture in the roof of the sphenoid, and on the MRI, the trickle of the CSF and the meningoencephalocele into the right side sphenoid sinus. So again, the corridor we will be using to access the sphenoid sinuses through the septum and the middle turbinate. We go up to the natural ostia, we identify it, we identify the superior turbinate, and we coblate the face of the natural ostia. So all the mucosa around the natural ostia is taken away. We are using a normal ProSize Max wand at a setting of 7 and 3, which is the the normal setting. After the bone of the ostia is identified, with a punch we widely open the sphenoid ostia. And if there is any bleed that occurs, the coblation also has a coagulation mode. So now you can see the ostia has been opened up and you can see the meningocele coming into view. This is the meningoencephalocele which has come into view. Ostia is widened. Hemostasis is achieved again. Make sure all the little bleeds are coagulated away with the cobblator. And then using a cobblator, we will reduce this meningoencephalocele which is filling the sphenoid sinus. Now, another advantage of using this coablator is that in case there is active CSF leak, the coablator does not stop functioning. It continues to work. Actually, it works better because it needs fluid like saline or even CSF if there is a CSF coming in to create plasma. Any other device, let's say if you're using a bipolar device and there is active CSF leak coming, the devices don't work very well. So you will notice once the meningoencephalocele ruptures, there is active CSF leak. It has a suction built into it. The coablator device has a suction built into it. It's taking the CSF away and the device continues to work and take care of any bleeding points. So we are reducing the meningoencephalocele. You can see the brain tissue which has come in. Any small dural vessels are easily cauterized with the coagulation mode. Then we remove the mucosa around the defect. Like I said, that is very crucial to create a raw bony bed around the defect because that is where the graft is going to sit. After that is done, these were our first initial cases when we were not using Surgicel, fat wrapped in Surgicel, but fat alone. We are just going to plug in the defect with a dumbbell shape of a fat. And once the fat goes in, the leak completely stops. So using a ball probe, we are gently pushing the fat into the defect and then we cover it with a graft. Again, a small piece of Surgicel to keep the graft attached because it's on the roof. We don't want the graft to fall down with gravity. Though we have not seen it happen, just to make sure that doesn't happen. Fibrin glue is used and then we press all the repair with a piece of dry gel foam. No nasal packs are used like in the other case. Now, this is a case from the leak was from the lateral lamella. Even in the initial steps now, we have started using the coablator device because since there is less bleeding, it helps us to delineate, bony structures and bony defects much better. And it helps us to see and visualize the meningoencephalocele much more clearly. So we are doing an uncinectomy. You will notice how cleanly, these steps can be done with the help of a coblation device. We are taking away the mucosa. And after that, we will do an uncinectomy. The bone is very thin. You can move it with a coablator or use a microdebrider after this, because once the mucosa has been taken care of, bleeding is automatically stopped. So the uncinectomy is completed. Now we come to the bulla. Again, you will see, you will appreciate the lack of any bleeding. Again, the mucosa of the bulla is gently ablated away. Because in a lateral lamella, you have to do a bullectomy. The bulla has to be completely removed to get to the defect. If you do not remove the bulla completely, many times you will miss the defect of the lateral lamella. Then we are going to struggle, cut the middle turbinate and make things more complicated for us. So we are taking away the mucosa of the bulla. So like I said, the complete bulla has to be removed. With a J curate, I'm moving it forward, and you will notice as the last part of the bulla comes out, the defect comes into view. So this is the meningoencephalocele from the lateral lamella. This is the right nasal cavity. This is the middle turbinate, and the defect was coming from the lateral lamella. This is the same case moving forward. Here you can see in the CT the defect in the lateral lamella. So again, or any bleeding or any ooze is taken care of. And this is the defect. Again, bending the coblation wand slightly upwards, we reach up to the meningoencephalocele and we have started to reduce it. So again, appreciate the lack of bleeding. Any little dural vessels is automatically taken care of with the coablator. It also has a, like I said, a coagulation mode, which can take
130 to 2.
The small vessel.
215 तक आए तो चलेगा. हाँ बेटा हम तो दाल चावल ही खाने हैं basically.
So now you can see the defect has come into view. Now the next step, important step, is the delineation of the defect. That is very important. Because just like in COM, the inner and outer layers fuse. So same in this, the dura is tightly adherent to the bone or the nasal mucosa, you have to delineate it completely. So using a sharp sickle knife, I will show you how I delineated the defect. I separate out the dura and I remove the nasal mucosa from around the bony defect. If you don't do this step, there are chances that your repair can fail. Just like in COM, if you don't freshen the margins or if the tucking is not proper, the graft can fail. Similarly in this. Now you will see in this part it is still attached. I separate it out again with a sickle knife and a nice circular defect has come into view. So again, using a fat wrapped in Surgicel, we push the fat wrapped in Surgicel into the circular defect. And again, an upward ball probe works very well. Gently, do not bury it too much. Don't injure anything on the inside. Use a cottonoid to suck away any fluid or secretions that might be obstructing your view. So make sure the defect is completely plugged. And now you will see that there is no active CSF leak. Another small piece of Surgicel is pushed inside to completely seal the defect. So that completes the plugging of the defect. Now all we have to do is place a graft on it and as a spot of glue, and that would complete the procedure. Again, with the same cottonoid, we suck away anything. And if the defect, like in this area, is on a flat surface, I use a thin bone which I've harvested from the ethmoids to support the defect. So I'm taking a small piece of bone. These are thin ethmoid bone. The advantage of this is it is so thin that it is as malleable as cartilage and actually thinner than a cartilage. So it's very easy to manipulate this bone into a defect. So all you have to do is insert one end into the defect. So once that is done, I create a notch at the lower end with the sickle knife there and then just push this bone inside as an underleg. So once this goes inside, the CSF pressure and the pressure from the brain automatically presses it against the defect and it creates a complete seal. Then I put a small graft again, which is facial atta, and a spot of glue. No nasal packs are used again, no gel foam in this case, and that completes the procedure. Now, these are another kind of leaks which are very interesting. They are a separate entity. They are called leaks from the lateral recess of the sphenoid sinus. And the here is slightly different because we use a transpterygoid approach in these cases. If we go into the same corridor between the septum and the middle turbinate, we will not be able to adequately plug this defect. So there are surgeons who propagate that no, these defects can easily be managed with approach which goes transsphenoid, but the success rates are much higher if you go through the transpterygoid approach. So again, this is the left nasal cavity. That is the middle turbinate. I have lateralized it. That is the septum, and you can see the natural ostia. So we are ablating away the mucosa around the natural ostia. After that, with a downcut ronger, we open the natural ostia wide. And once that has been opened, you go into the sphenoid sinus, we will be able to see an active CSF leak, which I am sucking out. Now, this arrow points to the meningoencephalocele, which has come into view. But notice, if I was using this approach, my lateral access is very limited and I would not be able to get to the bottom of the defect. So continuing forward, we resect part of the middle turbinate. This is very important because you have to make the sphenoid flush with the maxillary antrum. So part of the middle turbinate has to be resected away, leaving a stump behind as usual. After that, an uncinectomy is done. Again, we are doing it same as in the other case with a coblator. We are using the precise max wand. Then we do a wide middle meatus enterostomy, and we make it flush with the posterior wall of the maxilla with the help of a microdebrider. Then using a coblator again, we coblate the mucosa around the sphenopalatine foramen and coagulate the sphenopalatine vessel. We identify the sphenopalatine foramen with the help of this bony ledge as pointed by the arrow. This is called the crista ethmoidalis. And my ball probe is into the sphenopalatine foramen. Then using a ronger, I remove the posterior wall of the maxilla. Some amount of oozing might be there from some little twig of the sphenopalatine foramen. You can see this little vessel. You can again coagulate it away with the coblator. Once that is done, the contents of the pterygopalatine fossa are partly, coagulated and coblated away, because we have to get to the interior face of the lateral recess. So you can see the fat and other contents of the pterygopalatine fossa. So basically we have to work between the Vidian and the foramen rotundum. And we have to sacrifice the Vidian nerve. So you can see the blue interior face of the lateral recess coming into view. And this area would be the area of the Vidian nerve. So once you coagulate away the Vidian nerve, you can get some amount of bleeding, which is from branches of the vessel from which accompany the Vidian artery. You can see this ooze coming in from here, pointed by the arrow. That is the Vidian artery which accompanies the Vidian nerve. You can drill it with a diamond burr and the bleeding usually stops. So we are opening the interior face of the lateral recess now. Now see the meningoencephalocele coming into view. And till now, I am not manipulating the meningoencephalocele because I have to get to the base where it is attached. Now I am head on, and now I can coblate away the meningoencephalocele. Same procedure using the Precise Max wand. I am gently ablating away the tissues. And again, you will see a nice circular defect. Same way, using a sickle, you have to make the edges raw. You have to remove the mucosa which is around it, because you need to create a bed for the graft to come. The defects are all nice and circular. Now you can see a nice circular defect in the lateral recess. And again, I'm going to plug it with fat and Surgicel. Using a ball probe and fat wrapped in Surgicel, I am pushing it into the defect. Once that is done, again a small piece of bone from the ethmoids is taken. And it is pushed into the defect, just like in the other case. Once that is done, a small piece of fascia is taken from the thigh, kept over the raw bone which has been, the bed which has been created. Make sure there is no folding up of the edges of the graft, because that can cause a failure in graft or improper epithelialization. Once that is covered, a spot of glue and a piece of gel foam to press the repair you have done. Again, no nasal packs have been used. And that completes the procedure. That is the final picture. So if you appreciate here, if we had not opened this posterior wall of the maxilla and had not gone transpterygoid, there was no way I would be able to access this area. Even if I open this wide enough, I would not have been able to get to the base or the source of the CSF leak. This is a few of our publications which we had on lateral recess defects. Now, another important entity which can be and had also been ignored or missed by us are clivus leaks. So both patients were operated outside for a cribiform leak defect, but the leak did not stop. They were operated again. The leak did not stop. The patient came to us with an MRI. The MRI again said there is a leak from the cribiform. So we got a CT scan done, and we were going in to repair the leak from the cribiform plate when one of our residents picked up on the axial CT that there seems to be a defect in the clivus. So do you understand what was happening? We were thinking like clivus defect repair, I mean, leaks are so rare that it doesn't even come to mind that a leak can be in the clivus also. So cribiform, roof of sphenoid, these are the more common sites, and someone had repaired it outside. So probably there was no leak, or there were multiple leaks at that time when this case has been done. So we did a transsphenoid repair of the clival defect, and it was such a small, tiny little defect that we actually had to evaluate before we were able to Surgicel and seal the defect. This is a sagittal view in which you could see. Again, we went in between the septum and the middle turbinate, opened the sphenoid wide, and we were able to see the leak in the clivus. You can see the sphenoid sinus filling up with the CSF. The procedure again which we used was the same. After adequately widening the we ablated away the mucosa around it using a coblation wand, again a precise coblation wand, and identifying the bony margins of the defect. So we are just going around the leak and separating the mucosa, ablating the mucosa away so raw bone can be reached. So we were able to gently tease off the mucosa from the edges. But the leak was so small that we would not have, it was a pinhead leak. We would not have been able to plug the leak. So using a sickle, I gently widened the leak so that a plug could go in. So we just made the rent about 2 millimeters wide. And then with a blunt probe, kind of enlarged it, made it nice and circular. And you will see there is active CSF leak which is coming now. Again, the same procedure. We took a small piece of fat and see how the pressure was pushing it out. And just plugged this defect in a dumbbell fashion. And as soon as the fat went in, the leak automatically stopped. There. So half of the fat goes in, half remains out, and it kind of forms a dumbbell on the inside. So the leak has stopped. The graft for this case was actually very thick because of the 2 or 3 surgeries the patient had undergone. The fine fascia was not available, but we took a thick chunk of graft, kept it over the repair, and filled it up with glue and a piece of gel foam. And again, no nasal packs were used. So this brings me to the last slide. A few pearls. Start with simpler cases. Take a senior colleague's help whenever you are in doubt. Like Dr. Shamit very nicely said, that there is going to be someone who is your senior or who knows more than you. If you are in trouble, do not let your ego come in between, but take your colleague's help. It will help you learn better. We have purely shifted to coblation, as you could see in most of these videos, because it has helped us give a cleaner field. That is number one. Number two, using a bipolar in a narrow nasal cavity, you require an endoscope, you require a bipolar forceps, you require suction, someone to irrigate it. So in a narrow space, putting in 4 instruments is many times very difficult. But with the coblator, we have an endoscope. The coblator has built-in irrigation. The coblator has a built-in suction. It has a built-in coagulation and ablation. So even in very narrow spaces, it has helped us to work very well. So we have shifted completely to coblation. The other key thing is make sure, like I was showing you with the sickle knife, that the bone is bare a few millimeters all around the defect, because it is very important to create a bed over which the graft can be put and proper epithelialization can take place. Release the dura if it is attached to the nasal mucosa, just like you would do in an ear case, and use fat wrapped in Surgicel, because we have found it easier to work with, easier to push in than just fat alone. Thank you very much.
Hello, Ramandeep.
Yes, sir.
Thank you, sir.
Great demonstration.
Thank you, sir.
And great use of correlation. I agree with you. Putting 4 instruments in a small child, I did a meningocele, and the child was small, so nostril was also small, and the adult size bipolar cautery was there, and subsequently it burned the nostril outside, just at the Ella site, and child developed a vestibular stenosis. That was a complication. So great use of coblation. You said CSF auto and this rhinorrhea can be mimicked by CSF autoria. We just before the COVID, in first week of March, we had a CSF autoria case which was diagnosed, treated outside as CSF rhinorrhea. And when patient came, I saw the CT, there was no defect. So I got the CT temporal bone and there was a defect. It was Mondini defect in the ear, bilateral, and which I operated, and then it settled down. The other use is, other comment is, do you have any experience of frontal sinus positable defect? I got a chance to operate over 2 cases side by side, Vikramville Agri, and we did this 2 whole operations, and both the patients were traumatic. Your comment?
Yes, sir. So I said that I don't have experience with spontaneous leaks from the frontal sinus. Traumatics, we do port surgery. We create 2 ports here, and we go through the nose also. Creating 2 ports just above the eyebrow actually help us look onto the defect head on and get to it. If the leak is lateral, or if the defect post-traumatic defect is lateral, then we do a mini craniotomy kind of thing. We just take away the front bone of the frontal sinus, and we repair it head on, and then we keep that part back with the mini plates.
I got a patient who has a spontaneous this thing post radiotherapy, positable. Is it post spontaneous or post radiotherapy? And patient is not agreeing for the surgery because she is quite afraid, and she is a case of CA mandible post radiotherapy.
Okay.
CA was
Sir, has any chemotherapeutic agent been used?
Yeah.
Okay, so we have this publication in which a chemotherapeutic agents they many times cause CSF leaks. So there are 2 or 3 papers in the literature. One of them is ours, which we recently published about 2 to 3 months back. So what basically we have hypothesized is that if there is metastasis in the brain, right, it of course increases the intracranial pressure, and it also erodes part of the bone. It can erode the cribriform or erode the posterior table. And then when the chemotherapeutic agent kicks in, the metastasis shrinks, but it leaves that defect and that area, and spontaneous CSF leak starts to come from it.
Okay.
Sir, I have a question to ask from Dr. Big. Sir, in all the lateral pharyngeal leaks you have operated, what was the age group and the profile of the patients? Usually, what is there in the literature, these are more common in females around 40-50 years of age, where we say lateral sphenoid has a canal, which is lateral pharyngeal canal, which is Sternberg canal.
Right. So Weber, that theory has been debunked now. If you go through the literature, Sternberg canal causing these defects, as you saw in that video, this is not a Sternberg's canal.
Yeah.
So lateral recess is a separate entity, which they have explained what happens when the base of the pterygoid gets pneumatized and it expands. The plate around the brain kind of thins out, and in case there is an increased intracranial pressure, that is one of the potential sites from which the leak can come in. So again, patients can have IIH leading to they'll be more prone to it because that bone is very thin.
So
So it is
lateral
a matter
recess
of
leaks
time
are
whether cribriform erodes first or the lateral recess erodes first, because nature is trying to reduce the pressure. It has to create that defect and let the CSF flow out.
okay.
Sir, my name is Jafar. I had two questions basically. Can I go ahead and ask you those
Yes, yeah.
questions?
Sure.
Yeah. So, firstly, sir, post CSF leak from cribriform plate, what is the chances of anosmia? The patient having anosmia, persistent anosmia.
If it's bilateral, yes, definitely anosmia. There is a high chance of anosmia, but like most of them are unilateral.
Yeah.
So the chance of anosmia is less. Number two, since we have shifted to coblation, that is another one of the papers which we are doing with the neurosurgery people. Coblation causes less thermal damage in that area than compared to a bipolar cautery or a monopolar cautery, because it is not a heat-driven process. Plasma formation is not a heat-driven process, and the temperatures are 40 to 60 degrees Celsius. There is copious irrigation. So chances of anosmia are much lesser, which we have already seen in our current study, which we are doing with the neurosurgery people. That was for pituitary surgeries, because in that you get bilateral corridor.
And the second one was, sir, in post-operative CSF leak, since you said you don't put a pack either, what is the post-operative care that you advise your patients in an ideal scenario? So as to, my question is, the reason I'm asking you this is because I had operated one patient and her specific question was, when can I start doing my housework?
Right.
Which involves a lot of bending and sweeping, swabbing, etc.
So Jafar, that's a very fantastic question. Unfortunately, neither me nor literature has a definitive answer for that. Some surgeon will say 6 weeks, some will say 1 week, some will say do work in 3 weeks, some will say 3 months, kuch nahi karna aapne. So there is no one answer.
There's no consensus on this point.
There is no consensus. So post-operative period, like Vaibhav knows very well, we have worked together at PGI. Our patients are admitted 3 days post-op. 3 days ceftriaxone is given according to institute antibiotic policy, and patient is discharged after 3 days without antibiotics. But the patient is put on topiramate and painkillers, and of course any other medication that they're changing. We give them in the first day, there is a relative bed rest. That means you can toss and turn around, but not get up. Third day, we relative ambulation. You can walk to the bathroom and come back, but try to rest for the first week that is there. And after that, you can start doing your daily activities. Because what we have hypothesized is that mucosa to mucosa integration is going to take a couple of weeks. So make sure that there are no strenuous exercises at least for a couple of weeks. Baki, it is the same question, how quickly can I fly after a staphylotomy surgery? I mean, papers say you can take the evening flight after surgery, others say don't fly for 6 months. Again, we don't have a consensus on that.
Yeah.
Thank you, Dr. Work.
Thanks, sir. Thanks, sir. Thank you.
Thank you, Dr. Damandeep, for excellent presentation.
Thank
you. Use of coagulation in CSF rhinorrhea. I mean, it's a definite advantage to use coagulation because of the bleeding control which can be offered by coagulation. I just have one query. In lateral sphenoid leak, I did one case. How do you, what is the way to prevent trauma to the maxillary nerve? Because when you are dissecting, we have to take care of the VR line.
Yes.
And this patient, I took great care of this maxillary nerve, but patient had anesthesia over the cheek in the post-operative area. So how do you tackle this?
So again, avoid using a bipolar in that area. Because I'll tell you why that damage happens. Number one, clean delineation. If you can identify the Vidian, you have a relative idea where your foramen rotundum is. Because when the pneumatization takes place, it takes place between the Vidian and the foramen rotundum.
Right.
Using bipolar has more collateral thermal damage compared to a coablator. So coablator, the depth of penetration is about 1000 micron meter, which is 1 millimeter. And this is much more in unipolar or bipolar devices.
Okay.
Number two, some twig of sphenopalatine or the Vidian is going to bleed there. And we, in our hurry to stop that bleed, we rampantly, start bipolarizing all those things. Right. And that is the cause for, this leak.
Right.
Also, the advantage I found with Coblator is before I used to do these defects, I never found these nice circular defects because there was always blood. I was struggling. I was cleaning. I used to inadvertently fracture the crib area of the crib.
Area, right.
And my defects were much larger. I used to say defect 7 millimeters, 7 millimeter. After I've started using Coblator, I've realized the defect is no more than 2
Very
to 3.
small. Excellent, right there. I think coagulation has definite advantage over bipolar here also.
Yeah. So
Sir, which wand do you use for coagulation?
The skull base, 100%. I don't know how many cases I must have,
Right. Right. So there's another question by Dr. Zafar. Which wand you use for?
I use the Precise Max wand.
Okay, Precise.
So you can also use the wand meant for tonsillectomy. It is the Easy View. It is slightly narrower.
The EVAC 70 won't work here, sir.
No, the 70 was made for Jafar. The 70 was made for a tonsillectomy. So the wand to work has to be upside down because the saline needs to come for the creation of plasma. If you turn that wand upwards, because it does not have any ports for irrigation, the fluid comes from the side of the wand. If you see the wand carefully, if you turn it straight, you will see a lot of charring and lack of plasma formation.
Okay.
So the EVAC 70, anywhere you have to work head on and the wand has to be straight, EVAC 70 won't work. EVAC 70 was made for tonsillectomy. It works like that downwards.
Okay.
Okay, thanks once again, Dr. Ramandeep,
Thank you,
for
Ravi.
excellent presentation. I think we can call off this presentation. Now we proceed for the next talk by Dr. GB Singh. Dr. Gautam Bir Singh, has he joined?
Yeah, I've joined, Ravi. Good morning.
Welcome,
good afternoon. Good afternoon. The very lovely lecture from Virk. In fact, we have also been started using coagulation now.
Very nice.
We are using coagulation for everything, right from removal of our angiofibromas, right for even CSF rhinorias also.
Great, great. So let me introduce Dr. Gautam Bir Singh. Dr. Gautam Bir Singh is professor at Lady Hardinge Medical College, and he has special interest in, I would say, otology. He does a very good ear surgery, and he has also special interest in bronchoesophagology. And being in a pediatric hospital, he has vast experience in pediatric ENT cases. And today he will be talking about
Ravi, how do I connect to my
you can just share your screen, sir.
Yeah, just a minute. I think there is
the lower part. Hello.
I'll go to.
So he will be talking about HIV in ENT practice.
Yeah, I'll press on the screen.
You have to share your. You already have shared your screen, I think.
Yeah. Now I want to go
open
to my
your presentation.
It's first I open my presentation.
Yes. Open your presentation.
Just a minute, please. You'll have to bear with me.
No issues. You just switch it off.
I'll just close this.
Close this window.
And I'll just
and
open
go
this
to your presentation.
Just a minute. Okay. Now, I think you have. I should put now what I should do. It's showing here on the screen.
Please
so start slideshow. Start slideshow.
Slideshow.
Okay.
I will request all the other faculty to please switch off their mics.
Is it okay now?
Gautam sir, you have to click from beginning. From the left hand side, it's there, na? From beginning. Yeah. You can just click it.
Now. Okay. I think now everyone's getting it. Is it
Yes.
visible?
Yes, sir.
Okay. So, good afternoon, everyone. Sorry for this hitch. And at the outset, I'd like to thank Ravi and Dr. Rathore, Professor Rathore, and the organizing committee at MAMC for giving me an opportunity to interact with you all. And I will be talking here about ENT manifestation in pediatric HIV and AIDS patients. The first case of AIDS in India was diagnosed way back in 1986. And at present, the HIV prevalence in India is 0.22%. And we are very lucky that there is a trend of generally declining AIDS now. We are going to have something else maybe. And there are about 86,000 cases diagnosed every year. Okay. And out of these 12%, about 10.4 thousand cases are pediatric patients. And what is more alarming here is this, that out of these 10.4 thousand patients, 80% of the patients are going to come to you with ENT manifestations. So the idea here is this, that, the chances of diagnosing a patient with AIDS lies more in the hands of the ENT surgeon as compared to a pediatrician. So that is the first thing you have to be very careful about. Now, there is some more data, 55% of HIV children less than 3 years of age have ENT manifestation. And then you have 98% of HIV children below 9 years of age have ENT manifestation. As the age goes on increasing, like now the pediatric age group is anywhere between till 18 years of age, the chances of having ENT manifestation, let us say in the adolescent age group, is as high as about 100%. So these are the data that we have from NACO. And interestingly, that is why we say that, all the HIV patients in the pediatric population would probably be diagnosed by an ENT surgeon. Now, coming on to our classification of AIDS. Now, this is a clinical classification. There are two references that I have given for them here. So you have, first of all, sorry, excuse me, we have the slides there. So you have not symptomatic, having no significant symptoms. Then you have mildly ones where you have cervical lymphadenopathy and all. Then you have moderately symptomatic where you have chronic oropharyngeal candidiasis, lymphoma, pneumocystic carni and all. Then you have severely symptomatic cases as well. So this is a classification that we follow, and it's a standardized classification that we use. But what is more important here is that, you have to understand that if you have symptoms, they are suggestive of AIDS. So you must get your patient diagnosed. This is not a surrogate for diagnosis, number one. Number two, in an untreated patient, if you have a new patient, and you all of a sudden have the development of ENT manifestations like oral lesions, that means that there is a progression of the disease. The disease is deteriorating. It's going from moderately symptomatic to maybe severely symptomatic case, number one. Number two, third important thing is that, if your patients are on this retroviral drugs, and then they develop this ENT manifestation, that means that this is the significance of treatment failure. And there is increase in the plasma HIV RNA level. See, we in Harding have a very good unit of HIV AIDS patients, and this HIV patients. So we are closely, collaborating with our pediatrician, and we have a new case. And if we diagnose an ENT manifestation, that means the patient is very severe. And if a patient is already on treatment, and then we diagnose him to be having this ENT manifestation, we mean that this signifies that there is a treatment failure. So be very careful when you are diagnosing the case. It has a great clinical relevance as far as pediatric AIDS is concerned. Now, coming on to the predisposing factors for the ENT manifestations, well, these are 5 very important factors. 2 of them are, of course, laboratory findings, that you have CD4, which is less than 200 milliliters, and then you have HIV and RNA levels more than 3,000 copies per ml, and then you have xerostomia, poor oral hygiene, and smoking. See, smoking is a very important predisposing factor for HIV. We have found that's what the literature also tells you, and it's not that children, once, because now I told you that the age group extends from anywhere from 0 to 18. So I mean, the adolescent people, they experiment with life, they are into smoking, and that is the time when they develop these. They have a greater chances of developing this HIV manifestations. Now, what are the various HIV manifestations that we can have? So we have the oropharyngeal manifestations, we have the neck manifestations, we have the otologic manifestations, and then we have the rhinologic manifestations. So this is in the order that they present. You're more likely to have an oropharyngeal manifestation, then you might have a second chance of having a neck manifestation. Let us begin here with the oropharyngeal manifestation. Now, the commonest one, of course, is the oral candidiasis, which is known as the oral thrush. Now, it is a recurrent, persistent thrush in a non-breastfed babies of maybe 1 month of age. And it is pseudomembranous, erythematous, and angular cheilitis is also present. We all have seen oral thrush, and if you see an oral thrush in a child who is not breastfed and is more than 1 month of age, you must suspect that probably you are dealing with an HIV patient. The treatment is, of course, the use of topical clotrimazole and nystatin. You can give fluconazole orally also, and in resistant cases, we give itraconazole for 7 days or amphotericin B. So any of these drugs can be used for the treatment of oral candidiasis. The other symptoms which we have periodontal and gingival diseases. Like there is a linear gingival erythema and necrotizing gingivitis. Now, what is more important here is the oral herpes simplex virus and the oral human papilloma virus infections. Now you can see the photographs here, In the herpes simplex virus, you have these punched out small lesions, quite, small lesions. And here, in the case of human papilloma virus infections, you have the vesicular lesions. So these are, small vesicles with ulcer. Lesions are bigger and recur and are persistent. The treatment of choice is, of course, acyclovir. In resistant cases, you can use valacyclovir and foscarnet. The oral human papilloma virus infections, well, of course, there is an increased incidence on the patients who are on heart therapeutic regime. And of course, the oral sexual behavior. As I said, smoking and this early sexual contact in adolescent children have led to an increase in HIV manifestations in the adolescent age group. We all know about Kaposi sarcoma. Kaposi sarcoma is a synonym with HIV/AIDS. It's the commonest oral malignancy in HIV patients. Number one, there is skin and visceral involvement. You see the hard palate. Now, this is a very characteristic lesion, which you can appreciate here, which I have put here. You have a hard palate, gingival and buccal mucosa, red, flat, asymptomatic lesions, dark, and you do a biopsy for diagnosis. Well, the treatment is you give a combination of surgery, radiotherapy, and systemic chemotherapy, both for oral and extraoral lesions. You can use topical chemotherapy for the lesions which are exclusively in the hard palate. Then you have the non-Hodgkin's lymphoma. A non-Hodgkin's lymphoma is, very distinctly different from what is a Kaposi's sarcoma. You can see it has an punched out ulcerative appearance on the focal growth. There, this is the very characteristic picture of the non-Hodgkin's lymphoma. So you have ulcerated soft tissue mass, a biopsy, and of course the treatment is CHOP regime, and you have this surgical debulking and the radiotherapy which is given to the patients. Now, coming on to some other rare oropharyngeal manifestations that you can have oral hairy leukoplakia, and that is due to the Epstein-Barr virus, white corrugated lesion in the lateral part of the trunk. The treatment is trichloroacetic acid and glycolic acid with podopylene resin, and systemically you give your patient acyclovir. And then you have this after stomatitis. So, after stomatitis, we all know we have it in three forms: the major, minor, and the herpeti form. In fact, what I told you about herpes simplex virus, that might cause these after ulcers, and they are not related to stress now. Please do not confuse, or rather, put an etiologically that they are due to stress. We have so many children, who all of a sudden come to us with after stomatitis, and we think that it is due to stress and all, but most of the times, they might be due to an HIV infection, especially the herpetiform lesion where there is involvement of the herpes virus. So after stomatitis is yet another, very important stigmata of oropharyngeal manifestations of HIV patients. Now, the second commonest manifestations which you see, are the neck manifestations. Now, you see cervical lymphadenopathy, that is in the form of tuberculosis, lymphoma, and Kaposi sarcoma. If you have two or more than two sites in the neck involved for a duration of more than 3 months, then you have the presence of what is known as the cervical lymphadenopathy. And then you have this salivary gland disease, parotid gland hypertrophy, bilateral, very important. We all know the treatment, but this parotid gland and the cervical lymphadenopathy, along with some autologic manifestations, and the first one, of course, being the oral candidiasis, are the most important manifestations of an HIV patient that presents to you in the ENT OPD. Okay, so that is one strong message here. Then you go to the otological manifestations. Rehab otitis externa, patients do have, but that is basically related to seborrheic dermatitis. What we have more commonly, is a secretory otitis media. That is the accumulation of steroid fluid in the middle ear, which is leading to deafness. And this basically happens due to adenoid hypertrophy, okay, in patients of AIDS who are more susceptible to infections. You diagnose them by impedance audiometry, and then you give your patient a course of antibiotics for 4 weeks. If the disease still stays on, you put in a grommet. Now, if you have this coming repeatedly, if you have repeated bouts of secretory otitis media in your child, then probably this is a rare manifestation of HIV infection. Then you have acute otitis media and chronic otitis media. Nothing special to tell you about acute and chronic otitis media in a patient of AIDS where the immunity is already, very much depressed. They are more susceptible to infections. You can have pseudomonas and staph infections, and of course, acute otitis media and chronic otitis media are very frequently seen in these patients. Now, what is more important to remember here is that they have this tuberculosis of the ear, which we do not see. So in cases of tuberculosis of the ear, we believe that HIV should be ruled out. And of course, if you have oral polyps which have been infected by Pneumocystis jirovecii, it's a very rare microorganism. It is seen exclusively in AIDS patients. So if you have this, then probably you're dealing is one of the important manifestations of HIV infections. Your patient can also have autosyphilis, very important. Syphilis, any latent syphilis, all these sort of syphilis presentation, primary, and all these sort of syphilis presentations can happen in a child, and especially when he's on AIDS. Tuberculosis and syphilis, they become more active in a patient who's having HIV. Then let us come to the nasal manifestations. The nasal manifestations, you have rhinosinusitis. That is a very common thing. Now, this rhinosinusitis is, of course, a very vague symptom. We can have it even in cases of malignancy. You can have it in cases of anything. But if you have protracted nasal discharge and blockade for more than 12 weeks, this is the standard definition that we use for chronic rhinosinusitis. But if you have these attacks frequently, if you have these attacks frequently, they said more frequently, let us say that if a child is having a chronic rhinosinusitis episodes frequently in a year, 2 or 3, and then of course you have to get alarmed and his immunity is altered. So this may be a telltale sign of your HIV infection. Fungal sinusitis. Well, we have them, fungal sinusitis. These are very dreadful. You have them both Candida aspergillosis and mucormycosis. They lead to bony destruction, nasal bones, palate and skull bone, and surgical debridement and lysosomal amphotericin B is the treatment of choice, and they are fatal. And fungal sinusitis, of course, they are seen with comorbidities like diabetes mellitus and HIV, and children's are no exception to that. So much more important than chronic rhinosinusitis is the presentation of fungal sinusitis in a child. If you have it, then you're very clear that yes, probably you are dealing with the case of HIV infection. Coming on to the neoplasms, well, you have a nasopharyngeal lymphoid masses. I told you adenoid hypertrophy that makes a patient more vulnerable to secretory otitis media. You can have lymphoma, you can have Kaposi sarcoma, and sometimes, this also leads to idiopathic thrombocytopenic purpura, and your patient presents to you with epistaxis. You start treating the epistaxis without realizing that you're probably having an underlying HIV infection as well. So neoplasms, epistaxis, rhinosinusitis, and especially one very special type of rhinosinusitis, the fungal rhinosinusitis, is an important stigmata for your HIV infections. Coming on to the tonsillar abnormalities, or what are known as some other rare manifestations here, you have infections like tumors, okay, both Kaposi and lymphoma. In the larynx, you can have candidiasis, you can have Kaposi sarcoma, you can have vocal cord edema, and you can even have recurrent laryngeal nerve syndrome. And similarly, Sjogren syndrome or a Sjogren-like syndrome presentation is very much seen in HIV patients in small children, okay, in young children. And these are some of the other rare clinical presentations that you can have in a child who's having HIV. Coming on to the esophageal candidiasis, well, yes, you have, this is very common, especially with oral thrush, and should be suspected in childs with oral candidiasis. As I said, their refusal to feed, they have drooling, and they have odynophagia and dysphagia. And the treatment of choice is fluconazole, 3 to 6 milligram per kg body weight per day initially, then switch over when the symptoms improve for about 21 days. Ranula, sometimes it is mentioned in the literature. We have not seen a case of ranula suffering from HIV. That's why I kept it in the other rare manifestations. But I was going through the literature, and the Western literature tells you that ranula presentation in a child can be an indication for HIV manifestation as well. Now, what is the magnitude of the problem? The prevalence of common ENT manifestation in pediatric AIDS and HIV patients. Now, you can see here, that the oral candidiasis, this is the commonest, about 84%. And then, of course, you have the cervical lymphadenopathy and the parotid gland enlargement that I was telling you. And of course, then you have the otitis media. Now, this is very important, secretory otitis media, acute suppurative otitis media, and chronic suppurative otitis media. So these are the four important clinical features with which your child can present, Some other rare presentations are, of course, the periodontal and gingival disease. You can have oral hairy leukoplakia. You can have the nasal manifestations like sinusitis and the fungal sinusitis in particular, and otitis externa. So these, of course, are a few common types of ENT manifestations which are mentioned in the books. Now, how do you clinically, have a suspicion that your patient is having one of the HIV manifestations? So this is a guidelines which we found, which was mentioned in the literature. I have given the references below. Now, it tells you that the need is that if you have to require more than 4 antibiotic courses a year, number one, or the occurrence of more than 4 new ear infections a year, the flora keeps on changing, the development of pneumonia twice a year, the occurrence of bacterial sinusitis for more than 3 times a year, the use of preventive antibiotics, and of course the unusual bacterial severe infections by rare pathogens. This of course has a geographical bias. Like suppose we sitting have a pneumocystic girovecii oral polyp, and then of course we start suspecting that yes, this is a case of a very rare case of HIV manifestation. But these are the clinical indicators that probably your child is having an HIV infection. Now, ENT manifestation prevalence, to summarize, it's a short lecture and I'll just summarize it for you, that the ENT manifestation prevalence is about 80% of all the pediatric patients. Now, this helps you, it's an intrinsic part of diagnosis. It is not a surrogate for HIV testing. You have to get your patient thoroughly HIV tested if you're seeing any of these lesions. Oral manifestations are the commonest, and they are, if you see your patient with oral candidiasis, herpes, or human papilloma virus infection, especially in adolescent male, then you must suspect that probably your patient is having an HIV. Lymph nodes, yes, and parotid gland hypertrophy are the other second most commonest presentations. And then you have the otological manifestations like chronic otitis media, and the nasal manifestations like the sinusitis are also the other few important clinical manifestations that you have in a patient of HIV. The management is, of course, a multidisciplinary approach. You require a pediatrician, you require an immunologist, an oncologist. They all have to work together, and the ENT people, after diagnosis and treating their particular disease, it's not over, because once a patient of AIDS, he becomes a lifetime patient, and curing them does become a big problem, and they have to be incorporated into a society once they become adults. And so, what's the take-home message? Act against AIDS. Use a proactive, multidisciplinary approach. You require doctors. You require trained the health personals, the government, the people. Everyone has to be aware. The government, of course, is doing a lot for AIDS. We have a lot of program for that, but the awareness among people is still very low, and they do not accept that their patient is having AIDS or might have AIDS. If he's having frequent bouts of secretory otitis media, we send them to AIDS clinic. They do not report there. There is a lot of stigma attached to it, and of course, you require a dedicated team of doctors. Thank you so much. The doctor prescribes drugs for which they know little, for diseases which they do not understand at all. It's so true when we are dealing with AIDS. We treat our patients for acute suppurative otitis media, chronic suppurative otitis media, without realizing that probably these are the patients which might have a hidden HIV infections as well. Thank you so much for giving your patient hearing. If there are any questions, I'll answer them to the best of my academic and clinical knowledge.
Thank you so much, sir, for this comprehensive session. I would now like to invite the faculty for any comments or queries.
Thank you, Dr. Gautam. I think it was a good coverage of HIV in ENT, and in a very short time, you have covered everything. And I'm sure PG students will be able to answer anything about HIV in ENT after this lecture. If there are no more questions, I think we can go ahead with the case discussion. And I can see Dr. Nitin Nagarkar here, Director AIMS, and also Dr. Sunil Kumar and Dr. Vipin Arora with us for the case discussion. Dr. Deepika, please
yes, sir, yes.
Start with the introduction of the faculty for the case discussion.
Next, we have a case discussion which is being presented by our third year PGs, Dr. Karandeep Singh and Dr. Avibo. To moderate this session, we have the eminent faculty, Dr. Nitin Agarkar, Director, AIMS Raipur, Dr. P.K. Rathore, Director, Professor and Head Department of ENT, Maulana Azad Medical College, Dr. Sunil Kumar, Director, Professor and Head, Lady Hardinge Medical College, New Delhi, Dr. S. Mandal, Professor and Head, VMMC, New Delhi, and Dr. Vipin Arora, Professor, Department of ENT, University College of Medical Sciences, New Delhi. We welcome you all, sir.
Hello. Thank you, Dr. Deepika. Thank you.
Dr. Karandeep and Dr. Avibo, please share your screen and start. Over to Dr. Karandeep and Dr. Avibo.
Good afternoon, ma'am. Good afternoon, sir. So, are we audible?
Yeah, you are audible.
Okay.
Ma'am, screen is visible.
Yes, your screen is also visible. Sir, should we start the session?
Yes, you can start.
I will request all the faculty for the case discussion to please switch on their video cameras so that we can see you also. And
Thank you, Dr. Ravi, for inviting us, and my special thanks to you, Professor Rathore, who is also joining us in the panel. It's always a pleasure, and this time again we are with you for the ENT update. Most of the times we enjoyed your hospitality in person, but we'll continue doing it online. And I think it's a great academic activity which you've been doing. Again, thanks to you and Professor Rathore. And I've got a wonderful panel with me. So I'm very much over here, and thank you so much for inviting me.
Thank you, Dr. Nitin, for your nice words. I think we can go ahead with the case discussion now.
Sure.
Good afternoon, everyone. Today I'll be presenting a case of a patient, Manoj, 65-year-old male, resident of Faridabad, shopkeeper by occupation, presented to ENT OPD with chief complaints of non-healing ulcer on the right side of tongue since 3 months and swelling in right side of neck since 1 month. History of presenting illness. Patient was apparently well 3 months back when he noticed an ulcer on the right side of tongue, which was insidious in onset, initially the size of a pea, that is approximately 1 into 1 centimeter. It gradually progressed to the current size, that is around 2 into 3 centimeter. It was associated with bleeding on touch, associated with pain on touch, and there was no aggravating or relieving factors. It was associated with pain on touch for 3 months, which was insidious in onset, gradually progressive, moderate intensity, dull aching. There was no radiation, reference, or migration of pain, and it was aggravated on taking spicy food, chewing, swallowing, and relieved on taking medications. Patient noticed a swelling in the right side of the neck since 1 month, which was insidious in onset, gradually progressive, initially the size of a pea, which is around 1 into 1 centimeter, and now progressed to the current size, that is 2 into 2 centimeter. It was not associated with pain or redness or fever or discharge. There was no aggravating or relieving factors. There is no history of trauma, no history of any dental intervention, no history of usage of dentures or sharp tooth. There is no history of earache, no history of excessive salivation or difficulty in swallowing. There is no history of any foul breath from mouth. There is no difficulty in protrusion of tongue, no history of deviation of tongue on protrusion. There is no history of difficulty in speech, no history of change in voice. There is no history of loosening of teeth. There is no history of cough with sputum or blood in sputum or shortness of breath. There is no history of abdominal pain or jaundice or pruritus. There is no history of headache, vomiting, or seizures. There is no history of any deep bony pain or joint ache. There is no history of loss of appetite or significant weight loss. And there is no history of any other ENT complaints. Past history, patient is a known case of hypertension since 25 years. He is currently controlled and is taking tablet amlodipine 10 mg once daily for the past 10 years. He is a known case of diabetic mellitus type 2 since 20 years, which is also currently controlled on tablet metformin 500 mg twice daily for 8 years. There is no history of bronchial asthma, tuberculosis, coronary heart disease, or syphilis. There is no history of blood transfusion. There is no history of any non-drug allergy. There is no history of any previous surgery. Socioeconomic status. Patient studied till 12th standard and he belongs to a 4-membered family, lives in a Pakka house with per capita income of rupees 5,000. He belongs to upper lower class according to the modified Kupuswamy scale. On personal history, he is a non-vegetarian by diet. The bladder and bowel habits are normal. Sleep-wake cycle is adequate. He is a chronic smoker since 25 years with 25 pack year of cigarette smoking history, which he stopped smoking since 3 months. He is a non-tobacco chewer since 25 years, and he is non-alcoholic. In family history, there is no history of any similar illness or significant illness in the family.
Good afternoon, sir. So should I proceed with physical examination?
No, just hold on, Dr. Karandeep.
Yes, sir.
Why is so much information you need? This is probably a straightforward case. You have mentioned socio-economic status, this and that. Better to speak less because you might be in trouble. Okay, my view is this. So only the relevant things. You were mentioned radiance, then reference, then one more word of pain. This thing better avoid. There's no reduction of the pain in the anywhere else. So you have mentioned radiance, migration. One more was reference. So better to avoid all these adjectives.
Okay, sir.
Just to avoid the further question from examiners. Less we speak, better it is. Okay? Dr. Rathore, you're nodding. Are you with me on my same page or?
No, I am with you, but now they have mentioned these things, so let them explain.
Okay.
Why they have asked all these things. You understand? These are the. Now, doctor, can you explain, as sir has asked, about these points? What is the importance? Why? What was in your mind?
Okay. Actually, we want to know if there is any referred pain in case of if the base of tongue is involved, then the
The commonest referred pain,
otalgia.
Otalgia. So, is it due to pressure, or what is the reason of this referred pain?
This is because the posterior part of the tongue, that is base of tongue, is supplied by the glossopharyngeal nerve, and there is the Jacobson nerve is supplying the air. So there is connection.
You asked some questions related to radiculopathy also. Why did you ask that? You asked something of causalgia sort of situation, which is a radiculopathy. But why you in this case? What is in your mind? Hello?
Yes, sir. Sir, we want to rule out whether there is a localized nerve involvement or not.
Localized nerve involvement.
Whether the pain can also be because of the nerve involvement in the since the patient also has a neck swelling, it can involve skull base and the
Don't give this. See, commonest feature in base of tongue is the type of swallow.
Yes.
What type of swallow they will be having? Suppose it is a left side lesion. Left side base of tongue lesion is there. So first thing the patient will do, he will swallow its saliva in angled manner.
Yes, sir.
Means the tongue will be twisted in that because it is not functioning properly. So you should give more emphasis on type of swallow, what type of difficulty, whether it's liquid, whether semi-solid, these sort of things. Aspirations, these are common things you should do. These radiculopathy and very rare. It happens. This skull metastasis is so less. Okay. And I'll request other other faculty members also to ask on basis of history.
I think, thank you, Dr. Rathore, Dr. Nitin here. Like Dr. Sunil had very rightly said, if we are talking of, generally these cases are either given as a short case or as a long case. If given as a short case, of course, very little but very relevant information need to be told to the examiner. And yes, even if it's a long case, I think some of it was superfluous because unnecessarily it will lead to some questions which would be asked because certain times there's a repetition also. So I agree that we stick to the very basic fact of the case so that discussion later on the management part can be focused, which I think is better to do for the student.
I think you can proceed now further.
Coming on to the general physical examination of the patient, the informed consent was taken before proceeding with the examination. Patient is conscious, cooperative, and oriented to the time, place, and person. The general condition of the patient was fair. Patient was afebrile and touch and was stable. Patient is well nourished with the BMI of 23.25. The blood pressure was 130 by 90 millimeters of mercury.
Just again hold.
Yes.
Why you are BMI? We are not concerned with BMI. We are ENT people. We are not physician. We are not diabetologists. Then I'll ask you what is the BMI, how we calculate, what is normal, what is abnormal. So avoid all this.
Okay, sir.
I agree, Dr. Sunil. No need for so much of information. Please, I think they should understand general physical examination, just the patient conscious, cooperative, afebrile, well nourished, BP so much, pulse, so that you focus on what your condition is exactly. That's what we want to come to. I mean, there's no point, in giving such a, you're not an MD medicine student. I agree very much. Keep it very basic.
Can I just come in? I'm Dr. Mandal.
Dr. Mandal, sir.
Yeah,
Namaskar. Please
Namaskar. Namaskar. Yeah, what I want to say is probably what they are hinting at, what is probably relevant is the recovery of the patient or toxicity as a result of this thing. So what they can comment on probably is the nutritional status. Okay. If you have to comment on the nutritional status in 1 or 2 lines. Okay. Everything else seems to be superfluous, and basically you are dragging the examiner in a spot where you can be in trouble.
Rather inviting the trouble from examiners.
Yes, that's what I'm saying.
Shall I proceed?
You can make a comment on the nutritional status in a single line.
The blood pressure was 130 by 90 millimeters of mercury in the right arm in setting position. The pulse rate was 88 per minute in the right radial artery, regular, good volume, no radial or femoral delay. The respiratory rate was 18 per minute. Clubbing was present.
Can we come to local examination if
yes, sir.
Faculty member, because it will be as a short case to you. So you give that local examination properly. Otherwise, anything positive in general physical?
No, sir. Only clubbing was present, sir.
Clubbing, okay. Okay, all right. We'll take care of that. So locally, I think you can now proceed with local.
Coming on to the local examination. On examination of the oral cavity, mouth opening was adequate. Orodental hygiene was fair. On inspection of the lesion, there was 2 into 3 centimeter ulcero-proliferative lesion present on the right lateral border of the tongue, extending from the right lower first to third molar, and it was present in the posterior half of anterior 2/3 of the tongue. Lesion on inspection was not crossing the midline or involving the tip of the tongue. It was not involving the floor of mouth, alveolus, or the right buccal mucosa. The lesion had irregular surface and irregular margins. The margins were also raised and everted. The sloughing was present and the base was yellowish gray. Coming on to the palpation of the lesion, there was tenderness was present. Inspection findings were confirmed. The size was 2 into 3 centimeter ulcero-proliferative lesion with everted edges, and surrounding induration was present 1 centimeter around the lesion, and induration was 1 centimeter away from the midline and 2 centimeter away from the tip of the tongue. There was bleeding on removing the slough which was covering the floor. The lesion was not involving the floor of mouth, alveolus, right buccal mucosa, or posterior 1/3 of the tongue. The tip of the tongue was free from induration and was mobile. There was no induration on the base of tongue. On the examination, the lips, vestibule, buccal mucosa, gingivolabial and the gingivobuccal sulcus, hard palate, retromolar trigone, there was no abnormality detected. The teeth were normal with nicotine staining. There was no loosening of the teeth. On the dental formula, on the bilateral upper and lower jaws, all the teeth were present. Coming on to the indirect laryngoscopy, the base of tongue was normal. Epiglottis, vallicula, there was no abnormality was detected. Bilateral 2 vocal cords and false vocal cord, they were mobile, and there was no abnormality over there. Bilateral arytenoid, the aryepiglottic folds and the piriform sinuses, no abnormality was detected, and the glottic aperture was adequate. Coming on to the examination of the neck, on inspection.
Dr. Singh, can you repeat the palpatory findings?
Yes, sir. Sir, there was...
Just briefly.
Yes, sir. Sir, the lesion was tender, 2 into 3 centimeter size, and present on the right lateral border of the tongue with everted edges, and there was surrounding 1 centimeter induration. The induration was 1 centimeter away from the midline and 2 centimeter away from the tip of the tongue. And it was not involving floor of mouth, alveolus, or buccal mucosa, or the posterior 1/3 of tongue.
No, it wasn't crossing the midline?
No, sir.
No.
It was
Base
just
tongue?
right. No, sir.
What about the floor of the mouth?
Sir, it was not involved, sir. No induration over there.
Okay. Okay.
Sir.
Why we are interested on all these findings?
Sir, for treatment aspect, sir, we have to know the surgical extent of the so that surgical margins can be planned accordingly, and the subsequent reconstruction also.
Reconstruction in this case?
Sir, if it is involving the mandible or floor of mouth, we have to plan it accordingly, the treatment part.
Why the base tongue is involvement is important? Can you hear me?
Yes, sir. Yes, sir.
Why the base tongue? We are much worried about the base of the tongue, whether the induration is there or it has gone there. Why we are interested in to know about it? And why we are interested to whether it is crossing the midline, yes or no? Why? What is the importance? Obviously, you told me, but the basic reasons.
Run surgical anatomy. Remember that. Tell everything.
Base of tongue is a part of oropharynx. That's why.
And sir, if it is crossing the midline or involving the base of the tongue, the function of the residual tongue, sir, it will
get reduced.
It will get severely reduced, sir, and we have to plan the reconstruction accordingly so as to maintain appropriate quality of life.
So what about the involvement of the lymph nodes, the possibility of lymph nodes contralaterally?
Increase when the size increases, the chances of lymph node metastasis also increases, sir.
And if it's
crossing midline.
If it's in the midline, then it can go to contralateral line.
Yes, sir.
There's so many things, so many factors. That is why we are interested to know about this.
Yes.
Okay, so can you summarize so far your case?
One question, Sunil.
Okay, can you answer?
Yes. Karan?
Yes, sir.
You have to rule out parapharyngeal space and carotid involvement. How have you ruled out in your examination? Surgical anatomy of oropharynx is important. Okay.
Yes, sir. Sir, I have examined the cranial nerves 9th, 10th, and 12th, and also I have examined the carotid pulsations.
So, in this case, is it important?
So
in this case?
In this case, since the lesion is not in, sir, it is a limited lesion, not involving the floor of mouth or posterior after tongue. So it will be unlikely that
it is important. Always don't say that it is not important. Malignancy is common and malignancy behaves very differently. Okay. So if you are given a choice that you palpate now neck, where will you palpate first? Neck for nodes. Okay.
Sir, I would like to palpate for the level.
Sir, level 2, 3,
level
and
2.
4.
You don't want jugulodigastric?
Yes, sir. Level 2. So level 2, 3, 4.
You want level 2 first. Okay.
Level 2.
You know the lymphatic drainage of base of tongue.
Yes, sir.
So suppose this is a adjoining malignancy of soft palate also. So will it make any difference in your lymph node? Hello.
Yes, sir.
Question पहुंच गया ना?
Yes, sir.
Sir, it will reach to level 2 and 3 if soft palate is involved.
नहीं, दोबारा से बोलो, कुछ क्लियर नहीं आया. दोबारा. Hello. अभी को?
Yes, sir. Sir, if soft palate is involved, then it will drain to level 2 and 3 lymph nodes.
Suppose soft palate is involved in adjoining area. So you are saying 2 and 3 will be involved.
Yes.
Any other thing which will be involved earlier? You know, when soft palate is involved, then it is very difficult to treat surgically this patient, because repair of soft palate is nearly impossible to get. Okay, hard palate you can do something, but soft palate functionally is almost impossible to get. Okay, and plus because it is a very rich lymphatic area, so you may get a involvement of retropharyngeal area also.
Yes, sir.
All right. So that is why the people avoid doing any neck dissection once the palate is involved by this malignancy. So these are all things you should know before. Okay. Now continue as Professor Sunil has done guided.
Okay, sir. On examination of the neck, on inspection, there was a 2 into 2 centimeter size single swelling present in the right upper part of the neck, approximately 1 centimeter anterior to the angle of mandible, 1 finger breadth above the level of hyoid, and 1 finger breadth below the lower border of mandible. The surface was smooth, margins were well defined, the overlying skin was normal, there was no scar, sinuses or fistula, there was no visible pulsations over the swelling, no discharge or erythema. On palpation of the swelling was non-tender, local temperature was not raised, the findings of inspections were then confirmed.
Dr. Karan, I would like to interrupt here. When you're talking of neck examination, especially when you're talking of malignancy, you have to talk in terms of the levels of the lymph nodes. This is the standard practice now, whether level 1, 2, 3, 4, 5, right side, left side. So this is okay if you're talking just of a single swelling. But here you're talking in reference to the draining lymph nodes when you know that there is a primary in the neck. So I think it is much better you talk in that term, because your disease clearance is also going to be based on that itself. So your plan of action, whatever surgical clearance also will be based on the levels. So I think it's always better. So you need to tell about level 1, 2, which one you want to tell over here.
The swelling was present in the right level 2, and after on palpation, the surface of the swelling was smooth, regular margins, firm in consistency. It was mobile, not fixed to underlying structures. Skin over the swelling was pinchable. There was no palpable pulsations over the swelling. There was no thrill, no bruit. The trachea was central in position. Laryngeal crepitus was present. Laryngeal tenderness was absent. Bilateral carotids were palpable. On cranial nerve examination, 9th, 10th and 12th nerve examination, no abnormality was detected. On examination of nose and ear, nose abnormality was detected. Systemic examination, there was no abnormality detected on examination of the cardiovascular, respiratory, on CNS and the per abdomen. So my provisional diagnosis would be the patient is a 65 years old male with hypertension and diabetes, which are controlled, and a known smoker and a tobacco abuser, with 2 to 3 centimeter ulceroproliferative lesion on the right lateral border of tongue and ipsilateral level 2 lymph node, 2 to 2 centimeter in size, and it is a most likely a case of carcinoma of the right lateral border of tongue with neck metastasis.
So this is your summary.
Yes, sir.
Okay, but this is if you want to write a diagnosis, this big will not be acceptable, no?
Yes.
So if we say that let's know the diagnosis, how would you write?
You have to give the stage. You haven't staged it.
I cannot stage this at this point of time, because to properly stage it, I would need to know the depth of the lesion according to the AJCC 8 criteria.
No, clinically you can still diagnose. Clinical.
Clinically, it is T2N0MX, sir. T2N1MX, sorry.
Okay. So how would you go further from here?
Sir, from here, I would like to do investigations first to confirm the diagnosis, then investigations to support the diagnosis, then investigations to stage the disease, and after that, the investigation for treatment, sir.
No, doctor is saying you will give options to the patient. You will explain to the patient what he is having.
Yes, sir.
Don't jump to the investigations that I will do this. So first explain, because explanation and counseling is very important these days.
Yes.
To avoid all medical legal issues. Yes. I think all panelists will agree with me, because these days don't jump to that send to MRI, send to CT, this. You must explain, must give the options to the patient that this is, you are having this. These are the possibilities, and this is how we going about further.
Yes.
So these are your formative years. Start all this.
Okay, sir.
Okay. Otherwise, once the habit sets in, it's very difficult to change.
And so since the patient has presented to me, I would explain the patient that since he has been a chronic smoker and tobacco abuser, this lesion is most likely a carcinoma, which has now also metastasized to his neck.
Let's say I am the patient. How would you counsel me? How would you explain this bad news to me?
Okay, sir. And sir, I would explain that since you have been.
No, I am not, sir. I'm a patient. I'm the 65-year-old male.
Okay, sir.
इधर जैसे बोलते हैं ना वैसे हिंदी में समझा दो.
समझाओ कि
ओके सर,
क्या बीमारी है, पहले बार बता रहे हैं मरीज को, इसके बारे
कैसे बताओगे?
ठीक है सर. Sir, I would explain that क्योंकि आप बहुत टाइम से you have been a smoker and a tobacco abuser. So जो आपके टंग में जो जीभ में लीजन है, that is most likely कैंसर बन गया.
लीजन तो उसको पता नहीं लीजन क्या होता है.
तो घाव जो बना हुआ है आपके जीभ पे, वो मोस्ट प्रोबेबली एक कैंसर का गांठ बन गई है. तो उसके लिए हमें, और जो आपके गर्दन के अंदर भी पहुंच चुका है तो उसका जो कैंसर है, तो इसको आगे में इलाज के लिए मतलब सर.
डॉक्टर सिंह, मैं अकेला आया हूँ, मेरे साथ में कोई नहीं है, तो वुड यू लाइक टू आस्क कि भाई तुम्हारे साथ में कोई है, नहीं है, माँ बाप भाई बहन बच्चे, या सीधा ही मुझे खड़े खड़े ही समझा दोगे सब कुछ ये बात?
वो सर,
you know, it is very difficult to convey these bad news to the patient.
Yes sir.
We are still learning all this art. तो क्या कैसे, how would you start?
Okay sir.
You consider me as a patient.
Okay sir. आपके साथ कोई आज आया है या आप अकेले ही आए हो सर? I would prefer to know that first.
डॉक्टर साहब, मैं तो आज अकेला ही आया हूँ, बस आप बताइए क्या क्या आप कहना चाहते हैं?
अच्छा, तो एक्चुअली जो आपके जीभ में जो आप घाव है आपके जो 3 महीने से है, वो
अरे बेटा उसको go ahead.
If the relative lives nearby, then the relative can come, or
so we can ask the patient to call the relative before breaking the news.
बेटे उसको पहले बिठाओगे कहीं किसी आराम जगह से. This is ideal situation. Although ideal situation are not there in our OPDs, but we must inculcate all these habits. Okay, उसको बिठाओ, यदि आसपास में उसके कोई रिलेटिव वगैरह हैं या कोई साथ में है, उनको भी बिठाओ. Then you open up this news. Okay, am I clear, sir? Do you want to agree all the panelists?
Yeah, absolutely. Breaking the bad news is very important. They must learn, and as you rightly said, all of us are still learning.
Karandeep,
yes, sir.
Always make patient comfortable.
Yes, sir.
Eye to eye contact should be there. You should be always empathetical and positive in your approach. Don't say that because it is early stage, so you can always consider about positive things, because it is a shock to the patient. It's a question of life and death. All right. Always keep a hand on his shoulder. So these are common physical gestures which you can give to the patient. Then once he is comfortable and is keeping a hand on the shoulder is not just to support. You have to see his pulsation there, so that he doesn't go after you break the news. He doesn't go down. So all right. So these are all practical techniques. So make him comfortable. See positive things. Be firm but positive in your approach. All right. Because as a surgeon, you should not give wrong hopes also. That I'll do that. This is not truly say everything. Okay. In our setup, we are doing these things.
Sir, I'm deliberately bringing these topics into discussion because in our days we were never, these things were not really discussed. So in modern days we must inform these graduates or postgraduates that these things are very important.
The communication
one more thing. One more thing is when you're telling it to the next of kin, just confirm how close that patient is, whether he is a relative, whether he's a son, daughter, cousin, or a nephew. You must also assess the relation, or the next of kin relation, as to whom you feel you want to break the news. That's also important.
I think with with most of the training programs now being skill based, so the communication skill part is, I think, very, very well highlighted, and definitely our resident doctors need to learn this skill. It is a learned skill, like you said, and everybody would keep learning. Very important. I think you can proceed.
Yes, Doctor. Karandeep, is it a disease of rich people or poor people? What you are giving us?
Poor people.
Why do you say so?
Because tobacco chewing is more common in lower class
Very good. What else?
And bidi smoker.
See, it is a poor anabolic state. They remain in a poor anabolic state. So the complications are likely to be more.
Yes, sir.
Plus alcohol as well as tobacco, chewing as well as smoking. These are important factors. This is common in our lower socioeconomic strata. So this is the reason for this, because you know the supportive role of alcohol as well as smoking. You know,
Yes,
both
sir.
have a supporting role for each other.
Yes,
So the incidence also rises. You have to explain all these things, how they are connected. Okay, so now I think now we can. The faculty agrees we can ask for investigations and other things.
Yes, we can proceed on to investigations.
And we would like to, after history examination, we would like to get imaging done for our patient since his swelling is small. In imaging, we would prefer MRI because we want to delineate the soft tissue, and if we want to rule out if there is any bony involvement, we would like to get contrast intensity also done, and then we would like to do we would like to take biopsy of the lesion.
See, when you talk of investigations, you should always talk of the routine investigations and specific investigations.
Yes.
Obviously, you'll be taking up the case later on for surgery or for some other management. So routine investigations, which of course would include the ones which are required for a GA or whatever. And then of course the specific investigations. So you have to talk in those terms.
Yes. And we would like to take the photography of the lesion also. And after normal routine investigation, we would like
No, just hold on. Why photography?
so that we can see post-op, we can compare
Post-op compare?
for medical legal purpose, MLC.
This is not a medical legal case.
No, but the patient can later make it into a medical legal case if he wants, if there is recurrence.
Are you taking routinely all these photographs?
Yes, sir. We usually do take photographs of lesions.
And during the planning of treatment and when the treatment starts, we want to see if the growth has.
Taking photographs. See, as far as taking biopsy, doing all these investigations, this is all mandatory requirement. Okay, before you proceed with the case, you could do that for documentation purposes, for teaching purposes. That's another thing. There's, of course, you can always keep all the data for other purposes, but definitely it's not part of the workup as such. If somebody asks you about a routine workup for a rhinoplasty, preoperative photographs have a role, but there's no preoperative photograph for a DL-scopy or for an intraoral examination. It's your findings which are written in the file or a card or whatever documented, which is more important apart from the other investigation.
Very correctly said. Dr. Karandeep and Abibo,
Yes, sir.
now you have said CT scan and MRI.
Yes.
Out of these two investigations, which one gives over assessment of the lesion?
So CT scan is the standard preferred choice.
Yes, correct. It is CT scan will be preferred. I agree. But if there is a question of over assessment, see, tumor will be there surrounding mucosa will be swollen and so many things will be happening. Okay, with each swallow with of the genoglossus, the tumor cells will be pushing in the lymphatics or in deeper structures. Okay, so this is the situation with the patient. Now, over assessment, which investigation is likely to give more over assessment?
So MRI.
MRI. Why do you say so?
So because in MRI, we are basically assessing the soft tissue aspect of the lesion. And with every swallow answer, as you said, sir, the soft tissue lesion can appear more enhanced.
No, tell me, with respect to local lesion or with respect to perineural or vascular spread, you are saying to me?
Sir, local.
With respect to local?
Yes, sir.
You are not interested in perineural or perivascular spread?
We would like to know that also.
MRI has advantage because of these 2-3 things. Okay. So over assessment is due to the surrounding tumor local swallowing of the mucosa. Then MRI has a benefit because over the CT because it gives a good vascular as well as neural spread of the tumor. So staging and assessment will be accurate in this. Okay.
And assessment of neck nodes is also better because we're doing that at the same time. So MRI would also help.
Okay, you have to explain everything when you are presenting the case.
The advantage of CT scan is the relation of the tumor to the bony structure, especially the mandible. That is where a CT scan would score over MRI. Otherwise, because it's a muscular structure, most of soft tissues, MRI has an edge over CT in assessing.
Now comes biopsy.
Yes, sir.
Main issue is about biopsy. Tell me something about biopsy.
We would like to get edge biopsy from the lesion, probably the anterior part of the lesion.
What are your concerns when you take a biopsy in such patient?
The mouth opening should be adequate. The patient should be covered.
Everything is adequate. You tell me about lesion. From where you will take? You will take single or multiple?
In this patient itself, you're talking of this patient. So
yes, you want single biopsy, multiple biopsy. You want vital staining.
We'll take a single lesion biopsy from the anterior part of the lesion. So we would like to take from this portion.
But that you see, the lesion of posterior margin is very dangerous for any surgeon. All right. So you want to take biopsy from this area, not from the posterior margin. Is there any rationale behind it?
So because we do not want to extend the posterior margin further posteriorly.
Okay. So you want a proof with you. Okay, very good.
Yes.
Any other thing? Do you want some staining before the biopsy?
Sir, it does not appear to look to involve. Sir, it does not appear that it may involve other sites. So vital staining would not have much role.
Biopsy you will take in general anesthesia or local anesthesia?
Sir, local anesthesia.
Local anesthesia.
So general anesthesia because bleeding might occur, which we may not be able to control. So preferably.
So what is your answer? Is it general anesthesia or one is speaking general? What is your answer? General or local anesthesia? Why do you prefer a general anesthesia?
So because if the patient bleeds and we are not able to control that bleeding, so the patient might aspirate. So
Doctor Singh, you let me know, you take under GA or under local?
GA.
You take all these biopsy under GA? Yeah, don't tell me this.
You
Sir, under local.
You don't, please. Your HOD is sitting there, Dr. Ravi would be there. Don't tell me that you are taking all this GA.
So we take under local anesthesia.
So routinely you will be taking that under local anesthesia, no? Until unless for some reason it's come negative or there's so much pain. That's another matter. Although there will be certain. Anyway, is there any other advantage of doing under GA? I do agree that bulk will be doing under local, but still any advantage? What about the assessment of induration when you take up such a patient under GA? Does it help? What about the spasm of the muscles of the tongue? Am I audible?
Yes, sir.
अरे जब GA देना तो इसको निकाल के इसका रेडिकल भी कर दो ना यार, फिर तुम GA दे रहे हो तो यार क्या तुम this is inviting a trouble.
So bulk of the cases are going to be done under local anesthesia, isn't it?
Yes, sir.
Sure. Okay, proceed.
Currently, deep, if suppose it is a indurated lesion, not a cauliflower-like outgrowth. So what other things you will do in biopsy?
Sir, if it is infiltrative, sir, we would first like to make an incision over the lesion and then take a deep biopsy.
Deep incisional biopsy, very good. Very. proceed further.
So after taking the biopsy, then since the patient is having a node in the neck, we would like to get ultrasound of the neck and including with that FNAC of the neck node.
My ears are burning, sir. I mean, once you have taken a biopsy, what is the need of FNAC now and ultrasound? Is there any advantage of it? You're wasting your resources.
Sir, in tongue lesion, the patient can have, sir, sir, we have look for, sir, any lymph node or any occult metastasis which we might have missed clinically. We want to, sir, confirm that.
Dr. Karandeep, you have a lymph node already on palpation, and you are subjecting this patient to MRI scan, and now you want to do an ultrasonography for the neck and FNAC also. How FNAC is going to change the management?
Yes, sir, it won't change the management.
So the management, you're anyway going to address the neck, isn't it?
Yes, sir.
A palpable node in the primary echelon drainage area has to be considered as positive lymph node, irrespective of whether you get a FNAC, positive on FNAC or you don't. It has to be considered as a positive node.
That is why in the beginning I said write minimum, speak minimum, which is really relevant. Otherwise, these questions will come up again. Getting my point?
Yes, sir.
Yes, sir.
Okay, carry
Asking for superfluous, investigations which does not actually add to diagnosis or management is basically raising the cost of care and denying it to so many others in a resource-crunched society.
And a lot of important time is also lost. I think the most important was a biopsy which has to be taken at the earliest, and practically it is taken under local anesthesia. It saves time, and I think we can proceed with the management much earlier then.
I tend to agree with Dr. Nitin because I think I also felt this similarly. First, you should tell about the histopathological diagnosis on the basis of biopsy because the report also takes some time, 4 to 7 days to come. And then you go for imaging because imaging reports will come earlier.
I think I'll differ with this. I think we should get an imaging first before the biopsy.
Sometimes biopsy might change the overall picture. That I agree with Dr. Arora.
All right.
Okay.
Go ahead.
Abibo, can you answer based on your history and examination? What are the synchronous malignancies you have ruled out?
So we've tried to rule out from the oropharynx, then from the
Specifically, you answer me, what are the common areas you will look? And you have taken care of all of them.
So we have ruled out carcinoma larynx, and because since he's a smoker, and we have also ruled out, sir, carcinoma lung also. Yes, sir, synchronous of that one.
So you have to see
esophagus also because
aerodigestive tract. Just answer in a simple manner. Aerodigestive tract ruled out.
Yes.
Because further investigation will depend on all these factors.
Yes, sir.
Okay. Carry on, but what do you want to do?
So after this, I would like to go for a wide local excision of the lesion, taking 3-dimensional 1 centimeter margin around the tumor. And
before taking the patient under GF.
No. You had to do the staging. You said you take the biopsy. Now the biopsy has come as suppose keratinizing squamous cell carcinoma, because that time you said that you will get the biopsy, then you will stage the disease. Yes. So it's high time we stage the disease because all the management is going to depend on that.
So, sir, most likely it is a T2, N1, and MX. Sir.
Why MX? You have already assessed in that case.
So M0, sir, after imaging.
Stage?
Stage 3.
2? How can it be? When it's N1, it cannot be stage 2 anymore. You should do the staging correctly. It's stage 3 now.
Yes, sir, stage 3.
So what is the plan of action for a stage 3 carcinoma of the tongue?
Sir, wide local excision taking 1 centimeter margin followed by modified radical neck dissection and adjuvant radiotherapy.
Wide local excision means you have to give exposure. How will you, which route you will take?
So, since it is located in the middle third, we can take a transoral approach.
What neck dissection will you do?
Some modified radical neck dissection.
Incision in the neck?
We would like to give to prevent these complications, it's better we give McPhee incision.
McPhee? Why McPhee?
There is no trifurcation point, and
McPhee.
temperature will be less.
McPhee for radiotherapy, doctor.
What is McPhee incision?
We give a U-shaped incision in the lower part of the neck.
Which McPhee? McPhee is a double horizontal incision given post-radiotherapy cases. It's not the one I think you would recommend here.
Sir, we can give a modified Schobinger incision. There are various types of incisions.
What about the lip split?
In this case, the lip split will not be required because we will be able to assess, sir, take out the lesion for oral approach.
Okay. Any role of frozen section?
Sir, actually a frozen section is not preferred because even if we take, first of all, it is expensive and it is not going to affect the outcome of the primary treatment or the 5-year survival rate. And even if the margin comes positive, it is difficult to identify the biopsy site.
No, sorry, can you say that again? Even if margins comes out to be positive, then?
The site from which the lesion has been taken, it is difficult to identify.
No, but so there is no role of intraoperative margin assessment by frozen. That means you are doing it by the technique is incorrect. You are actually, if a margin comes out to be positive, you are supposed to smear that surface with the ink, and then you need to revise the entire margin. Certainly, it won't be possible where exactly you took the sample from, but you need to revise the entire margin. So there is certainly a role of frozen section in management of oral cancer.
How will you do the closure of the tongue? Will you do some reconstruction? What's the plan?
Sir, it would depend upon the amount of tongue we have resected. Sir, if it is more than 30%, we will do reconstruction flaps via microvascular free flaps, sir. If it is less than that, we can go for primary closure, sir.
What are the advantages and disadvantages of both of them?
Sir, if we are not doing a reconstruction and we are doing just a primary closure, then there would not be optimum swallowing and articulatory function of the tongue. And the patient will have decreased quality of life. However, if we do a reconstruction via radial artery free flap or an ELT flap, it would certainly improve his quality of life and via his speech and swallowing, sir.
After how long would you give radiotherapy to this patient?
Yes, sir.
How long?
After 4 to 6 weeks.
I have a question for you.
Yes, sir.
How would you decide whether this patient requires radiation or not? Or is it given to all the patients?
We can look at the general condition of the patient. If the patient is not fit for surgery.
No, adjuvant radiation.
So the indications would be, sir, extra capsule in the post-op histopathology. If it comes like if there is extracapsular spread or vascular permeation or perineural spread, or sir, there are in histopathological report we see that there is poorly differentiated carcinoma, or the sir there. Yes, sir. If it is with multiple cervical lymph node metastasis, we would like to give radiotherapy in this patient.
You'll have to talk about the primary, first of all, close margins or positive margins. Then you're talking of the neck, extranodal. So you'll have to talk for both of these.
Yes, sir. It would depend on the margins and the thickness of the tumor, differentiation of the primary tumor, and then, sir, it will depend upon the nodal status in the pathological report.
Suppose there are multiple positive lymph nodes.
Yes, sir.
And you have done a neck dissection. Would you give radiation?
Yes, sir. It is one of the indications, sir, to give radiotherapy.
If there is one single positive lymph node in the neck dissection,
sir,
we can do selective neck dissection.
Sir, we can just follow up this patient without giving radiotherapy if there is no extracapsular spread.
Dr. Singh.
Yes, sir.
All this, the surgery, this and that. Suppose the family comes back to you.
Yes, sir.
Ask you, doctor, can this happen to our family? So how would you explain to them? They are much worried that this has happened to my father, this can happen to me, my kids,
yes, sir,
and my brothers, sisters. So what would be your answer?
So my answer would be that if it is a behavioral tumor, it depends upon your particular smoking and your...
No, behavior is okay.
Yes, sir.
But it's not that everything tobacco and alcohol it causes. I have seen many tumors where the people don't smoke or drink. They have these kind of things. So what would be your answer to the family, preventive aspects, and your explanation whether the children can have or grandchildren can have or the other family members can have? So what would your explanation and answer?
So squamous cell carcinoma of the tongue is not a familial disease, so it is unlikely that the siblings or the children will have this squamous cell carcinoma like this patient. So, in preventive aspect, I will advise them to not ever smoke or take alcohol, tobacco, and yes, sir.
What should be the follow-up plan for this kind of patient after your treatment is complete, number one? And what is the role of PET-CT in these kinds of patients in the follow-up, provided it's available?
Yes, sir. Sir, I would like to perform a PET-CT after radiotherapy.
What is the routine follow-up plan, first of all?
Okay, sir.
The patient has to come for follow-up. This has to be explained very well, of course, to the patient and relatives.
Yes, sir. Sir, follow would be after 12 weeks. I would like to perform a PET-CT. Sir, after 7 to 10 days, I would like to do a suture removal first and then assess whether it has healed or not. And depending upon the post-op histopathological report, I would advise the patient for radiochemotherapy.
डॉक्टर साहब मेरे पास तो पैसे ही नहीं है मैं कहाँ से कराऊंगा
LNJP में फ्री है
अरे this is the problem this is the problem that LNJP में है तो वहाँ सब करा boss LNJP is
so in the most of the government hospitals in India it is free
but I don't have a machine in my hospitals how can I get it done you must explain the importance of that PET scan to the patient then only he will agree.
Yes, first and foremost, to tell a routine plan of your patient, which has to be done on a clinical examination or ultrasound or whatever. There are very specific indications for the use of PET-CT. This is my question. So first you tell what would be a routine plan of follow-up for this patient. Suppose he's completed this course of whatever radiotherapy also. Patient will come to you for follow-up, stays in Delhi or close by. How often will you call the patient for follow-up? Three monthly, 6 monthly for a year, every year, lifelong, something you have to tell the patient. He will think it is just like any other orthopedic issue I have sorted out. I don't need to come after 2 months. Is it correct?
Yes.
Patient will have to come to you lifelong. Or no?
After 12 weeks, we would like to get PET CT scan done.
Again and again I'm saying PET CT is not available in most of the parts of our country and very expensive. There were two parts of my question. The first part was very clear. What should be the routine follow-up plan? And what are the specific indications for a PET CT is a separate part of the question, which we'll talk later in that case. So you just tell what would be the routine follow-up plan of this patient after the surgery is over, the radiotherapy is complete. Should the patient come regularly for follow-up, yes or no?
Yes, sir.
Yes, there is no confusion, yes.
Yes, sir.
Because it's a malignancy. You know, recurrences can occur.
Yes, sir.
There are always issues, especially the first 2 years are very important.
Sir, I would like to call the patient quarterly for the first 2 years, and then for the next two years, I would like to call the patient 6 monthly. Then subsequently yearly, I would like to call the patient for follow-up.
Vivo,
Yes, sir.
what will you see in a follow-up patient? What will you ask?
Sir,
You are worried about some recurrence. So what will you ask from him?
we'll see if there is, so in the oral cavity, we can see if there's any lesion reoccurring in the same site, or in the neck, we can see if there's any.
That you will examine. First, you will ask कि भाई ये तो नहीं है आपको, वो चीज पूछ बताओ क्या important होता है. In oral cavity, you have to see pain and trismus. Okay, you will ask yourself. Then you will go for assessment yourself. All right. So these are the common features of recurrence. Then neck you will see.
Yes.
Suture line you will see. Everything you want to see palpation. All right. These are the common things.
Sorry to interrupt, sir. We just have 5 more minutes for the discussion, and then we can wind off. Thank you.
Any role of chemotherapy?
Sir, in our case, chemotherapy is required, but if it is a large lesion, then we can give chemotherapy.
If there is extracapsular spread, then chemotherapy is indicated.
भैया आरटी तो दे रहे हो बेटा उसको, उसके लिए तो okay. So from my side, it is. I think we are done with it.
Okay.
Good to see Dr. Nitin, Dr. Rathore, Dr.
I'll ask one more. Okay. Suppose this is a larger tumor, not this much like. It is about 4 centimeter. Can you name some flaps which can be used in this type of surgery?
We can use radial artery free forearm flap.
Common things. Tell smaller flap first.
Yes, yes. We can use delta pectoral flap, pectoralis major, mycutaneous flap.
No delta pectoral. It is a tongue, most probably base of tongue. That's all situation is there. Approach will also change. Suppose base of tongue is involved, then your approach will also change. Pelvic-mandibulectomy will be there. Now tell me what are the flaps you can cover this area.
Okay.
Common flaps.
We can take if mandible is also involved, then we can take this bone flaps.
Okay.
For reconstruction of the mandible, we can take this fibular flap, or we can take iliac crest flap, which is based on the deep circumflex iliac artery. Then we can scapular flap.
What are the common lingual flaps you know? Lingual flap, pectoralis major, then DP, then radial forearm flap. That's how the ladder pattern type of repair is there. Don't just jump to the radial forearm. Okay. So you have to use all these flaps for this type of repair. Why it is so?
Because a major portion of the tongue is removed, so we want to reconstruct the tongue so that the function of the function of tongue is there.
Mostly it is lost. Okay, well, how will you address the bone? Suppose bone is involved, how will you address the bone?
So depending upon the extent, we would like to go for a marginal or a segmental mandibulectomy.
Okay, tell me, how will you decide? Confusion is this only. Marginal or segmental?
If it is less than 5 mm depth, then we'll go for marginal mandibulectomy. And if it is for segmental, we will go if the tumor is extensive, or if after we do this marginal mandibulectomy and only around 10 mm depth of the mandible is left, then we will convert it into segmental.
And doctor, in textbook, it is clearly written that if it is up to the mucosa, okay, then you take out the periosteum surrounding it. If it is involving evading the mucosa, go for a marginal mandibulectomy, whatever sort you want to decide. And suppose it is breaking the bone and entering into the marrow, you have to go resort for segmental mandibulectomy and decide your repair accordingly. I think, Ravi?
Yes, sir. I think we can stop here, and the discussion can continue for a long time, but for the sake of other presentations, I think we can stop here. And I thank all the panelists, all the senior faculty members for giving their inputs in this case discussion. And Karandeep and Abhibu, I think you need to study more and prepare well for your exam, right? After the inputs, I think you must be now aware of what are the faults and what all you have to read more.
Yes, sir.
And I thank Dr. Nitin Nagarkar, Dr. Mandal, Dr. Rathod, Dr. Sunil, and Dr. Vipin Arora for their inputs. Thank you very much.
Thank you, Ravi.
And we can proceed for the next lecture. Thanks a
Thank
lot.
you.
Thank you, Ravi.
very
Thank
much.
Thank
you.
you, sir.
Thank you.
Bye.
I'm sure the delegates found this lecture very informative. For all the final year postgraduate residents, the session will be very helpful for the upcoming exams. Next, we have a talk on the topic hearing aids by Dr. Vikas Malhotra. Sir is Professor, Department of ENT at Maulana Azad Medical College. Sir also has special interest in health information technology. Sir, please proceed with the session.
Hi, good afternoon, everybody. Very good afternoon to the seniors, my colleagues, and junior colleagues. A lot of friends here. One of the things that I'm missing this year is the opportunity to meet everybody in person that this event used to afford us every year. Dr. Ravi, I hope you'll agree with that. So basically, I've kept the topic about hearing aids. It's something that used to bother me a lot when patients used to come to me, and I used to find myself a little lacking because we did not have that much of an understanding, because we were reading about a lot of other things, but we were not reading too much about hearing aids. So I've got a small presentation.
It's about hearing aids, the past, the present, and the future. Before my presentation, I would like to say that I'm just a student. I still consider myself to be a student. I like to learn. I'm sharing my understanding of the topic. It may be incorrect or incomplete, and if that is the case, then I remain open to correction or modification. I also would like to declare that there is no conflict of interest. So how the presentation will flow is that we'll talk a little bit about the history, then the ages of hearing aids, current state of affairs, near futures, and a very exciting topic that I find very interesting is hearables. So just a brief slide about the hearing aid history. This is not the entire history. This is just, to set the stage for understanding that as far back as 2 AD, Galen, the Greek physician, described bone conduction. A lot of data was lost because books were lost, texts were there was no Dropbox to record your information in and keep it safe. So a lot of material was probably lost. But in 1521, there is a record of Cardano in Italy mentioning the use of bone conduction in order to hear better. Also by 1627, Francis Bacon described the ear trumpet in his book. And interestingly, in his book, he also said that before his description, the Spanish were already using an ear trumpet. So the ear trumpet would be predating this. To understand the progress of hearing aids, we need to understand that development always parallels technology. That may not appear to be very true to those of us who work in resource-constrained environments. There is a lot of development and technology available outside that may not percolate down to your place of work. But at least in the case of hearing aids, that has been the case that the hearing aid technology has been... Yeah.
Dr. Vikas,
yes, Dr. Ravi.
We cannot see your slides actually. Please make it full screen, and we can just see your first slide title goes there. We are not able to see your
okay, just give me a second.
You have to make it slideshow, sir.
Yeah, I am on the slideshow. Just give me a second.
Yeah.
Can you see my screen?
Yes, sir.
We can see your screen, but it is just stationary. It is not moving. It shows just...
Let me just stop the share and then restart it.
Yes.
Are you able to see me though?
We can see your slide, but not the screen. Not the show, like slide show. Please make it full screen and
yeah, it is full screen. Are you able to see it now?
Actually, we can see part of your presentation.
Just give me 1 second. Let me share it again.
Yes. Now we can see, yes.
Okay. So I hope you give me a few minutes.
Yeah, sure.
Extra. Yeah. So this is visible now?
Yes, it is visible.
Okay. So I was on this slide and I said the development parallels technology, and that has been the case in the case of hearing aids. They've moved very rapidly with the advent of technology. So when we talk about ages of hearing aids, we have to understand that the ages are a little bit of an overlap. So you will not have a clearly defined, first trimester ending, second trimester beginning kind of a situation. So they'll be overlapping, but broadly hearing aid, the ages can be divided into an acoustic age, which was the non-electric, and then the electric age, which would further be divided into the carbon age, the vacuum tube age, the transistor age, and the digital age. So the acoustic or the non-electric, this was very interesting, and you can see, I hope, the images on your screen. The first one here is the ear trumpet. We've seen these in a lot of movies and cartoons and all. So originally they were made of Feynman halls, then they moved on to seashells, and then as vanity took over, you had a very fancy design also. The second one were known as conversation tubes. Now these look like what the younger in the audience would identify as hookah tubes. But let me assure you, they are not hookah tubes. These are known as conversation tubes. And the important thing was that the broader end used to be kept close to the mouth of the speaker. And then the speaker had to speak into it. And I was surprised to know that they were sold till about 1976 because a lot of older people used to find the quality of hearing enhancement with these better than the hearing aid devices available at that time. The third one is the first hands-free hearing aid. This is also the first binaural hearing aid. These are known as auricles. These are designed in mother of pearls, obviously for some very fashionable rich woman. These are interesting. These are at the crossroads of the dentistry and the ENT. These are known as dentaphones. So these were the first bone conduction devices, and these were actually this big. And there would be a metal sheet which would be used to capture the sound as a diaphragm, and there would be a smaller pin that the people would tightly clench between their teeth so that they could hear through bone conduction. Of course, even this early stage was not free from quackery. There was this device known as the vibraphone, and the only person that these helped was the seller. It did not help the wearer. Next, when electricity came around, we came to the carbon hearing aids, 1898 onwards. So initially there were these tabletop models which has 1, 2, 4 or 6 microphones, and these were big devices kept on the dining table facing the person who was speaking, and the listener had to use a pair of earphones. As the batteries became smaller, you had the smaller stylish lunchbox models. When the batteries became smaller still, you had body-worn devices. Next came the vacuum tube hearing aids. So these were vacuum tubes, as some of you would know, are the devices that were used to make the first computers also. So again, there were bigger devices, tabletop models. And interesting is that there was a binaural device costing about 30,000 USD in today's terms. That was the largest ever hearing aid made. It weighed in about 100 kgs. Technology developed and the devices became smaller. You had body-worn two-piece because the batteries were still very large and they could not be kept into a single housing. So there was one piece that was the battery, the other piece was the hearing aid, and then this was connected to the ears through the earphones. Then came a very stylish device known as the acoustic-on wrist ear. So if you see this advertisement, it says that it makes it possible to wear an acoustic-on like a wristwatch. So this was a very small device from those times. And it was like one of the earliest smartwatches. It could help you hear better. Now, this is the point around 1952 that the hearing aids started to look somewhat like what we recognize as hearing aids today. So initially, we had transistors replacing the vacuum tubes. These were more robust, smaller in size, and had better battery efficiency. So this is one of the first body-worn hearing aids. The second image is that of one of the earliest behind-the-ear hearing aids. We also had an in-the-ear hearing aid. This was the Telex Model 23 around 1965. And then we had very smart eyeglass hearing aids. These were actually the first cross hearing aids. But this was not because of an intent. This was a fallout of the electronics being so big that they could not be housed in one side of the stem. So you had to house the electronics on both sides of the spectacles, and that technically made it the first cross hearing aid. So where are we now? Now we are in the electric age, digital hearing aids. I think we should call it the electronic age now. This started from around 1996 to the present. Now again, like I said, the ages are not very clearly defined. So Dr. Ravi and I were residents together, and we would remember Dr. Vipin also, that a lot of patients used to come in and we used to have to choose between analog and digital, and we had to explain to them analog and digital, the differences between. So those devices were still around. The difference between those devices and these was that in the analog hearing aid, either the entire processing was analog or large part of the processing was analog, because the computer processing power was very limited and slow and expensive. So you could not, and it was larger in size. So you could not build into the hearing aid too much of computing power. So large part of the acoustic signal was manipulated in an analog manner, and only a little bit of control used to be done by the digital hearing aids. Today, what is happening is that we all know that there is no limit to the amount of reduction in size that you can achieve with the semiconductor transistors and solutions on a chip. So all of these hearing aids, they are very, efficient computers basically that you wear in your ear or behind the ear. And the moment the sound is incident upon the receiver, it is instantly converted into a digital signal. And now the digital signal, we all know, can be manipulated in whichever way you can. Just try to think of it contrasting the normal audio cassette if you've used it, or the reel tape for the video, editing that compared to editing digital video on your mobile phone. There is no comparison. So it is infinitely easier to use it on the digital medium. So that is what has happened now. To my mind, most of these devices, these are three form factors. They essentially differ in form factors. Behind the ear, then receiver in the canal, then in the ear type of a hearing aid. If they become smaller, there's an in the canal hearing aid, that's the ITC, completely in the canal, the CIC, or invisible in the canal, IIC. The basic difference between these devices is the size. Now, the computing devices are very powerful. There are certain trade-offs and certain benefits. So obviously, invisible in the canal, even an ENT surgeon sitting across the patient will not be able to make out that the patient is using a hearing aid. Contrast that with the behind the ear model. So that's a larger one. The larger ones have got advantage that they're easier to handle. They are slightly cheaper. Their batteries are larger, so the batteries need replacement less frequently. Then you can build in a little more fancy circuitry into them than you can into the completely in the canal or the invisible in the canal devices. Problem of the smaller devices is that the batteries are smaller, so they have got lesser capacity and they need to be replaced more often. So that increases the cost not only of the device but also of the battery. That's a recurrent cost. Given that the average life we consider of the devices to be about 5 years, that becomes a substantial part of the cost of the battery. The second thing, which is more important, is that when I am advising my patients, I try to assess how good they are with their hands and their fingers. So the older people who comprise a large proportion of the population who need a hearing aid, to my mind, suggesting a very small hearing aid is a disservice to that group of people because that inherently introduces an element of dependence. You want to give a hearing device to the patient so that he's independent or his level of dependence on others decreases. But if you make him dependent on other people for changing the battery, for keeping the hearing aid somewhere, for taking it out, for placing it in the canal, then you're not actually doing any good service. So I try to convince the older patients at least to go in for the bigger models. And the younger ones, they are well free to choose. So largely that's the difference between these devices. But some of these problems have been sorted. But looking at what these current devices offer, they are digitally programmable. They've got Bluetooth connectivity. This is a very important thing because with Bluetooth connectivity now, what you can do is you can actually take the control of a very small device and put it into the hand of the patient on a bigger screen. So they can use their smartphone to control the device rather than taking the device out and fidgeting with the small pincers or small needles. So this is a very useful thing. The other thing is obviously that they can stream audio directly from their phone into the hearing aid or from the television into the hearing aids, and that's a big advantage. Another useful thing is rechargeable batteries. We all use them in our devices at home. Our mobile phones have got a rechargeable battery, and why should the hearing aids not have them? Then the newer devices are water, wax, and dust resistant. So these reduce the amount of care you need to take of these devices. Think of it as a washable mobile phone or an IP67 or an IP68 device. It's infinitely convenient to have, and it increases the longevity of the device also. The last two things are contrasting. So there is a group of people who want an invisibility. So a young CEO would not want to use a device that is visible. He does not want anybody to know that he's got a hearing loss. So they look for invisibility in the device. Then there is another group of people who want to use it as a fashion accessory. So they want to flaunt it, not necessarily as a hearing aid, but as a fashion accessory without the others coming to know that it's a hearing aid. So the manufacturers, the companies are very smart and they try to subscribe to both these views and they produce devices that satisfy the needs of both of these groups. So what does the near future have in store? Integrated sensors, connectivity, artificial intelligence, these are all buzzwords that are used, thrown around 2 rupees a kg, but They are not like that. When you talk of hearing aid technology, so some of the important things that AI connectivity and integrated sensors can do is automatic adjustment as per environment. So you go to a stadium and your hearing aid samples the sound in your ambient sound stage, decides what kind of noise filtration is required to that, so that you can hear the score and the person sitting next to you very clearly, but it drowns out the sound of the rest of the auditorium. So with a good device, the hearing aid user may actually be more at ease in the auditorium or in the stadium than a person with normal hearing. And some of these devices can have tinnitus relief programs built into them. They may have sensors that can track your activity. Very important sensors are gyroscopic sensors that can detect falls, so that if a person, an aged person who's living alone, or he's out in the park alone and he falls, the hearing aid is able to send a signal both to his family members and to his healthcare administration that will rush an ambulance to be by his side. So that can be a lifesaver. Then wireless content streaming. As people grow old, they may have weakening of their eyesight, and somebody who's a voracious reader may not be able to read anymore. So audiobooks come to their rescue. They can listen to music. They can obviously listen to their see their favorite programs and listen to the dialogue on television. Geotagging is a very interesting concept. So, for example, you are wearing a device that has got AI and geotagging. The moment you reach home, it knows that you have reached home, and it switches on the various sensors and modes that you need at home. So it will automatically connect you to your TV, to your home phone, to the other devices at home, and you will be able to interact with those devices without actually having to switch the mode on the device. The sixth one is something that I found very interesting. Why I found it very interesting is that these six things that I've listed, they are already part of a commercially available device known as a new here Circa AI, that's being touted as the first, very advanced artificial intelligent hearing aid device. They've already built the mask mode into it. So we've been into the COVID thing for the past 8, 9, 10 months. And already on the market, there is a device that has got a mode that makes it easier for you to listen to what a person who's wearing a mask is saying to you. I mean, I don't think there can be any faster to market product than this. So all of these things are not tomorrow. These are actually available today. That brings me to the final section, the hearables. The ear is the new wrist. Why I say that is that you were using the phone, and a lot of us are using smart watches now, which offload a lot of features of the phone onto the watch. So the next step is going to be that the ear is going to be the new wrist. So the features that you had in your the smartphone features that you had in your watch will now be offloaded to devices that you wear on the ear. So what is a hearable? A hearable is a body-worn computer that you wear in your ear. It's a body-worn computer that you wear in your ear. So what are the things that these hearables will bring? Biometric sensors. So there will be activity tracking. Like I just said, that's already there. Vital signs tracking. So you will have an ECG and a BP and an SpO2 monitor right there built into the hearing aid device or the hearable device. And you don't even need to have a smartwatch on to, count your steps or whether you got enough flows, whether you drank enough water and God knows what. Then fall alerts, very important. Augmented hearing, like the example I shared of the stadium. So these will be able to enhance selectively the kind of sound the listener is interested in. That could be the sound of the neighbors saying something about you after you had an argument with them. I don't know, but it will allow you to pick on faint distant sounds. Another super interesting possibility is translation. And some of these devices are already available for limited languages, though they are not built into the hearing aid devices, but the devices are there that they can provide you real-time speech-to-speech translation of a foreign language. So the photograph some of you would recognize is the iconic robot from Star Wars called R2-D2. And he had this weird language, which was very cute actually, which had whistles and beeps and things like that. And only his companion, the C-3PO, could understand what he was saying. With this kind of a technology, none of us will have a problem listening to what or understanding what R2-D2 wanted to say. Another very interesting way of looking at things is why hearables are important is that we all know that, you've all heard that people say that you are the product. Your attention is the product. Your time is the product. When you use Facebook, WhatsApp, so actually you are the product, and all of these companies are vying for your screen time or screen space. The important differentiator between video and audio is that when you see video, your consumption requires full engagement. I'll simplify that with an example. When you're driving, you cannot watch a movie, right? If you are driving, you can't, or at least you shouldn't watch a movie because you cannot pay attention to the road and to the video at the same time. But when you're listening to music or a podcast, when you're driving, that is not that much of a problem. This is because the consumption through the ears is passive. It does not require the 100% engagement of your senses to, the task at hand. So a lot of these companies are now moving on from the screen to the ears so that they are able to capture that aspect of you as a product also. Enhanced assistance, augmentation of interaction with the environment as the sight begins to fail. So you cannot augment sight as much as you can augment hearing. We all know that. So instead of providing visual cues when the sight is failing, the person might be able to use audio cues. Another very interesting thing is assistant integration. So all of us use either Alexa, Siri, or Bixby, the images of an Echo Dot. I was one of the first users in my family of the Echo Dot when it was introduced, and it used to be a very silly device at that time, and the responses were not very accurate. But those of you who are using these devices would realize that now it's uncanny at times the accuracy with which they mimic the response of a real human being. Of course, the device is dumb. The brain is sitting somewhere else in the computers on the cloud, and because of the good quality internet connectivity and the smart AI and the machine learning, they are able to almost mimic. So you can actually have a conversation with Alexa or Siri right now. Bixby not so much, but Alexa and Siri definitely. So what is the next step? Probably Jarvis. Those of you who have seen Iron Man would recognize that Jarvis is the the big brother of Alexa, Siri, Bixby, and all of them rolled together and raised to the power of 100, things like that. But those things are not science fiction anymore. That brings me to the end of my presentation. I just have a small video. I hope I'm able to play it and you're able to listen to it. It's from a movie that I found very profound. It's called Her. Those of you who have seen it would recognize it. It's a very small 1-minute clip. Dr. Ravi, do I have the time?
Yes, Dr. Vikas, please.
So it's only about a minute. It's only about a minute.
Right.
I hope you're able to hear the audio. The dialogue is interesting.
I even made a new friend. I have a friend. And the absurd thing is she's actually an operating system. Charles left her behind, but she's totally amazing. She's so smart. She doesn't just see things in black or white. Like, she sees this whole gray area, and she's helping me explore it. And we just bonded really quickly. I'm weird. That's weird, right? That I'm bonding with an OS. No, it's okay. It's weird.
Well, I don't think so. Actually, the woman that I've been seeing, Samantha, I didn't tell you, but she's an OS.
You're dating an OS? What is that like?
It's great, actually. Yeah, I mean, I feel really close to her. Like, when I talk to her, I feel like she's with me.
Are you falling in love with her?
Does that make me a freak?
No. I think anybody who falls in love is a freak. It's a crazy thing to do. It's kind of like a form of socially acceptable insanity.
विकास,
यस सर,
भाई हिंदी में ट्रांसलेट करो, हमें नहीं समझ में आया कुछ।
सर आप सर yes sir, I'll sir आपको सब समझ आ गया, but I'll still go through again. So that brings me to the end. I'll just stop my screen share. Sir, so basically what was happening is that without spoiling the entire movie for the people who've not seen it, what happens is that it's from not so distant future when people are using a hearable device to communicate with their life, all the components that make up the life. So, for example, to set a reminder, they would just give a voice command instead of using a calendar on the phone screen and things like that. Something that we are already doing as well. You can tell Siri or Alexa to put in a reminder. So what happens is that this guy goes in for this new software upgrade, and the software upgrade, like I just said a minute ago, the Echo Dot, Alexa or Siri have become so human-like now that sometimes you wonder whether you're actually talking to a device or you're talking to a person on the other side. So something like this happens, and the OS is upgraded, and it is upgraded to the level of intellect and sentience that the person thinks that the relationship with, for example, Alexa becomes changed to as if he's got a girlfriend, So Alexa, he's in a relationship with Alexa, and she emotes and she is participating with him in his life on an emotional level also. So that future is not so distant. If you see, if you talk to your Alexa or Echo, I find it very fascinating, but at the same time, I find it very scary as well. So that's the future in store for us. It's up to us how much we allow it to interfere.
Hello, Dr. Sunil. Dr. Sunil.
Sir, namaskar.
Namaskar. Dr. Sunil, you only reminded me a story of many years back when my kids were very small. And I remember you having told me about my elder daughter's conversation with you on telephone. When you said that, oh यार मैनू ये लग्या कि मैं किधरे गलत तो नहीं किधरे अंग्रेजी नाल तो नहीं फोन मिलाया था. So it is the accent of speaking English, that matters.
Yes, sir. So कैसे हैं आप सर?
I'm recovering but not fully fit. Trying to join you in between.
Yes, sir.
Very good to see you, sir. Dr. Pasi, sir.
Thank you. Thank you, Vikas.
So Dr. Sunil, sir, like I was saying, so I don't know whether to be amused by it. I am definitely amused by it, but I find it very scary also. Also to know that, these devices are listening in on your conversations 24/7. So you are sitting with your wife and she asks you the password of your locker or your bank account and you speak it out. You don't know somebody somewhere is analyzing that data and, they have all of that. So those are scary aspects of technology. But they have always been around, and we need to, be more cautious as to how much we allow these technologies to interfere. Already, what happens is sometimes if you are, and this has happened, and there are case reports of this, that people who had the Echo Dot in their homes, they were conversing about कि इस साल कहाँ घूमने के लिए चलते हैं, अच्छा हांगकांग देख लेते हैं करके, and in a day or so, Amazon starts to send, suggestions of things to do in Hong Kong, or Google starts to send you suggestions of booking tickets on without you ever having searched on the device. So that's how pervasive they are.
No, sometimes it becomes nuisance also.
It is a big nuisance, sir. It is a huge nuisance. It is a huge nuisance. But we have to realize that
lot of issues of privacy are being given up in the quest for technology to find balance.
Yes, sir, we are offering ourselves.
So confused.
These companies.
Thank you, sir, for this informative lecture. Now I would like to invite any comments from the faculty members.
Dr. Deepika, I'll just take a second to thank the organizers, and I would like to say all my seniors, juniors, and colleagues that I'm really again meeting everybody. We used to have nice warm cups of coffee standing outside in MC auditorium, and I'm really missing it. I hope this COVID thing goes away, and next year we are able to sit together and have coffee again.
Yeah, this time we'll have to have virtual coffee.
Incidentally, Dr. Vikas, right now I am in the auditorium. Just the coffee and the food is missing here.
And the company.
Hopefully next year we will have a grand show with everybody physically meeting in the conference. Right.
Absolutely.
Thanks for your excellent talk. I invite Dr. Rajiv.
Thank you so much.
Thank you very much. Thanks.
The next talk is by Dr. Rajiv Kumar on the topic management of carcinoma larynx. Sir is Associate Professor at AIIMS, New Delhi. Sir, please proceed with the lecture.
Hello.
Hello. Yes, sir.
I am audible?
Yes, sir. Yes, sir. We can hear you.
So this.
You can share your screen, sir.
Yeah. Hello, my screen is visible.
No, Dr. Rajiv. Please click the center button, share screen.
So I have done that and I can see my screen. Are you not able to, sir?
No, we are not able to see. In the Zoom app, you have the share screen in the bottom center.
Yes, sir. Yes, sir. I click that one only, sir.
Click again. I think you.
So it's desktop one. We have to click then.
In the. Have you? Are you able to see all of us?
Yes, sir.
So just below in the center, you have a green button, which is the share screen.
Yes, sir.
You click that button.
Yes, sir. I am doing that only. And then it is coming like there are lot of options are coming. Yes. I am sharing that and then opening system preferences. Digital info media is coming. Just give me a minute.
Okay, sure. Meanwhile, is the Dr. Vikas there? Dr. Vikas?
Yes, I'm here, Dr. Ravi.
Hi, actually, hi. I think we were talking about hearing aids, so I thought let's discuss something about hearing aids because Dr. Rajiv is still busy in his presentation. You talked about cross hearing aids. Can you tell something more about cross hearing aids for our delegates?
For the delegates or for the attendees?
For the attendees.
So the one that I talked about, the cross hearing aid that I talked about was basically not by, it was by design, but it was to overcome a shortcoming. The devices, the electronics were so large that they could not be housed into a single side of the spectacle stem. So they had to be divided into two parts, and then so cross basically it refers to routing the signal across the one side of the head to the other side of the head. So if there is, for example, a lot of hearing loss in one of the ears, and on that side you are not able to hear, so the sound signals from that side can also be picked and presented to the other side. So there is a semblance of binaurality in the appreciation of the sound. So one side of the sound stage does not become dead, and the patient is able to appreciate. Of course, it is not the same as listening to. Not the same as listening from both the ears in a normal person or even in a person with a lesser hearing loss, but some hearing preserved in both the ears. But it is better than only hearing one side of the sound stage.
Right.
What used to be done earlier was that people used to pay a lot of attention to just the visual stage in the environment. But with the advent of the devices and with the better understanding, and also probably because the problems of the eye were sorted out to a large level by these, surgical procedures and good quality spectacles and progressive lenses, people started to focus, and the amount of information that you lose from the sound stage if you don't get a 360-degree perception of the sound, that's a big detriment, and it's a safety risk also. For example, if you're not able to hear from one side at all and you're crossing the road and there is a car that's coming from that side, a person who's able to hear, it's a matter of routine. He does not even realize what he has. It's only when you lose these things that you realize how much of a problem they are. So it's a device to kind of address that issue.
Thanks for explaining. Thank you very much, Dr. Vikas.
Most welcome.
We have Dr. Saurav Varshney with us. Sir, are you there?
Yes, Ravi, I am there very much with you.
Sir.
Welcome, sir. Dr. Saurav has recently joined as director of AIMS Devgarh. Welcome, sir.
Oh, my pleasure. My pleasure. Thank you.
So we are just waiting for Dr. Rajiv's presentation.
Yeah.
Meanwhile, sir, you can also comment if you have some comments to make about the hearing aids, the previous lecture by Dr. Vikas.
Yeah. That was a wonderful presentation by Dr. Vikas. Ravi, you were mentioning about cross hearing aid.
Yes, sir.
So cross hearing aid, I think it's a very, very important that one topic which we always discuss, and I've been wondering that we are able to help people who have bilateral hearing loss. So we can very easily prescribe bilateral hearing aids, but there is a condition which we are never addressing in our clinical practice, is the unilateral sensory hearing loss. So we have good number of cases, and we had done two big surveys at our previous institute, and we found that about 8% of the cases they have unilateral sensory hearing loss, which is beyond moderate category. So I think when we talk about prescription of hearing aid, still we are not clear how to help this category of patients. So I'd like to have Dr. Vikas, if you are there, what is your view on this? That if you have a patient with a unilateral sensory hearing loss, which is more than moderate, so how you are going to help this patient as a prescription of hearing aid?
Sir, I absolutely agree with you that these are cases who have been much neglected, and sir, there are two aspects to my mind. What my limited experience is that we are not aware that these are the patients who need help in the first place, so we do not offer them help. So that needs to change, and that has to come from our side. There is no problem. There is no doubt about that. So the ENT surgeon has to understand that you don't leave a person who's got slightly reduced vision in one eye without a correction in that eye. So why should the ear suffer like that? But that is something that we need to talk to our residents about, and they should be aware. But the second part that I find difficult is that unlike the eye, the patient is not very convinced.
Correct.
Also with the narrative of doctors wanting to prescribe aids even when they are not needed, we cannot deny that that kind of a narrative is also circulating. I find it many times a little difficult to tell the that you do need a hearing aid on the other side to augment the hearing, and just because one ear is functioning normally or one ear is rehabilitated adequately does not mean. Sir, another example is cases who have got a who've got a different hearing loss. So one ear would have a slightly lesser hearing loss than the other, but to the patient's mind, he is able to hear very well from that ear. The other ear he doesn't pay attention to. So they do not get convinced to get
Because I'll just share with you that we are getting many
it's very,
cases
very important.
now.
We should not neglect it.
We are getting many cases
Hello,
now,
sir.
which are I think Dr. Rajiv is back, and his slides are seen. I'll just conclude in one minute that
Yes,
we are getting a lot of cases where the people are coming with this, that they are in a gathering, who are in executive positions, attending meetings and all, they are not able to hear the conversation properly in the meeting. So they are category which are willing to take hearing aid these days. So my point is that we have to look into this category with a unilateral sensory hearing loss consideration also. I think back to Ravi. Ravi, I am just muting myself.
Right, sir.
Because
Thanks a
Dr.
lot, sir.
Rajiv is back.
Thanks a lot for your comments, sir. I think we can go ahead with Dr. Rajiv's presentation. Dr.
So my
Rajiv,
screen is visible, sir?
Yes, your screen is visible and we can see it in full screen.
Thank you, sir.
Thank you so much, sir. Good afternoon, everyone. I will be talking regarding the management of carcinoma larynx. And as Dr. Ravi have requested, this is for post-graduation. So I am just giving an overview how to go forward, because these cases are given as a short cases. So I will give how to generally go. Hello. So the management depends upon the stage of the tumor. So for all the patients who presenting with the laryngeal pathology, first we need to stage the tumor after we have done the biopsy, and the staging will be done by basically the clinical examination, the radiology, and the subsite. The subsite is important because in larynx, both supraglottis, glottis, and subglottis, the laryngeal management will be little different.
Management depends upon the stage of the tumor. So for all.
Hello, sir.
Yes,
Dr.
Ravi,
Ravi?
we can
Sir,
hear.
I am audible, sir.
Yes, you are audible. Very
Okay.
much audible.
So the management also depend upon the patient factors, the surgeon factor, and the resources which are available in the hospital. So the first, I would like to talk about the clinical presentation. So most of the patient present with these common features like hoarseness, which will be usually progressive and persistent. Then there can be odynophagia, that is painful swallowing if the disease is in supraglottis and extending to piriform fossa sinus. Patient can have concomitant dysphagia if it is again spilling on to piriform fossa. Breathing difficulty due to bulky growth or because of the cord palsy. Patient can present with stridor in sometimes in emergency, and sometimes they have neck node at presentation also. So there are variable presentation to the patient with carcinoma larynx. So like as told you, the voice quality give us a clue. If there is a early hoarseness, then it is more in favor of glottic carcinoma. But if there is a muffled hot potato voice like quality, then the lesion might be located in supraglottic area. The stridor, which is sometime we have seen patient presenting late in the disease and can present directly in the emergency room, have respiratory distress, are suggestive of advanced glottic carcinoma compromising the airway, transglottic disease with subglottic extension, or very bulky supraglottic lesions which are occluding basically the airway rather than there is any cord impairment, or that lead to a narrow chink because of the bulky growth, and these patients have airway compromise. So for to make a diagnosis, apart from the clinical history and addiction history, we have to examine the all ENT subsites, but the importance are the neck examination, in which we will look for the presence of nodes, and then we have to look for the laryngeal expansion and laryngeal crepitus. So laryngeal expansion give us a clue that is a locally advanced disease, and absence of laryngeal crepitus give us a clue that the disease is going beyond the larynx and it is in the post-cricoid area, and that's why we are not able to hear the crepitus. So this is known as Boca's sign. In the laryngeal examination, in the OPD basis, we can have so many armamentarium these days, but basically we start with indirect laryngoscopy. We can use 90-degree laryngoscopy if there is some issues with the patients like increased gag reflex. We can spray it properly and do fiber optic laryngoscopy also. In some centers where stroboscopy is available and there is an early glottic lesion, we can do strobe to look for the mucosal wave pattern. Narrowband imaging is a optical imaging system which is currently being used in many centers worldwide, and it gives us a clue for very early subtle lesions which might not be visible on white light scopy, and there is a full classification about the lesions which I will be just giving you in little detail. And the last and the final gold standard is direct laryngoscopy, which we do to assess the lesion and the extent, as well as taking the biopsy for histological diagnosis. So this is a very small video of fiber optic with laryngoscopy, and I will just run through the area which is I am interested, is this one, where we do the narrowband imaging, and instead of white light we have filters of blue and green light, and we can see this vasculature pattern in the submucosal area, which give us a clue regarding the any early changes of the malignancy like dysplasia or very subtle changes which give pointers to the site of biopsy basically. So NBI is basically an optical imaging modality, and it uses optical interference of blue and green light. And these two peaks, the wavelength peaks, correspond to the peak absorption of hemoglobin, and thus enhances and better contrasts the mucosal microvasculature and give us the area of interest to target for biopsy or to see the extent. This is one of the classification which is given by Nee et al. And
Echo,
there is echo going on. So, hello.
Doctor, you have your phone also along with your laptop. So switch off your phone audio.
All right.
Maybe because of that it is having echo.
Hello.
Yes.
So this knee classification is basically given for the seeing the microvascular pattern, and mostly if it is type 5A, B, and C, it is more in favor of malignancy. Type 1, 2, 3, and 4 are mostly benign. Type 4 is little in the suspicious zone where you have to think that it can be a early subtle changes, which is in favoring of malignancy. So this is for exam going postgraduates. If somebody asks the narrowband imaging, then you need to know the basics of this narrowband imaging and this classification, which help you quantify that this lesion belong to which class, and how much this patient is prone for having more sensitivity for the malignant lesion. Then when we do laryngeal examination, we look for the airway impairment, whether the glottic chink is adequate or not, the type of growth, exophytic or endophytic, whether it is a superficial spreading lesion or a deep invasive lesion spreading to paraglottic or lateral pharyngeal wall, what all mucosal structures are involved, and if there is cord immobility, then what is the cause of that immobility, and how much is the extension outside the endolarynx spilling over to piriform or posterior pharyngeal wall or going to postcricoid area. So all these examination need to be taken into account while assessing the patient. Direct laryngoscopy is basically done to confirm the histological diagnosis, though these days, because of the COVID situation, we have done this with the help of fiber optic laryngoscopy also, and many centers are doing it before also. But biopsy through direct laryngoscopy also give us advantage of thorough visual examination, palpation for the submucosal extent, and we simultaneously check for the adequacy of exposure if we are planning for any transoral resection, either with laser or robotics. We look for the passive mobility test of the arytenoid, if the arytenoid is fixed or not, and we can also look for the disease into the ventricle and the paraglottic space extension. So that's the direct laryngoscopy we need to do. The important point here is if there is a plan for any transoral laser or robotic resection, especially laser in glottic lesions, then if exposure is not good during the biopsy, then that case might not be very much suitable for later on for excision of the lesion. So once we have done the clinical examination in the OPD setting, and we have to advise the radiology if we want to see the third dimension of the tumor, and we have this option of contrast enhanced CT scan, MR, and PET CT. The first line of investigation is mostly contrast enhanced CT scan, which is very much easily available, rapidly done, and give us a very good detail, anatomical detail of the extent of the tumor and surrounding areas. So we have to look for the resident, we have to look for the presence of neck nodes for the staging, because we, apart from T, we require N staging also, erosion of cartilages like thyroid, cricoid, invasion of the preepiglottic and paraglottic spaces, and submucosal extension beyond the larynx. The limitations are in terms of superficial mucosal lesions and large exophytic lesion where the point of attachment is sometimes not very much clear. So that's why these things can be sorted out on direct laryngoscopy also. So few slides where we are showing the extent of the like area epiglottic fold tumor. We have to see that the tumor is going into the paraglottic space, and the left paraglottic space is free from the tumor. There is a large lymph node at level 2. Bilateral true vocal cords are getting involved, and the tumor is crossing through the thyroid cartilage into the strap muscles, and vessels are free, no encasement. So this is a serial sectioning from top to bottom. We have to look for each and every structure. The tumor is going into the subglottis and extending into the subglottic region, hugging the cricoid cartilage. Then we have to look for the thyroid invasion. Thyroid is normal or not, tracheostomy done at which level. And if there is a complete obstruction, that's why the tracheostomy was done, and patient might have presented with airway compromise. So all these findings need to be seen on scan. So this will help us in determining the extent of the lesion, as well as we help to see the T stage and the N stage on scan. Now, between CT and MRI, CT is cheap, readily available in most of the centers and preferred for ossified cartilage where we can see. But in case of MR, it is more sensitive for very early lesions like anterior commissure, or just where we are little doubtful whether the tumor is still T1 or it's crossing the anterior commissure and becoming T4. On pre-epiglottic space and paraglottic space, where we can planning for any limited surgery in terms of laser resection, we need to see the exact extent into that area. We need to have MR. But MR is not preferred because the motion artifact might be there because patient is continuously swallowing and this is a long 45-minute scan time. So preferred is still CT in most of the cases. But in doubtful cases, we can order MR. For metastatic workup, normally for stage 3 and stage 4, we routinely do non-contrast CT chest for look for subpleural metastasis or metastasis which can be easily missed on chest X-ray. So stage 3, stage 4, we upfront go for NCCT chest. For stage 1 and stage 2, it is not required to routinely do NCCT chest. And we can do with, because stage 1, stage 2 have very low incidence of metastatic occult lymph node metastasis even in larynx. So for distant metastasis, we hold on to NCCT chest. Management depend upon the staging, and staging, we all know that we have this staging system devised by AJCC staging system. And so for early glottic lesions, like who's limited to one vocal cord or with one vocal cord going to anterior commissure or involving both true vocal cord with mobility, we have so many treatment options available like transoral laser surgery, radical radiotherapy, or open partial laryngectomy. But the aim is to cure, to preserve the larynx, high voice quality, and minimum morbidity. So we have to discuss these things with the patient, the treatment option with the patient, and we have to see his other needs in terms of voice, in terms of his occupation, and in terms of resources, what we have in the R setting, and then we advise the best treatment option for the patient. The concept is the single modality. It should not be like we did transoral laser surgery, the margin or multiple margins are close or positive, and then we say, okay, now you go for another surgery or we go for radical radiotherapy. The aim is to have a single modality and complete cure. Patient counseling is must in this concept area. So this staging classification system is well known and widely used worldwide, so that we all have a similar results and it is easy to compare the results. It is given by European Laryngological Society classification from type 1 to type 6. For resident, they must know this classification because sometime in exam it must be asked by the examiner that which type of cordectomy you are going to do and why. CO2 laser is the most commonly used laser in the setting because of low incidence of bleeding and very rarely few cases reported worldwide of airway fire. Otherwise, it is very safe. Laryngoscope, what we use should be matte finished to limit the reflection from the laser. And mid-caudal lesions with normal column mobility are the best lesion which give us a good success rate in terms. These are certain contraindication like trismus, tilt, transverse mandibular diameter. All these T's need to be ruled out before we take a patient for transoral laser surgery. Transoral laser surgery, we have to look for patient factors, tumor factors, and surgeon factors. And the best case scenario should fit for the this modality of the treatment. If there is some issues with the size like anterior commissure, location like anterior commissure, or it's a bulky tumor which we are not able to excise properly, then we can opt for another modality. This editorial by Mendel Hall et al. Says that the voice quality between the two modalities are comparable, but the locoregional control is also similar with both modalities. But laryngeal preservation rate is higher with transoral laser surgery as an initial modality of treatment. So if somebody asks you that out of radical radiotherapy or transoral laser surgery for T1 glottic lesion, what will be your initial preference? Then apart from patient choice, you should talk about that the laser has a better advantage in terms of laryngeal preservation rate. For T2 glottic lesions, there is a systematic review which says that both the modalities, the transoral laser surgery and radical radiotherapy, has comparable local control rates. So T2 is the area which is little still dicey, and some prefer radical radiotherapy and other centers prefer laser surgery. So it depends upon the expertise center to center where they want to go ahead with T2 lesions. So for contemporary surgical management of early glottic cancers, there is no prophylactic neck dissection because of the low incidence of occult lymph node metastasis. The local control rates are lower for T1 lesions with tumor infiltrating the anterior commissure, and for T2 lesion with decreased vocal fold motion, whether either we treat it with translaser microsurgery or open partial laryngectomy. And thyroid cartilage division is rare, and the T2 tumor with decreased cord mobility have a high risk for occult cartilage invasion. So we need to look case by case, and with appropriate staging system, we should opt for either radical radiotherapy or transoral laser surgery for these lesions. Now, glottic lesions are very different from supraglottic lesions because they have high incidence of occult lymph node metastasis up to the tune of 40 to 50%. The options for early means T1, T2 is transoral laser microsurgery, TORS, TAUS, open partial laryngectomy, or radical radiotherapy. So again, from case to case basis, we have to see which case fits into best treatment option apart from patient choice. And this one meta-analysis which compares the primary surgery with primary radiotherapy concludes that early stage supraglottic squamous cell carcinoma shows that the primary surgery may result in decreased disease specific and overall mortality compared to primary radiotherapy. So that is the important point taken from this meta-analysis, that the primary surgery may result in decreased disease specific and overall mortality. But still, with center to center and with the experience, some people prefer for laser surgery in early stage supraglottic carcinoma with bilateral neck dissection in the same setting. Now, the gold standard for laryngeal management is total laryngectomy for locally advanced disease like advanced T4A locally recurrent disease and after failure of radiation therapy. But the problem with the total laryngectomy is that there is this loss of communication, airway closure, nasal airflow issues, swallowing, and psychological issues. So that's why in the early lesions and in the locally advanced disease like T3, we should try to have something which is less than total laryngectomy so that we can avoid all these factors to the patient like communication and all things. So in this class, there is another treatment option available is open partial laryngectomy, where the expertise of laser or laser as a resource is not available, and patient does not want to go radical radiotherapy, or the disease is little advanced, patient is not fit for concurrent chemoradiation, and open partial laryngectomy is another option. And the principle is that the survival from the index cancer is compromised if a local failure result after radiation therapy or surgery to the supraglottis and glottis. Medical and surgical organ preservation modalities alter the topography of the larynx and make definitive evaluation of recurrent cancer difficult. Used only when resection of the tumor can be accomplished comfortably with local control rates that approximate those of total laryngectomy. So we have to use these things only when we are able to achieve a good local control rate, then we should go for this organ preservation modality. And before that, we have to do a complete 3D assessment of the extent of the tumor. We need a good imaging and preoperative assessment under GA also. So goals are microscopically negative margins while preserving the functional integrity of the larynx. So that is the goal for open partial laryngectomy. So between open partial laryngectomy and transoral laser surgery, the transoral laser surgery has an upper hand but only in cases where we cannot do is poor transoral access, or there is laryngeal cartilage extension, or there is lack of technology, then we can opt for open partial laryngectomy in modern day indications. These are few vertical partial laryngectomy like frontal, frontolateral, 3/4. So European Society has given another classification for open partial laryngectomy, which is supraglottic, supracricoid, and supratracheal laryngectomy. I will not go into detail, but if you read this paper, then there is subsets also, and Europe is very fond of doing this open partial laryngectomy rather than doing total laryngectomy for these patients, and especially for salvage cases also. So for postgraduates, if they want to go through this, then they simply have to read this paper of European Laryngologist Society for open partial laryngectomies, and the staging system is given there, and they should have some idea basically regarding this staging system. Now for stage 3 carcinomas, the current preference is functional larynx. If there is no tracheostomy, functional larynx, and no aspiration, is concurrent chemoradiation. If the patient is already tracheostomized and there is a lot of preoperative assessment, there is a lot of aspiration, then surgery followed by adjuvant radiotherapy is the preferred modality. And what kind of surgery we need to do? We need to see the extent of disease. Either it can be total laryngectomy or near total laryngectomy or some open partial laryngectomy. All depend upon the extent of the disease. Last but not the least, for locally advanced disease, which is through and through cartilage erosion, thyroid cartilage erosion, extralaryngeal spread, we are not left with any other option but the total laryngectomy, which is gold standard. There is one video which is available with our department's AIMS head neck surgery YouTube channel, where residents can go and see the steps of this video. I am not going to show it here because it will take 5 to 7 minutes extra. So this is there. Then we have to look for the rehabilitation of these patients after total laryngectomy, and the 3 option is esophageal speech, tracheoesophageal prosthesis, and electrolarynx. Currently, the gold standard is tracheoesophageal prosthesis, which gives a very nice, comprehensible voice. And the only problem is the Provox is costly, is costing more than 30 to 35,000, and the Indian made prostheses like Siddham and others are costing less than 1,000, but because of their recurrent candida infection in this setting, we have to change it repeatedly between 3 to 6 months. But if the patient cannot afford that, this locally available Indian made prosthesis is very good way of rehabilitating these patients. And they this is a video which shows that the patient has a good voice.
कहाँ से आए हैं? अच्छा, 1 से 10 तक बोलिए, बोलते रहिए. 1 2 3 4 5 6 7 8 9 10. आगे बोलिए, जितना बोल सकते हैं. 1 2 3 4 5 6 7 8 9 10 11 12 13 14 15 16 17 18 19 20. नाम क्या है आपका? 2 3 4 5 6 7 8 9 10.
So these Indian made prostheses are doing very good in terms of voice rehabilitation, and patients are satisfied. And most of our patients cannot afford Provox because 35,000, and sometimes they might also fail within 6 months to 1 year, although some say they work more than 1 year in some cases. But this easily available and cheap option is a good way of rehabilitating these patients. So this is very brief overview for management of carcinoma larynx. I have not gone into details, but if there are any question, I would happy to take them.
Thank you, sir, for this comprehensive session. I'm sure that all the delegates, all the residents must have benefited from your lecture. I would like to invite any comments from the faculty members.
May I ask a question?
Yes.
Ravi?
Yes, sir, please.
Okay. First of all, Dr. Rajiv, excellent presentation, bringing it into such a compact form, such a big topic, and
Thank you, sir.
very
Really
informative.
big topic for me.
Yeah, it's a vast topic for discussion, but you have very nicely comprehended. My one question that in the context of recent advances, that is there do you have come across any study which is comparing transoral laryngeal surgery with transoral robotic surgery for supraglottic regarding the outcome prognosis? Because
Regarding the
yes, I'm talking about this transoral robotic surgery,
yes,
robotics.
yes, sir.
So, is there any comparative study in literature present you have come across comparing transoral laryngeal surgery and transoral robotic surgery for laryngeal carcinoma? And is the robotic proved to be better that way?
Sir, frankly speaking, I have not read any head-to-head study which compares TORS with TOLM. But I have read about the studies which only robotics is done, and they have shown good results in supraglottic carcinoma. But head-to-head, sir, I am not aware if there is some.
Because if I'm right, there was a publication about 3 months back,
Okay,
which said that if you compare, it was not comparison between laryngeal and robotic, but that was a comparison between robotic and radiotherapy.
Okay, sir.
And it said that if you compare both these, then robotic has better precision and better prognostic future as compared to simply going for radiotherapy that way. So
But
I
sir,
just
the meta-analysis which I showed you,
yeah.
the for supraglottic early supraglottic lesion, the radiotherapist they argue that by a single modality we are taking care of both nodes and primary. But if do surgery and we do nodal dissection, which is level 2, 3, 4, or some people only do 2, 3 for supraglottic, if the nodes are positive, then it upstages the tumor, and then we have to give radical radiotherapy as the adjuvant therapy. So they argue that in spite of going for two treatment, like first surgery, then radiotherapy, the single modality can be taken care in stage 1, stage 2.
Correct.
So that is their argument.
Yeah. Just for the interest of the, because I think the residents are also attending it. So question may be asked to them about the robotic surgery, because many centers are into robotic supraglottic laryngeal surgery. Thank you, Rajiv. Thank you very much.
Just to mention that we had a session on transoral robotic surgery as well as transoral ultrasonic surgery, TAUS and TOR, yesterday by Dr. Alok.
Yes.
So, I think it was covered nicely by Dr. Alok yesterday, and he did show some comparison of TAUS with TORS. And the only, what I could gather is that in TAUS the equipment is very much less expensive as compared to the TORS, and you can do whatever things you can do with TORS, you can do also with the TAUS. The advantage of TAUS is that you have a better bleeding control because you are using a radio frequency energy to control to cut as well as control the bleeding.
So this TAUS can seal up to 7 mm of lingual arteries.
Yes. So that the bleeding control is better than the robotic TORS.
Yes.
That is what Dr. Alok Thakkar had yesterday.
Yes. So we have both the equipments like TORS and TAUS, and sir found that this TAUS is very good for day-to-day use because robotic is shared by most of the departments.
Right.
But TAUS is with our department only, so we can routinely using it.
So it is more economical and more handy.
Yes,
as compared to TAUS.
Ravi, all said, TAUS is definitely better because of the less requirement of say economically. Also, it is viable in country like India, but only the limitation with TAUS is the space which we have to operate on, which is definitely a better advantage with robotic. Because I've not done TAUS, but yes, I have done robotic cases. So in my personal opinion, definitely, except for the economy and the accessibility, availability, because very few centers can have robotic. I agree with you, but space advantages with robotic as compared to dexterity and space is definitely an advantage with robotic compared to TAUS. But in country like India, Taos has a better scope and option. I agree.
Right. Thank you, sir. I think we are extending our time into the case discussion, so we'll stop here. And I really thank Dr. Rajiv for his excellent talk and comprehensively presenting such a large topic in a short time.
Thank you, sir.
Thank you, Dr. Rajiv. We'll straight away go to the next case discussion, and I invite Dr. Deepika to introduce the panelist.
We welcome you all to the last session of today's evening. Next is a case discussion which is being presented by Dr. Vishnu, third year postgraduate resident, and Dr. Sanjay, second year postgraduate resident. To moderate this session, we welcome our expert faculties, Dr. Anup Raj, Professor and Head, Sharda Institute of Medical Sciences, Greater Noida, Dr. Saurav Varshane, Director, AIMS, Deoghar, Dr. Ishwar Singh, Director Professor, Department of ENT, Maulana Azad Medical College, New Delhi, Dr. Ravi Roy, Professor and Head, RNR Hospital, New Delhi, and Dr. Manish Gupta, Professor and Head, Maharishi Markandeshwar Institute of Medical Sciences and Research, Ambala. We welcome you all, sir.
Dr. Deepika, Dr. Ishwar Singh is also one of the panelists.
Introduced. Yes, sir, I have introduced. Sir.
Hello. And I welcome Dr. Anup Raj, sir. Good evening, sir.
Good evening, good evening.
Yes, sir. Good evening.
Good evening, Saurabh. Good evening, Ishwar. Good evening. Saurabh, good evening.
Sir, very good evening, sir. Nice to see and hear you, sir.
Same to I.
Sir.
Yeah.
Can they start?
अब कर लो. मैं म्यूट कर रहा हूँ अपने को. जब आप बोल रहे थे ना तो भाई बोल रहा था. हो रहा था.
Sir, can they start the presentation?
Yeah, go ahead.
Please.
Over to Dr. Vishnu and Dr. Sanjay. Please start your presentation.
Good evening, all the respected seniors. The case presentation for today, my topic is nose and penis. So, a 60-year-old male presented to our OPD, a manual laborer by occupation and a resident of Faridabad. The patient presented to us with presenting complaints of right-sided nasal obstruction since past 3 months and right-sided cheek swelling for past 2 months. The patient developed right-sided. The patient was apparently well 3 months back when he developed right-sided nasal obstruction, which was present since 3 months. It was insidious in onset and gradually progressive. There was no aggravating or relieving factors. There was no history of excessive sneezing or lacrimation. There is history of occasional fullness of ear on right side, and there was history of scanty, foul-smelling blood-stained discharge, which was about and it was about 5 to 6 episodes per month, and it used to stop spontaneously. There was no history of nasal twang, no history of decreased sense of smell, no history of mouth breathing, no history of snoring, no history of post-nasal drip, and no history of headache. The patient also had right-sided cheek swelling for the past 2 months, which was insidious in onset. It was gradually progressive. There was no history of any discharge from this swelling, no history of any pain or fever, no history of any colicky pain over the right side of the face or increase in size of the swelling on taking meals, no history of any aggravating or relieving factor for this swelling, no history of reduced mouth opening, no history of loss of any sensations over cheek, and no history of trauma or discharge from the swelling. Also, there was no history of any oral fullness, no history of decreased hearing, no history of decreased vision or double vision, no history of facial heaviness or facial pain, no history of shortness of breath or seizures, no history of focal neurological deficits, no history of weight loss, no history of loss of appetite or any neck swelling. The patient did not have any comorbidities. Specifically, there was no history of type 2 diabetes, tuberculosis, hypertension, epilepsy, jaundice or asthma. There was no history of previous surgery or blood transfusion or any drug allergy. Also, the patient had normal bowel and bladder habits. Patient had normal sleep pattern, and the patient is a textile worker industry for past 30 years, and there is history of tobacco chewing for past 35 years, and there is no history of smoking or alcohol intake. There is no history of similar chronic illness in the family. The patient belongs to upper middle socioeconomic strata according to the modified Kupru-Swamy scale.
So hold on. You said patient is a textile worker.
Yes, sir.
What are the other professions which may lead to the nasal problem?
Sir, there are certain professions that lead to certain malignancies of the sinonasal tract. For example, sir, hardwood worker and softwood workers, they are exposed. They are more predisposed to develop carcinoma of the paranasal sinuses. And sir, patients engaged in shoe industries, leather industries, and sir, exposure to hydrocarbons, aromatic hydrocarbons, sir, they are all
Asbestos.
Asbestos exposure, sir. Nickel, chromium exposure, sir. And sir, specifically, sir, sir, there is a mahogany, African mahogany type of wood, which is which is the most dangerous type of hardwood and leads to carcinoma of the paranasal sinuses. And Ubuntu
so
tribe
textile is
there,
also held responsible. It is part of it.
Sir.
So textile is
textile industry, sir.
Okay, Sanjay, what are the differentials you have in mind with unilateral nasal obstruction patient?
Sir, for a patient of an elderly male of this age, sir, having these unilateral nasal obstructions, sir, it could be, we could keep sinonasal malignancies. Then, sir, inverted papillomas could be there. And, sir, any...
Sanjay, I would like to interrupt here that why you want to say straight away malignancy, and on the other hand, you are saying inverted papilloma. So is inverted
why not sinusitis?
Sir, as such, the patient does not have typical complaints of sinusitis, sir. The patient is having the
nasal obstruction
patient,
is there. Nasal polyp can be there.
Yes, sir, nasal polyposis.
Nasal polyp can be there. He has a dust. He works in an industry, dusty, or there is more of fibers.
You have not considered any kind of DD. You are straight away, just by examining, you are telling a patient is having a malignancy.
So you are already fixed, presumed.
Preoccupied mind.
So sinonasal polyposis.
So
all
go
those
back to your examination history slides.
Sir?
What basic, sir, can I speak? What I basically want to say is, in your presentation of the complaint, what are the favorable points that shows towards a neoplasm, whether it be benign or malignant? Can you summarize those points to
Sir,
press upon your idea?
Yes, sir. So first of all, the patient is an elderly male.
History slide on this thing. Display the history slide.
Again, go to history.
Come back.
So the patient is an elderly male, sir, and the patient is a worker of in the textile industry for about 30 years. Also, sir, the patient is a tobacco chewer since past 30 years. And so now the patient is presenting with a right-sided nasal obstruction, which is there since 3 months now. And then accompanied with it, the patient also had a cheek swelling, sir. So, and the patient does not have any allergic symptoms, sir. So,
I'd like to mention one thing, Sanjay. What you should be starting with is straight away the acute duration of presentation. That is the first point in favor. If you see your history, it's only 3 months nasal obstruction, 2 months cheek swelling, and patient is having nasal bleed, patient age, and then the exposure, that is the industrial exposure.
Yes.
So these are straight away point you would mention that first the acute nature of the history indicates that we are dealing with something which is serious. Okay.
Yes.
So your what I think we want you to elicit very clearly is that what are the points in favor? It's the acute duration of the symptomatology. That is the first thing to indicate. Okay, because sinusitis, nasal polyp, inverted papilloma, or rhinosporitis, and all that does not have such acute history like that. Okay, so that is what I think the experts wanted you to understand. Okay, go ahead, please.
Then, sir, coming over to examination, sir, Dr. Vishnu, sir, will take over.
General, going to general examination. The patient is conscious oriented. General condition is fair. The patient is afebrile, no pallor, icterus, cyanosis, clubbing, lymphadenopathy or edema. Pulse rate is 74 per minute, regular, normal volume and character. BP 124 by H2 in the right upper arm in sitting position. Respiratory rate 12 per minute, regular, thoracoabdominal. Local examination.
Just one question, because we are, I think the purpose of this exercise is to make the resident understand where they can go wrong in their final exam. So how did you observe the respiratory rate of the patient?
Sir, while counting the pulse rate, we'll be observing the.
No, I'm asking the respiratory rate.
Simultaneously, we'll be.
So the patient was in sitting posture or lying posture when you were observing the respiratory rate?
In the lying position.
So you were examining the patient on a couch, or you were examining the patient on the patient's stool?
On a couch.
So do you normally examine an ENT patient on a couch?
In sitting position.
So see, in exam when you are writing, the purpose of this, what Dr. Ravi told me, is to just bring to your notice where you have to be very emphatical and clear. Okay, then you have to mention that patient was observed in a lying posture, the respiratory rate, thoracoabdominal movement, respiratory was this. So you have to make the word there. Okay?
Or he should mention that I have examined the general exam. Hello, you should mention the general examination was done under in the lying position.
Yes. So
because general examination all has to be done in the lying position.
Okay. Go ahead.
Local examination. The face is swelling on inspection. Size 4 into 3 centimeter was present for the right side of cheek, which extends superiorly till the lower eyelid, inferiorly till 1 finger breadth above the angle of mouth, medially till the nasomaxillary groove, and laterally reaching till the zygoma.
How will you ascertain the size of the swelling?
Because the margins are quite diffuse. They are not well demarcated margins. Go back to this photo.
Picture. How can you confirm the size of the swelling?
So margins are diffuse.
Sir, on palpation, we will be confirming the size.
Hold on. The margins are diffuse, so you say the swelling is extending from this side to this side, rather than saying 4 centimeter, 3 centimeter. So it is extending to the margin of the orbit, to the L of the nose, lower down to the angle of the mouth, and the other side is where posteriorly it is going towards the outer canthus is not visible.
And I agree, because you are saying that till nasomaxillary groove, it will be better that nasomaxillary groove is obliterated, because you are not able to appreciate that. So say that it is not appreciable.
I can see the groove.
Okay.
If you observe, you see the groove is there.
हाँ sir, है.
A groove है.
I think you should first mention about the inspection findings, then move on to the palpation.
दास में जो point दे रखे हैं.
Palpation is always for confirmation of your observations.
Definitely.
Always.
Go ahead.
The overlying skin was erythematous, no pus point or scar or sinuses or fistula were seen. And on the
this is finding of a palpation or inspection?
Sorry, inspection.
Achha.
Moving to palpation.
अरे कई पॉइंट होते हैं यार उसमें इंस्पेक्शन में भी.
अभी बता रहा है इंस्पेक्शन, फिर से चले जा वापस भैया. Inspection complete to कर.
The overlying skin was erythematous. No dilated veins or scars or sinuses or fistula were seen. No pulsations, visual pulsations were seen.
Which pathology may cause a sinus over this area?
If there is any abscess, then it can cause discharging sinus over the area. Tuberculosis of the zygomatic bone can also cause discharging sinus.
And fistula?
Tony, what is a fistula?
Fistula is an epithelial line tract connecting two surfaces.
So your esophagus is connecting the hypopharynx to the stomach. So it is a fistula?
Sir, abnormal, sir.
So go ahead with the causes of fistula, sir. Ask you.
From which cavity the fistula may arise over this region?
So from the maxillary sinus.
Okay. So it will be enterocutaneous fistula.
Yes,
okay, proceed.
On palpation, the local temperature was not raised. The swelling was non-tender. The inspectory findings were confirmed. Margins were not well defined. The swelling was hard in consistency. It was not mobile. Surface was smooth. The overlying skin was pinchable. The swelling was not compressible also. External nasal examination.
Go back.
When you are palpating, which margin you are interested? Margin is not well defined.
Ill-defined margins are characteristic of malignancy.
Did you palpate the upper margin, and what was the if it is blunt or if it is sharp, what is the inference?
Sharp margins are characteristic of any bony swellings. If it arises from any soft tissue, then it can be blunt.
So in one case, the upper margin, that
just
is
sensation.
orbital margin, is well defined. In other, it is diffuse. What do you mean by that?
Diffuse margins are characteristic of any malignant swellings. So benign bony swellings can also cause sharp margins.
Can you tell some condition in which you will have a well-defined margin over cheek swelling? Tell me any pathology you can think about where you will have a well-defined margins on the cheek swelling.
Sir, if any sebaceous cyst arising on the
Cyst can have it. Okay, good. Go ahead.
If your patient is slightly younger age, say 20 or around 20 years, then younger patient, because this patient is elder.
Sir, if it's adolescent male, then we can suspect juvenile nasopharyngeal angiofibroma.
Here in the cheek, I say the X-ray finding are ground glass.
Fibrous lesion straight away.
Fibrous dysplasia can occur. Fibrous dysplasia can occur.
See, any benign fibrous lesion appearing in that area can give you well-defined margins. Inflammatory swellings will not give you well-defined margin. Malignancy will not give you a well-defined margin. Okay, so this is how you can differentiate, because if you say that you are not having a well-defined margin, that is going in line with your provisional diagnosis, what you mentioned in the history, and it can be a neoplasm. Okay, so go ahead.
External nasal examination. The dorsum was midline. Osteochondrial was increased.
Just a minute, Sanjay. One more thing to add. You have not spoken about the sensation over the mid-facial region. That is also important.
Why?
Sir, I
Why
mentioned,
it is
sir,
important? Tell.
sir,
Dr.
the infraorbital nerve is there, sir. So if any malignancy is expanding, it can involve the nerve and there will be cheek paresthesia, sir.
Okay. Any condition specific which can have cheek paresthesia as a presenting symptom? Any pathology?
Sir, in adenoid cystic carcinoma.
Yes, sir.
Correct.
Bilateral ala, columella, vestibule, no abnormality detected.
Vestibule is not included in external nasal examination.
The point to see in the external examination is external appearance of the nose, sinus tenderness, and nasal patency.
Move. Okay, move.
On anterior rhinoscopic examination without speculum, vestibular hairs were seen, no furuncle or discharge, no erythema. In the right nasal cavity, pinkish, fleshy, polypoidal mass was seen, no ulceration or bleeding points were seen.
1 minute, go back. Vishnu, go back. You said it's fleshy and then you are saying it is polypoidal.
That I was also not convinced with this.
Fleshy polypoidal.
Yes. What is the definition of polyp?
Polyp is an epithelial, inflammatory, edematous, pediculated mucosa.
No, polyp is not inflammatory. Polyp is submucosal edema, is the simplest definition. It is a collection of, it's an edema which is submucosal. That is why it is lifted, the base is lifted, it looks pale, and it has less vascularity and less sensitivity. Because there is a collection submucosally. Okay, that is a polyp. Now, when you say polyp, it has to be pale. And on the one end, you are saying polypoidal, and other end, you are saying fleshy. And if you say fleshy, it is vascular. Okay, so that means that there is no collection submucosally, but it is some growth which has a higher hypervascularity and giving color as red. So both cannot go hand in hand. So either you have to convince us it is a fleshy mass or it is a polypoidal mass. What do you think?
Fleshy mass.
Fleshy mass. Okay, so it cannot be polypoidal then. Okay, it can be multiple, it can be single. That is different criteria. Okay, but it cannot be polypoidal. So okay, we accept your version. It's a fleshy mass. Go ahead.
Anterior rhinoscopy with speculum.
How does the look like? On inspection, also tell the finding of this fleshy mass. Was it single or
surface,
multiple?
Single swelling.
Extent.
Extending completely over the nasal cavity.
Completely means you are not able to see the inferior turbinate.
So inferior turbinate not visual and middle turbinate were not visualized.
Okay, so you have to categorically say that it was filling the whole nasal cavity, even inferior turbinate was not visualized.
But in the diagram, they are showing inferior and the middle turbinate.
Yes, he has drawn there.
That diagram means कहाँ होने चाहिए?
Nasal patency test, cold spatula test.
Hold on. Just see, you said that there was history of active bleeding, 5 to 6 episodes a month. Okay?
Yes,
so you have to further comment, was there any discharge? Was there any bleeding, active bleeding? Was there any clots? So you have to conclude everything that way. Because
you have a probing test was there? You have written the probing?
The probing here on.
Go back to the probing, what finding you have written?
He says that there was no bleeding on touch.
Viability, mucosa intact, or were you able to where the probe was getting stuck up, Where did you try to find out the attachment?
So the probe could be passed all around except laterally. So the mass is probably arising from the lateral wall.
So did it bleed on touch? What is the consistency?
It was soft in consistency. The mass didn't bleed on touch.
Mucosa is intact.
Yes, sir.
And smooth surface, no finger-like or any irregularity.
No irregularity seen.
Okay, go ahead.
Nasal PHC test. On cold spatula test, there was reduced fogging on the right side compared to the left. The Cotter test was negative on the right side.
Okay, do we do Cotter's test in these cases with nasal mask?
So usually, in case of elevated nasal septum, we will do Cotter's test.
Cottle test in a mass case or in a rhinoplasty or nasal obstruction in rhinoplasty case?
So in case of before doing the rhinoplasty, we will be checking for.
Is this patient a case of rhinoplasty?
No, sir.
Then?
See, if you are doing a Cottle test, which physiological area and anatomical area you are assessing?
Sir, we are assessing the patency of the internal nasal valve.
So what is internal nasal wall? Where is it located?
Sir, it is bounded laterally by the upper lateral cartilage and medially by the septum.
Okay, so you are, when it is narrowed, you try to pull that area and see the patency. Here you are not even able to see that anatomy, is all blocked. So what we want you to understand is what is the relevance of doing this Cottle test? It is not required. Okay, so you should know the relevance of the test also. Why it is done in what area?
Sir, it is come as positive in case of deviated nasal septum if the deviation lies at the level of the nasal valve area. Then it can come false positive or false negative results can also come. Like in case of strictures.
No, we are not asking Cottle test. We want you to understand.
And what is the relevance of Cottle test here in this case of nasal obstruction, where the cause is a mass, not a collapse of the ala or upper border of the ala. Go ahead.
Posterior rhinoscopy. The posterior end of septum is seen. Pink fleshy mass was seen in the nasopharyngeal region on right side, not completely filling it. The upper end of right choana was free, and the left side no abnormality was detected.
Okay. One basic question: which size of posterior rhinoscopy mirror you have used in this patient?
Sir, the largest size.
And
which size?
Large size.
What is the name of posterior rhinoscopy mirror?
Sir, Sinclair Thompson.
What is it available only one size, or you have different sizes of posterior rhinoscopy mirror?
So we have multiple sizes. So they range from 8 to 15 millimeters, sir. So usually 10 millimeter.
Is it numbered like 8 to 15 millimeter, or it is 1 to 3, 4?
Numbered 1 to 3, 4 size, sir. So size 3 is usually adequate, sir.
Okay. So I think posterior rhinoscopy these days residents are doing very less. That's why I'm asking this.
How did you do the posterior rhinoscopy? Just tell the steps.
Initially, we will heat the mirror part of the so that fogging will be avoided. And
what will you do? Whenever you're explaining any procedure that is to be done in a patient, how do you start about it?
Sir, we will ask the consent of the patient. We will explain the procedure to the patient. The patient will be in sitting position. We will tell the patient to breathe through the nose and open the mouth so that the palate will be bulged upwards, and we can observe the posterior part pretty well. And the mirror part of the speculum is
negotiating the mirror. What else would you like to place in?
Sir, tongue depressor also we will be keeping inside the oral cavity, and in the patient, so that the patient won't be having much gag reflex. We'll have to we should not touch the posterior pharyngeal wall, and we have to bring the mirror upwards.
And what are the structures seen on the posterior endoscopy?
So the posterior end of the septum is seen.
How does it look like?
Posterior end of septum is seen.
Have you drawn the diagram of your?
You should have drawn the diagram.
Posterior endoscopy finding.
How does the posterior end of the nasal septum look like on posterior endoscopy?
In fact, what is being asked is what are the structures that you can see in a normal posterior pharyngoscopy?
Sir, on posterior rhinoscopy, sir, we can see the posterior end of the septum, the posterior ends of the middle turbinate and the inferior turbinate. And,
inferior turbinate. क्या बोल रहा है भाई?
Sir, superior
turbinate, sir. So the roof of the nasopharynx and the station tube openings.
And the most important structure you not yet said. You see the posterior nares or coena.
Sir, posterior coena, sir.
That is the first structure you are looking where you see everything going into it. You see through that only. Correct. Okay, go ahead.
Paranasal sinus.
All the three turbinates are seen. You see the doctor short opening of ischium tube. If there is any mass or adenoid can be seen if the child allows you, and posterior end of the septum looks like a ridge you are seeing from the posterior end on appearance from the backside, and the fossa of Rosenmuller. These are the structures which are seen on posterior endoscopy. Go ahead.
And please practice the diagram, normal diagram of posterior endoscopy.
वैसे, sorry for interruption, I am just asking why nowadays the students have stopped doing posterior endoscopy routinely?
Because nasal endoscopy is there,
yes.
Sir, they'll take the patient to the chamber where the endoscopy is available.
Endoscopy. और practice में उन्होंने endoscopy करेंगे, so that charges are there. चलो continue.
Paranasal sinus examination. On inspection, right lower lid was found edematous and congested. On palpation of paranasal sinuses, right maxillary sinus tenderness was present. Rest of the sinuses, no tenderness was present.
What is the most specific site to look for this maxillary sinus tenderness?
Sir, above the canine fossa, we will be applying pressure over the anterior wall.
Okay, so in this case, it was specific tenderness of maxillary sinus, or it was a tender swelling?
So probably
it may be inflammatory swelling of the soft tissue. It may be inflammation of the bone. That is osteitis. So you want to make us understand it is the tender swelling or tender maxilla.
Sir, tender swelling.
Okay, fine. Go ahead.
Okay, when Vishnu, one thing more. Which lid edema you said? Lower lid.
Lower eyelid.
If it had been an upper lid, what was your inference? What may be your inference? Or if it is both lids, then what is your inference?
Sir, probably the swelling has crossed the midline. If there both the lower lids, bilateral lower lids are edematous.
Not bilateral lower lids. If it had been a lower lid only, or if it had been a both upper and lower lid, or only upper lid.
Sir, probably there might be orbital invasion by the tumor.
I think you didn't get it. My thing was that if the patient is having a secondary sinusitis because of a mass obstruction, then upper lid involvement suggests frontal sinusitis. Both upper and lower may suggest ethmoid sinusitis. Okay. Similarly, maybe here it is because of the mass, not exactly because of sinusitis. Okay, go ahead.
Olfactory test, there was reduced sensation of smell on the right side. On the left side, there was normal sensation of smell.
How did you test for smell?
Olfaction?
Sir, we will be taking with us 2 test tubes. One will be keeping coffee powder, or and on the other any other like lemon or something, lemon, and we'll be asking the patient.
No.
Lemon? Are you doing taste, or lemon is for taste?
Sir, any other ordering substance which.
What? Be specific. You are doing the examination. It's a MS exam.
Sir, any other ordering substance?
Sir, we can take coffee powder, dissolve it in water, and then ask the patient to smell it. Or sir, we can use any perfume which the patient can smell. Or sir, in Indian scenario, if we can use a clove, sir, that also can patient smell, sir. And
Perfumes are not allowed. You can bring any exotic perfume and ask the patient to recognize that. That is difficult.
So there is
something which is very much handy and available in the ward.
Yes. What are the basic 3 elements are available?
Available in the ward. You don't have to go for all this coffee and all that. Something which is available in the ward, and every common person knows the smell of that.
Dettol solution.
Dettol, something more, much more, say, pungent in smell. Spirit. Okay, that is always available. You simply ask anyone; they will tell this is spirit.
Even in OPD it is available.
Yeah, that is something always there. Okay. Okay. Go ahead.
Oral cavity and oropharynx examination. The mouth opening was adequate. Orodental hygiene was poor. Teeth were stained. The third molar was absent on the right upper jaw. No bulge seen over the palate. Tongue and gingivobuccal sulcus were normal. Bilateral tonsil, uvula, and anterior pillar were normal. Base of tongue normal. Posterior pharyngeal wall was clear.
What about the anterolateral wall of the maxilla, where you must be interested in this, since there is a swelling on the maxilla, anterior part, superior part, or below the orbit there is a swelling. So are you interested in lower part? Did you palpate the upper gingival sulcus?
Sir, it was not obliterated, the upper gingivobuccal sulcus.
What is ping pong sign seen in which condition?
Is it on inspection or palpation?
अरे वो टेनिस बॉल, पिंग पोंग कुछ ऐसा होता है ना? ये संजय?
Sorry, sir. Ping pong.
अरे nasolabial cyst हो, कुछ तो हो रहा हो, thinning of the anterolateral wall होती है, तो उसको दबा के देखते हैं.
Okay, sir.
Did you said all teeth are normal?
Sir, teeth were stained on the upper jaw. Right, third molar was absent.
Did he undergo any extraction because of the pain in the tooth?
No history of any tooth extraction.
Or any loosening of teeth was seen? Did you notice?
No loose teeth were seen.
Chalo, go ahead.
Ophthalmological examination. There was no proptosis. Right lower lid was congested. There was no congestion of conjunctiva. Vision, finger counting at 6 meters on both sides. Ear, right tympanic membrane, grade 1 retraction was present. Left side normal. Breast, no abnormality detected. Neck, no palpable lymphadenopathy. Cranial nerve examination. On the first cranial nerve, there was reduced olfaction on the right side and normal on left side. Rest of the cranial are normal. The probable diagnosis include sinonasal malignancy or an inverted papilloma, antrocranial polyp, or fungal rhinosinusitis.
Okay, my question starts here. Get back here. Why are you saying sinonasal? Why not nasosinal malignancy? What do you think with your history? It is a sinonasal malignancy or nasosinal malignancy? Can we be say in a condition to give a comment on this? It's a
The
nasal malignancy
sinon,
going to the sinus malignancy coming to the nose. What do you think?
sir,
Sinus.
it
Sinus.
is likely a sinus malignancy which has gone into the nose, sir.
Okay, why you say so? See, the medial wall is shared. Lateral wall of nose is the medial wall of maxilla. So
Yes, sir.
it is
Common boundary.
technically
Sir, through
very difficult to convert. If you think, do you think that because the primary nasal malignancies are slightly different, there is a different category of pathological conditions? If you call primary measly sinus malignancy, okay. Out of all the paranasal sinuses, which sinus has the highest incidence of malignancy?
maxillary sinus.
What percentage of incidence maxillary carcinomas
Sir,
among all the sinuses?
50 to 60%.
50 to 60. 70 men. Only 20% are ethmoid and 1% is.
Yes, because which text you are referring to when you are saying 50 to 60%? Which book, which article you are referring to?
Refer or quote the standard books, not something undergraduate level.
Which book you are referring to when you are saying 50 to 60%? How many carcinoma maxilla you have seen in your tenure of 3 years? Dr. Sanjay?
Sir, I've seen. So in my first year, I saw.
He's not third year, he's second year. He's year two.
Okay. So how many have you seen till now?
Sir, I've seen 2 cases, sir.
2 cases. How many you have seen ethmoid, frontal?
No, sir.
No. So they have some practical inclination also. It is 70 to 80% is maxillary carcinoma. Okay. So it's so high incidence. Okay. Go ahead.
Okay, Vishnu, go back please to your differentials, and please tell me what are the points in favor and points in disfavor depending on all these differentials you have kept in mind.
Sir, the patient is an elderly male, 60-year-old male, and the occupation is the patient is a manual laborer working in the textile industry, and the inspectory as well as palpatory findings are suggestive of malignancy, like the patient, the swelling is hard in consistency, not mobile.
Just a minute, Sanjay. What you need to bring out is just salient features. 1, 2, 3 are the things in favor and what is against. You're not to summarize the case. Okay. Short duration of onset. Okay. Yes, epistaxis, cheek swelling. These are the points you have to mention.
And 0 down to 1 or 2 maximum. Why you are considering fungal rhinosinusitis? Any points in favor of fungal?
Sir, some of the inspectory findings, like lower lid, like the cheek swelling reaching till the lower lid and nasal mass, one of the diagnoses can be in an elderly male can be fungal rhinosinusitis.
Which type of fungal rhinosinusitis may present this like this?
Mucormycosis.
Okay, good. Points in favor of antrocranial polyp?
The probe could be passed all around except laterally. It is a feature of antrocranial polyp.
What is the classical feature of antrocranial polyp?
Pale.
It is a polypoidal mass. Mostly goes backwards. In the later stage, it comes forward. So what I mean to say is very unlikely. A fleshy mass, you have already said. So enterocornal polyp is highly unlikely. Okay, which bleeds. Most of the time, an enterocornal polyp will not have a bleed. Okay, unless it's come too large. But I would say it should be still lower down, not in the third place.
Should be the last one.
Even fungal rhinosinusitis should be above enteroconal. What Professor Singh is saying is absolutely right. That it can be invasive fungal rhinosinusitis. It can be. So still we have to prove it. Okay, because underlying a polyp, there can be. Yeah. So enteroconal polyp should be the last reading. Most unlikely.
And in fungal rhinosinusitis, the point, the fungus starts in the where? What is the thing seen in the nose?
So there will be crusting, blackish nasal crust will be seen inside the nasal cavity.
It has gone to that extent that it has caused swelling on the anterolateral part of the maxilla. Will the nose remain same or normal or with the fleshy mass? There should be some changes there also.
So they will be pinched up. The nose will be pinched upwards.
Okay, go ahead. Next slide.
What is the point in favor and against inverted papilloma?
There will be multiple episodes of bleeding in case of inverted papilloma.
That can lead in hypertension also. So what is the look of this? What is the point in favor by look when you examine the anterior rhinoscopy?
There will be multiple projections. Finger-like projections will be present.
See, before going to examination, whenever you talk about any pathology, you start the symptomatology with the age, because in ENT you start making diagnosis age related also. So what is the spectrum of age in which usually you have inverted papilloma? It's more common among males, more common among females.
Females.
What is the specific age? So you start your diagnosis with the age, then you come to the etiological exposure, professional, then the symptomatology, then your finding. Your diagnosis goes in the same sequence. So is the age favoring inverted papilloma, which is the usual age?
20 to 40 years.
No. What's the age of your patient?
60 years.
So the age is not going in favor. Okay. Then next comes the symptomatology, what you are trying to say now. Then comes the symptoms of the patient. So you said that nasal bleed. Sir is saying nasal bleed can be multiple nasal bleed episodes in hypertensive patient also. Is hypertensive bleed usually unilateral or bilateral?
So bilateral.
Is hypertensive bleed associated with nasal obstruction?
No.
Is hypertensive bleed associated with facial swelling?
No.
So you have to rule out things like that. Okay? Go ahead. Go ahead.
So what are the points in favor? So what is your tentative diagnosis? And then you...
One thing more, enteroconal polyp जो इन्होंने अपना रखा क्लिनिक उसमें डायग्नोसिस में, उसमें मेरे को तो कोई पॉइंट नहीं दिख रहा इन द फेवर ऑफ enteroconal polyp. Any point you can give me in the favor of enteroconal polyp? Any of the finding?
ये सर केवल एक पॉइंट फेवर में है सर. डिफरेंशियल डायग्नोसिस की लिस्ट लंबी करनी है.
हाँ, लिस्ट लंबी.
ये पॉइंट फेवर में है बस.
चलो, जैसे कि डॉक्टर वाश ने कह रहे थे ना, एज ना सिम्टम्स, कोई ऐसा नहीं है.
चलो आगे चलो, क्या करोगे अभी? तुम्हारा क्या डायग्नोसिस है, टेंटेटिव डायग्नोसिस?
Sir, probably sinonasal malignancy. Sir, I'll go with radiological investigations, and then I would like to do a biopsy also from the lesion.
Dr. Sahib, I have a specific question here. What is more important, a tissue diagnosis or radiology? Which is more important right now for the patient?
So radiological.
Radiological is more important than pathological. Are you sure?
Pathological also, some variants are highly aggressive tumors.
No. So my question is very specific. Yeah, I would like to, if you want to say your management part, that how will you work up the case, you like to first take a biopsy or you'll first do a radiological evaluation. What will be your preference? First,
first we
tissue
can.
diagnosis or radiological workup?
So radiological workup should come first, and then we can go to tissues diagnosis, sir.
Any specific reason to say that?
Sir, while taking a biopsy, sir, we might inadvertently change the normal anatomy, sir. So
see a mass which is falling into nose, a mass which is falling into nose. What anatomy you are going to take? You are just going to take a biopsy from the tissue which is falling into the nose nasal cavity. You're not going to take a biopsy from. You are not going to open the maxilla and take the biopsy. You have to take the biopsy from the nasal mass which is falling down. You're not able to see inferior terminate. It is huge mass. So,
if we know the extent of
what they are being taught is that in case take the biopsy from the tongue or that upstaging can be there. So that is what they are following. But here you have to see from where you are taking the biopsy. So in this biopsy can be taken, or you can say, sir, CT करा के biopsy ले लेंगे. So you can say, okay, it's a one time diagnosis. CT कराना है तुमने या और कुछ कराना है, कुछ एंजियोग्राफी करानी है कि तुमको वो ऑफ स्टेज करना टाइम लगेगा.
See what
tissue edema post biopsy.
What I want you to understand is that tissue diagnosis is to decide the treatment plan. Radiology is to decide the extent of treatment. Okay, so you have to both are important when you are planning the management of the case. But you should, in this case particularly, you should have a tissue diagnosis. It's a 3 month history, aggressive tumor. It is already going into the orbit or going into the maxilla. So you have to have radiology also. But tissue diagnosis in this case will be take a biopsy and then go for radiology in this case. Because
also they can justify by this after biopsy patient may require a pack for some time, and radiology will unnecessarily get delayed.
Okay, agreed. So
but it has to come from his mouth that what he wants first.
Yeah. That's what I'm asking. See, but the point is, in a institute like where he is right now working, both can be done and they can have early reports, because in such cases can be done. I agree.
So whatever you say, you justify. If you want to take radiology in one go, you have a paranasal sinus, and then we'll take the biopsy.
The little more point to be added to this is that why I would prefer tissue diagnosis is because it's going to take time. It's coming in the nose. It is very well seen in anterior rhinoscopy. So tissue diagnosis, it takes 7 to 10 days. And the tissue diagnosis is basically going to plan your management. And CT scan. Exactly. So that dictates.
Yeah, in my view also, if I like to take a tissue diagnosis for tissue biopsy, because it will take some time to have the pathological variant of the tumor. And in the meantime, we can have the radiology, because radiology will tell us what extent of surgical intervention is required.
Just before surgery, we can go for it.
Because we have to have it, the latest radiological evaluation before surgery.
Yeah, definitely.
Yeah, that's my view. Okay. And which radiological investigation are you going to write for this patient?
Sir, CT, nose and penis, sir. Sir, axial, coronal and sagittal cuts.
What about orbit? Because there is an invasion in the orbit also. And you did not mention the examination of the eye in this case particularly. You just mentioned about the lid swelling.
Movements, eye movements.
You have to give us a comment about the examination of eye also in this case. Okay? Okay, go ahead.
So just enumerate various investigation you like to do. You said biopsy is one, other investigations?
So we would like to start with routine blood investigation, sir. complete blood count, and sir,
Okay,
coagulation
routine
studies.
blood count for anesthesia or from further this thing. What
sir.
else?
Then, sir, we can plan the patient for MRI also, sir, if that's needed. If, sir, we want to
What is the
look
role
for.
of MRI in this case?
Sir, MRI is primarily used for in cases of complications, sir. If the tumor is extending into the cranium, or if there is any intraorbital extension, then MRIs are to be done, and they give better delineation of the soft tissues, and the tumor boundaries can be exactly, sir, we can come to know about it.
What else?
Sir, angiography can also be done to rule out any vascular lesions.
What?
Or any tumors like hemangiopericytoma having vascular content in it.
See, if you say hemangiopericytoma, I'll ask in this case, what type of CT finding? It's a vascular tumor. There has been bleeding. It's aggressively invasive tumor as per the history. So what type of radiological picture you are anticipating in a vascular tumor on CT scan?
Sir, flow voids.
Okay, good. Flow voids. And flow void
intensely enhancing lesion, sir.
Correct. Contrast enhancing lesion. Good.
And so the lesion would be locally aggressive, and it would involve the surrounding structures, sir, with bone infiltration surrounding bone erosions.
There will be evidence of bone erosions.
Bone erosions.
Okay. So this is what you are anticipating in your radiological finding. So what is the differential diagnosis? If you have a picture indicating a vascular mass on radiology. Differential diagnosis.
Sir, any hemangioma?
Hemangiomas are not so invasive, aggressive. Okay.
Hemangiopericytoma?
Hemangiopericytoma.
Correct. Hemangiopericytoma.
Granulomatous conditions?
Okay. Go ahead. Because see, it's a long list. Read about. There are 10-15 conditions which can have as simple as venous granulomatosis, which was earlier, now it is renamed. So it can also have the same picture. Okay, and even mucormycosis can have this type of picture. Okay, go ahead. Pathology हो गई, फिर क्या करोगे? Biopsy हो गई. What next?
We'll plan for surgery for this patient.
Do you have the radiology of this picture of this patient?
Yes, sir.
You have the CT scan?
Yes, sir. Actually, there was bone erosion over the posterior wall was present.
फिल्म है आपके पास? फिल्म है उसकी? प्लेट?
सीटी की पिक्चर दिखाओ ना यार.
शेयर कर सकते हो आप?
Yes, sir.
Okay, good. हाँ बताओ.
The CT goes totally against what you have presented.
Where is the fleshy mass? In the coronal cuts.
Fleshy mass coming into you said the fleshy mass coming into the anterior rhinoscopy near the vestibule.
During anterior rhinoscopy, there is no mass visible. There is a mass in the posterior corner on the left side and right side majorly sinusitis.
Yes. This is more into nasopharynx than the posterior part of nose.
So you didn't see the mass on the posterior rhinoscopy. This mass should have been seen.
Yes.
I think this CT is not on the same patient. Because
These are the same patient or different patient? You showed that there is a swelling, redness, and this.
There is no soft tissue swelling also on this.
On the cheek wall, yes, sir. Introlateral. No.
Exam section does not show any soft tissue swelling in this.
What I would say is this CT does not corroborate with your clinical and finding. So what I would say is, what is your plan? How will you go ahead planning? Suppose you have got a CT done. What is going to dictate how you go about the management of this case?
Suppose the biopsy comes as squamous cell carcinoma, and
Yes.
then you go ahead.
Go ahead.
Biopsy is moderately differentiated squamous cell carcinoma. तुमने गलती से दूसरे पेशेंट का लगा दिया सीटी या यही है? I think there is some confusion. This
ये नहीं है, मेरे ख्याल है दूसरे पेशेंट का ही है.
This CT doesn't belong to the clinical picture which you are shown.
इसमें तो नेज़ोफेरिंक्स में अच्छा खासा मांस पड़ा हुआ है.
ये तो एंजियोफाइब्रोमा जैसा लग रहा है सर.
हाँ, इसमें बड़ा मांस पड़ा हुआ है.
एंजियो और सीटी एंजियो रखा हो तो वो दे. चलो, the biopsy is moderately differentiated squamous cell carcinoma.
What next?
Sir, I will go for case the tumor and go for surgical or surgical management.
What will be your approach to the tumor?
Sir, open approach.
So how will you stage? Before we stage, then only we'll go for the approach. Sorry to interrupt in between.
No, sir, it's very true, very true. Correct, sir.
No. See, what Professor Singh sir is asking, you said open approach, okay? Why you were so confident in saying open approach? Why didn't you say okay, we'll do endoscopy? Why you straight away said I'll go open approach? You are right. Endoscopy is ruled out in this case. Why? Straight away. There is a soft tissue involvement. Anterolateral wall is breached.
The tumors are extending too much laterally, sir. They cannot be accessed endoscopically.
Correct. So you are absolutely right. And if I ask you the staging of this tumor with the finding, and if we think that radiological finding were as your findings are, what is the stage of your the CM maxilla?
Sir, posterior bony wall was eroded, so it comes under T3.
So T3, you have examined the neck also. It has to be TNM staging, right?
Sir, N0, T3, N0, M0.
Okay. So clinically, you say it is T3.
N0, M0.
What are the different types of TNM staging you have? What is clinical? Other is? Does your radiologist also give a staging? Your pathologist also gives a staging? Radiological staging भी होती है.
Classification, what is on Grange line, all those things you have to tell.
Yes, sir. Sir, on Grange line. So on Grange line is the line connecting the medial canthus to the angle of mandible, sir, and it is primarily.
I will, sir.
Time खत्म हो रहा है रवि.
Sir, I will request to wind off in next 10 minutes, sir.
Okay. Done.
So there is only one line, or there are?
So there are two lines. One is the on-Grange line. The other is the mid-pupillary line, sir, and it basically helps us to tell the prognosis of the patient. Sir,
Sanjay,
so
that is also given by on-Grange, but the one from medial canthus to angle of mandible, that is more popular. That has been quoted in the textbook. So the two lines are described in Thale Pange tumors of head and neck. So vertical line, so it divides into 4 quadrants. So
yes, sir.
what is the relevance of this oblique line?
Sir, we divide the region into 4 quadrants, sir. There is posterior superior and the anterior inferior, and then both of them are divided medial and lateral. So the tumors in the in the upper medial region have the worst prognosis, and the tumors which are in the posterior anterior inferior quadrant on the medial side have the best prognosis.
What is lateral?
Okay, Vishnu, you said N0, M0. How did you arrive at that staging? Which
Sir,
all nodes you ruled out?
Sir, first we had to calculate the submandibular lymph nodes.
Which is the first equivalent lymph node for malignancy maxilla?
Retro.
Sanjay?
I didn't get the question, sir.
Which is the first aclon lymph node? Sir, Dr.
So
Sahib is asking.
submandibular, jugular-digastric.
Okay, and
the submandibular and jugular-digastric lymph nodes are the most commonly involved, sir.
They are involved, but first aclon कौन सा होता है?
Retropharyngeal.
Okay, and for metastasis, what all tests you had asked to arrive at M0?
So for metastasis, we would like to order a CECT base of skull to diaphragm, sir, to look for metastasis in lungs, liver, or sir, any abdominal organ.
Up till diaphragm, you are not going to see the liver. You said lung, liver.
Oh.
Liver is below diaphragm.
Below.
Okay.
Yes, sir.
Anatomically, you are wrong. That liver तो नीचे चला गया. कोई बात नहीं. चलो.
And sir, PET CT can also be ordered to look for.
Why you want to do PET in this case?
Sir, in case distant metastasis is suspected.
कहाँ पे?
Then.
Which is the most common part?
Sir,
any node in the neck? भैया पहले तो लोकली आएगा ना तभी डिस्टेंट जाएगा.
When your examiners keep asking you question, does not mean you dig your own grave. Start off with PET-CT in the very first go. Okay.
चलो. So what is your plan now? You have staged the tumor.
Sir, I will go with surgery.
What surgery?
Name the surgery.
Sir, with medial mastectomy.
There is a soft tissue involvement. Anterolateral wall seems to be breached.
And posterolateral wall also here, sir.
Posterolateral wall is also breached. So why are you only confining to medial maxillectomy?
Sir, total maxillectomy.
See, you only said medial maxillectomy. Now we are correcting you. Okay, total maxillectomy. Now the skin is also involved. So are you going to take skin also in resection?
Will it be total maxillectomy or more than total maxillectomy? Because skin is also getting in here.
No, you will say more than total. Certainly.
So in a malignancy, indurated skin, that is involved, as good as involved.
Sir, why your finger is coming on the screen?
What is beyond total maxillectomy?
So total is also known as
pure total.
Near total. You started with medial maxillectomy, then near total maxillectomy, then total maxillectomy, then beyond, because now we are telling that skin is also involved.
Extended total.
Extended maxillectomy.
Because if you are going to do the skin resection also, then your reconstruction plan has to be also discussed. Although time is not there, but you should be prepared with these questions.
And before you take up the patient, would you like to consult somebody else? There are some sister concerns.
Yes, sir. Sir, we would like to consult the plastic surgery department and the dental, dental department for obturator.
Ophthalmology also.
So take those consultation and then plan the patient accordingly.
If the orbit is involved, so with total maxillectomy, what surgical procedure is done in the orbit?
Sir,
if orbit is also invaded.
Sir, the patient might also require orbital exenteration.
Orbital?
Exenteration.
Exenteration. So
what will be the indication for that?
Yeah.
Sir, involvement of the structures inside the orbit.
Which structures?
The bony invasion of the orbit.
So when extraocular muscles and or optic nerve is also involved, and we cannot salvage the eye.
Technically, orbit is a bony socket. Orbit is a bony socket. And then the contents of orbit are all what we are talking about. Muscles and all that, they are the contents of orbit. Orbit is a bony socket only. Okay? So you have to be very specific what Dr. Manish is trying to make you understand.
Periosteal involvement, periosteum of the orbit.
Okay. If there is a breach in the periosteum or invasion of the soft tissue like fat, etc., then only you have to go for it. कितना time है रवि? Yes, go ahead. What kind of incision? How will you proceed? Under general anesthesia or local anesthesia?
Under general anesthesia. With,
and what incision?
Sir, with Weber
Ferguson.
And if you have to do the orbital exentration, then how it is modified?
So supraciliary extension will be done.
You want to preserve the eyelids or you want to take away?
Preserve the eyelids.
You said involved lower eyelid.
Sir, for that, Diefenbach's modification will be done.
What is that?
Sir, we'll go to 1 centimeter lateral to the lateral canthus of the eye, the incision, and then it will be extended 3 millimeter inferior to the lower eyelid, and then extend to the midway between the nasal bridge and the medial canthus of the eye.
No.
So this is the classical Weber-Ferguson incision, sir. When we want to gain access to the more lateral sites, we would extend the incision laterally, sir.
See, that is to obliterate this thing, exentrate
So
the
we would give
eyeball.
subconjunctival,
you have to do the conjunctiva.
so subconjunctival incision
is to be given. You preserve the eyelid, that is subconjunctival, and if you want to obliterate, include the both the eyelids in the incision, you go supraciliary and below this, then whole of the eyeball will come out. When you have extension laterally going towards zygoma, if it is the tumor is not confined to the maxilla, if it is going beyond the maxilla towards involving this zygomatic process, and there you extend the laterally, that lateral extension what you are talking. Even sometime you have to go beyond that also. So what are the next question which is asked in the exam? Either you will be given asked on the skull or this here in the specimen. What are the various osteotomies you do in the maxilla?
Sir, we'll go if different cuts are there for maxillectomy.
Cuts are there.
Sir, 5 cuts are there.
5 cuts. So the sequence remains the same in all the cases, or you have to modify as per the tumor extension?
Sir, it has to be modified as per the case, sir. It has to be modified.
Okay. So, which
depending
is
on
the
the
standard first
extension.
cut?
Sir, vertically it passes through the anterior aspect of the medial wall of the maxillary sinus, first cut. Second cut, it goes to the inferior aspect of the medial wall of maxillary sinus. The third cut, it passes through the medial wall of orbit inferior to the frontoethmoid suture. In the fourth cut, it passes through the orbital floor. And in the fifth cut, it will pass through the posterior aspect of the maxillary sinus at the pterygomaxillary fissure.
You just enumerate what are the sequence. What did you say? First cut is? First osteotomy is?
So vertically at the anterior aspect of the medial wall of the maxillary sinus.
And you separate the frontoethmoid process here first. Second,
horizontal cut at the inferior aspect of the medial wall of maxillary sinus.
What you are talking about, man?
You release the maxilla first medially, then superiorly, then laterally, then inferiorly, then posteriorly.
Sir, laterally.
So you just tell the cut in the same sequence that you are removing the maxilla.
Sir, laterally zygoma has to be cut.
Yes, that's what I'm saying. So your cuts have to be sequential for that.
What you will use for cutting the bone? What instrument you will use?
Sir, electric oscillating saw is there.
Okay. And why we should remain below the frontoethmoid suture line?
So otherwise there is risk of
anterior.
There is risk of CSF rhinorrhea.
Sir, we will encroach upon the anterior cranial fossa, sir, and it can lead to CSF leaks.
Okay.
And
which? Yes, sir.
What osteotome do you use to separate from the pterygoid plates?
It is a straight osteotome, curved osteotome.
A curved osteotome. So from the maxillary tuberosity and from the pterygoid plates, it has to be taken out, sir, to ensure en bloc resection of the maxilla.
And why there is a brisk bleeding while doing the posterior osteotomy?
Sir, descending palatine artery can be we can come across the artery and it can cause bleeding.
Okay, so you have removed the specimen. Okay, you have removed the specimen. In this case, suppose you have done an extended total maxillectomy. Okay, you have removed the skin along with the total maxilla. What next? In this patient, have you planned post-surgery radiation also in your patient?
Yes, sir. We'll need to give radiation also, sir.
So you have to take an opinion of the radiotherapist also before embarking on surgery.
Yes.
Okay, so that is also to be mentioned. So you created a defect, you took help of plastic surgeon, and you have somehow completed the surgery. Okay, what next? How are you going to follow this patient?
Sir, maxillary processes, the patient should undergo dental consultation, orthodontist for processes.
Orthodontist will make a palatal obturator, or he can make this maxillary processes also?
Obturator.
Obturator is basically for the palate. Obturator means that it operates the maxillary cavity and the palate. Okay.
Nasal cavity and oral cavity are separated.
Yeah.
Yes.
And it will be prepared by prosthodontist or orthodontist?
So the orthodontist.
अरे दांतों को सीधा करवाते हैं जो टेढ़े मेढ़े
प्रोस्थोडोंटिस्ट बनाएगा
प्रोस्थेसिस है तो
प्रोस्थेसिस है तुम तो डेंटल कॉलेज के पड़ोसी हो यार
Okay, after how many days of surgery you will schedule radiotherapy for the patient?
Sir, once all the incisions have healed, sir, then we can schedule for radiotherapy.
What is the normal duration?
3 to 4 weeks.
What is the normal duration? I'm just asking what you have been doing in your setup. That's all.
So about 3 to 4 weeks, sir, to allow complete wound healing. and then sir, patient can be taken up for radiotherapy.
Okay.
And the specific region.
When the patient has to undergo radiotherapy, what counseling has to be done that these complications can happen in your patient? In this case particularly, that you have to counsel the patient that these can be the problems which may happen if you are undergoing radiotherapy now.
So there can be skin necrosis, so like discoloration of the skin and necrosis, and sir also
Sir, osteoradionecrosis.
Sir, because eye is in the ocular complications can also be there, sir.
Yes.
The patient can
Because they have to radiate
affected
that
vision.
area. There can be fistula, there can be skin necrosis, there can be flap failure, because in this case you are going to put a flap. There can be flap failure post radiation. The vascularity of flap may be compromised.
Yes, sir.
So all this has to be explained to the patient.
Yes, sir.
As part of counseling. Okay? Okay.
Yes, sir.
Sir, I think, sir, we have almost one and a half hour of discussion, and this can go on and on and on. I mean, so because of the lack of time, I think we can stop here.
No, it was a wonderful exercise. At least our idea was to let them know what all can be asked, what all they should be reading around. It's not only that you are talking about ENT, you should read about all these things, the other types of flaps, what are the options or reconstruction. You should read all this about. Okay? So this was the idea.
Right, sir.
Okay,
Right, sir.
Good.
Okay.
Thank you, Dr. Ravi. Thank you for the invite.
Thank you.
It was
I must thank all
good to interact all the
Dr.
panelists.
Nukraj, Dr.
Thank you, Ravi.
Dr. Ravi Roy, Dr. Manish.
Sir, nice to see you after a long time.
Nice to see you also for a long time. Even Manish, after
yes, sir.
For a long time. Okay.
Thank you, sir. Thank you, sir.
All thanks to Dr. Ravi.
Yes, sir. Yes.
On this platform. Thank you,
Good,
Dr.
sir.
Ravi. Thanks a lot.
Very much, sir.
Thank you, Dr. Ravi.
I think I just will wait for 5 minutes. I think Praveen is going to join.
Dr. Rathore has already joined, sir.
Okay.
Hello.
Ravi, I will just.
Hello.
Thanks to everybody.
Hello, Rathore.
Hello. Good evening, sir. I have joined.
We can't see your video.
Video actually, I have started my mobile, so some video problem I am facing. But I have joined long time back.
You have sent me hello also.
Yes, very nice to see all the experts.
Ravi, I'd like to wish your final year candidate also best of luck, because it's not only we are asking him questions. He should not feel bad. He did excellent.
Yeah. Considering them a second year, they have
always there is a scope to improve. So we wish him all the best for his future career and exams. Okay.
I think, sir, after this discussion, they will feel more encouraged to read more.
They should feel
prepare
motivated.
more for the exam.
And he did well. He was good. But he can still be better. That was the idea. That's all.
There was a problem because of this COVID, this collection and this and all that happened because the patients were not there. So whatever.
I understand, sir.
That was.
We understand.
I understand, sir. I understand. Sure, sir.
So, Dr. Rathore, I would like you to please please present a vote of thanks to everyone. Dr. Rathore is there, sir?
Hello. Yes, please. Hello.
Yes, sir. We can hear you.
Ravi, we have had a lot of good points from the experts, and I think that students definitely will have. How many we have in the total at present?
Sir, total attendance for the update, if we take both the days, it is more than 650.
Oh, excellent.
Very good.
The delegates were 650.
Very good.
And we had almost 15 to 20 faculty at a time. The total faculty involvement was more than 40 faculty were involved all over India. So our attendance is more than 650, sir.
Very good. Very good.
More than what
Congratulations.
have in MMC.
Yes, sir. So the
Now I
online
think I
event
got
is
my
much more
video.
than the physical conference which we used to have. Last year we had almost 175 delegates, but online definitely people had convenience of joining from anywhere, and I am pleased to announce that we had delegates from Nigeria, Croatia,
Oh, that's very good.
from Dhaka,
Very good.
and
Congratulations.
from Nepal and Pakistan also, sir.
All right, congratulations.
So
Congratulations. Very good.
So next time,
Very appreciating.
next time you do take permission from Ministry of External Affairs.
No, no. If you were, you should have done it physically. But all it would have been physical conference.
I'm joking, sir.
Correct.
International level ho gaya. Good, great.
Yes, yes. It's very good. Very good. Very good. And this is 9th year we are conducting.
Yes, sir.
I think very good.
Sir, I mean, all thanks to Dr. Anupraj, because I remember in 2008 we had conducted first ENT update under his guidance, and he was the head of the department, and the legacy is continuing, and we
Very good. I'm thankful to Rathore and Ishwar. They have continued it. But they never stop it. Even Ravi, you should also not stop it.
No, sir, we'll continue. In fact, I was asking Ravi to do it just before exam, if possible.
Even if you see, even surgery people are doing since how many years?
Sir, they are doing for last 30 years.
Yes, we should also make it a always.
And we can have some scholar like laryngology or radiology.
Yes, yes,
or,
we can always.
stress. We can have smaller
Ravi, I will, yes,
specialty thing.
I think doing it once a year, because see, this COVID has given us an opportunity to understand this platform also well.
This is a very good platform, rather.
Yeah, so you can, I think sir is very right, Professor Singh, that you can have small topics
Yes.
and you can have panel discussions on Sundays or something, and where the students can be benefited. I think this will be a good initiative. That is, we can have that way. Okay.
Or we can have more of a case presentation, so that rather theory they can read and understand. That will give an additional all kind of exposure. Now we had only 3 cases. We have more of the parotid or the thyroid or oral cavity or larynx. Those kind of cases can also be taken up, so we can have a more cases, so that it is more practical
More
and
variety of cases.
practical
Definitely, definitely. Sir.
even osteology can be included or instruments, so that patient and this candidate can be exposed to what of kind. I was keeping mum so that the external can ask more questions as compared to me, because for my students I am always available to them.
सर एग्जामिनर भी जो है इसमें इंक्लूड किया कीजिए, मतलब माइल्ड मॉडरेट सीवियर कैटेगरी वाले.
That's a good one.
माइल्ड मॉडरेट सीवियर कैटेगरी वाले हो तो बच्चों को एक्सपोजर अच्छा मिलेगा.
सर हर कैटेगरी के एग्जामिनर्स भी होने चाहिए सर.
हाँ, वही होने चाहिए ना, माइल्ड मॉडरेट सीवियर कैटेगरी वाले.
तो
सारे हम लोग सारे माइल्ड वाले थे.
Sir, with permission of Dr. Rathore, can I suggest a vote of thanks, sir?
Yes, Ravi, go ahead.
So, my sincere thanks to all the faculty members from all over India who have joined. So, I mean, we had faculty from all the major institutes of India, especially from the northern India, and everybody has contributed very well. And I also thank all the delegates who have joined from all over the country and also from other neighboring countries. And my special thanks to Dr. Rathore for his constant encouragement and guidance that we are able to conduct this online program. And my sincere thanks to our moderators, Dr. Deepika, I can see here, Dr. Vasun, Dr. Hitendran, and Dr. Riaz, who have been attending this program continuously since last 2 days, and they have been moderating all the sessions. And last but not the least, I would like to thank the Sun Pharma, Mr. Naveen Kaul, Mr. Deepak Vora, Mr. Arvind, for their constant support in providing the online platform, as well as the audiovisual facility which they have provided us for this online program. So because of them only, we are able to conduct this, and we are able to connect with all the people. For the delegates, I have one announcement that we will be having the delegate certificates also, and they will be uploaded by your name and place. They will be uploaded on this website only, so you can download those certificates directly from the website, and it will be done in next 2 days.
Ravi, after they give the feedback.
And after they give the feedback, for us, the feedback is the most important thing, so that we can improve further. We give best of our resources and the facilities for your learning. So the feedback is very, very important, and I would request that you please fill the feedback form so that we can mail you or we can give you the certificates. Thank you very much. I can also see Dr. Bansal here. Thanks a lot, sir. Nice to see you. And Dr. Bansal has been also very sincerely attending whole of the conference. Thank you very much, sir.
Okay.
Okay. Bye bye. Thank you very much. Thank you very much. Ishwar, thank you very much. Thank you. Saurabh, bye.
Bye, sir. Bye, sir. Take care.
Bye bye, Taneja. Bye bye. Nice to see you all.